Good morning, everybody. My name is Jakub Chwiećko. I'm a pediatrician and former K.I.D.S Foundation medical director, as well as business creation lead for EIT Health, not anymore. But it's my pleasure today to greet you at the Pediatric Innovation Day, where we're going to have the whole day of experience with the medical innovation in pediatrics. So welcome everybody here together with us, but also people joining online. Just to make sure, people who are online have the cameras and microphones turned off, but you can actively participate by asking questions in the Q&A, which will be moderated as well. We have the local agenda and coffee on the side, so everybody who's going to be willing to have some coffee, please do. And to start with, we're going to identify ourselves with the badges. So you probably see that the badges have different colors. We have the badges of organizers, which are red, badges of speakers, which are purple. I actually don't have one. The wildcard startups, which are blue, and the last one, participants, which are yellow. We invite everyone to join our online community as well. You can find the QR code at the back of your badges. And for those people joining online, you have the QR code here, so please join our community and stay connected to us. Today's event is organized by many kids. There is I4Kids, I4Kids Europe, and it's hosted by K.I.D.S Foundation, which is Children's Hospital Innovation Club. This will be a full day of exciting events. We have almost 20 speakers and panelists, 7 wildcard finalists, and we will have one-to-one meetings, investors for startups, and workshop for kids. Let's give it up for all the people here in the room so they can feel we have started something incredible in Warsaw. Right here you have the partners of I4Kids Europe Consortium. There is a hospital, San Juan de Deu. There is a long name for the foundation of San Juan de Deu in Spanish, which I won't pronounce. Sorry for that, guys. We have the Inveniam. We have the K.I.D.S, which is a children's clinical university hospital in Riga. We have the regional Hovnestadt from Denmark. We have HUS, which is Helsinki University Hospital, and EIT Health Spain, as well as K.I.D.S Foundation. Of course, this event wouldn't be possible without the sponsors, which are Siemens Healthineers and PALI European Institute. The sponsoring partner is Publicis as well, which is not in my script, sorry for that. And of course, our honorary patronate of Children's Memorial Health Institute. Another patrons of the event, Institute of Mother and Child, University Children's Clinical Hospital named after Ludwig Zamenhof in Białystok, which graduate Amen. Institute of Healthcare Management, Łazarski University, Coalition AI in Health, and Polki in Medicine, which is female doctors in medicine. Today's event is also endorsed by Rynek Zdrowia and Rzeczpospolita as media patrons. And of course, this project is made possible thanks to the funding of European Union. Starting with our team today, we gather here to talk about when imagination meets healing. And to unlock this magical pediatric innovation together, we're going to open this session with Karolina Sielska-Bielska, the K.I.D.S Foundation president, Arnau Valls, esteemed coordinator of innovation, Sant Juan de Deu, Barcelona Children's Hospital, coordinator for I4Kids and director of I4Kids. Many names, welcome. and my former boss, Magda, Krakowiak, the Director of Business Creation in EIT Health. This is my microphone, and I don't know where is yours, because it should be here.
Thank you, Jakub, and welcome everyone. We are really excited to be here in this Pediatric Innovation Day. So good morning, and on behalf of I4Kids and Sant Joan de Déu Barcelona Children's Hospital, welcome to the third edition of the Pediatric Innovation Day, the first held outside Barcelona in a colder environment, let's say. First, I would like to thank K.I.D.S Foundation, and especially Paulina, Karolina, and all the team for the amazing work that you've been putting out and hosting today's event. Also, Michael, Jakub, and Dr. Magda for the hosting of yesterday and showing us the health innovation ecosystem in Poland. Also, Magda, Maria, and Celia for the co-host and organization of the big finale of the wildcard that we will have today. And let me say few words about I4Kids before starting. I4Kids was born in 2020 in Barcelona with the aim of tackling the lack of medical products on the market for maternity and infant care. In short, our mission is to foster and promote innovation in pediatrics and maternity field for a better health and well-being of the small ones and future societies. So in 3 years, the I4Kids have already accomplished a great deal, counting with 64 members, 30 associates, and more than 30 associate entities, 92 research groups, mentoring 22 projects to advance in their developments, thanks to the valorization and acceleration programs, and has promoted and provided 125,000 euros in grants to help this project advance. Also, we've trained 500 innovators in innovation specifically for pediatric and rare diseases. During these years, one of the 3 projects that we are more proud and we think that will have more impact are, first of all, the collaboration in the I4Kids Europe that we've just started this year to try to foster on the experiences and the expertise around European pediatric hospitals around Europe to help advance in bringing new products and new solutions for the diagnosis and treatment of the small ones. The second one is an initiative that we've been collaborating to create the first Pediatric Impact Fund in Europe together with Ship2B, and that today we will have the Managing Director, Marc, who will be presenting the results and how is the innovation and investment ecosystem nowadays in Europe. And third, and not least, to be partners of the EIT Health in this wildcard program focused in child health that has been really a great initiative and learnings and helping accelerate 16 projects and participants and 7 finalists. Really, I'm really looking forward for today's speeches in this big finale, and I hope the best for all the participants. Finally, the I4Kids Europe project and the I4Kids have lots of different entities and innovators that have participated and that are here together with the common aim to make child health and the child have a better future. I see all these initiatives as a cradle for pediatric innovation, leveraging this different knowledge and expertise with the purpose of innovating to ensure that each child have access to the best diagnosis and treatment, as we said. So again, thank you very much, and I hope that today it's going to be a great day for starting these innovation, new initiatives and these innovation collaborations. So I pass the word to Karolina from I4Kids Foundation.
Hello, thank you very much. This is a very big pleasure for me to welcome all of us to Pediatric Innovation Den in Warsaw. We are a foundation, Children's Hospital Innovations Club, and I will say something more about us. We have a mission. The more important thing for us is join the forces to create hospital of the future for children and for all of people who care about them. So we are competence volunteers, all of us. We are business leaders, we are parents, we are people full of passion to change this patient experience. We decided to support this transformation. We cooperate with over 50 hospitals and healthcare units of Poland right now. And most of our projects is connection with patient experience. I would like to say that it's, I would like to say it's very big thing for us to have all of us here in Warsaw. And I hope that today's meeting will be full of energy and inspiration. Just take care this time. Thank you.
Great. So let's see if we can handle the slides. No, the technology is getting ahead of us. Right. Good morning, everyone. And I would like to say, welcome to Warsaw. I know that Jakub already said it, but I mean, as a fellow Pole, I think it's not very often that we actually are present as EAT Health here, at least from the central perspective. So I'm really glad to see so many faces and people from across Europe actually joining this event, and we're very happy to be here as well. So of course, I would hope that most of you around the room know a little bit about our organization. So we are a public-private partnership that is essentially has been established by and is supported by the European Union in order to foster innovation in healthcare, because we have a lot of great pockets of innovation across Europe, but our mandate is essentially to connect them and to make our continent a little bit more competitive and essentially answering the massive challenge of healthcare that our population is facing. So not specifically in, so of course I could tell you we are present in 8 different regions, and I could tell you all about our projects and so on, but I wouldn't be able in 5 minutes to tell you much about that you cannot read or that we cannot follow up in a conversations later on during the day. So instead, I thought that I'm gonna reflect about what EAT Health is doing by drawing a metaphor between EAT Health's work and actually riding a bike. So could I have a show of hands of the people who know how to ride a bike? Good. It's almost everyone, or some people are attending to the emails. Right, so we know that the feeling of riding a bike seems very familiar, right? And if we think about how a bike is built, there is a back wheel that is sort of providing the let's say, the push. And then there's the front wheel that is sort of guiding the roads, and it is very important to have a balance between the two. So I would like to draw this metaphor to actually innovators and technology and essentially all the scientific discoveries and everything that is happening around healthcare as being, you know, the back wheel, right? And it is very important that this back wheel is not providing too much of a propellant to the front wheel, because then it's very easy to actually lose balance. So EAT Health as a framework is sort of connecting the two. So the front wheel being the needs-driven innovation, very much connecting to the patients, working with the healthcare systems and so on, who should be guiding this innovation process. But EAT Health is sitting somewhere in the middle, like you may say a chain, that is making sure that both stay connected and that we can move at speed, that we can keep the balance, and that we can essentially enjoy this exhilarating ride. So speaking of which, you know, some people may say, well, we are actually a training wheels, but I don't view our role as such. We do support innovations, we do support entrepreneurs, we do support the technology development, but we very much stay in touch with the healthcare systems, the healthcare providers, and so on. And that's why we're very happy to be here and actually collaborate with San Juan de Deu in this Wildcard Challenge and the Wildcard project, and of course beyond. So very much looking forward to the rest of the day. And yes, please enjoy. Thank you.
To tell you the truth, I think we are quite well with the time right now. So thank you guys for being in such a strict trigger. We are right on time. I hope the people in front of the cameras in the computers are gathering as well. Because right now we will have the first keynote speech of today's event. We will present the key findings of the European Pediatric Innovation Ecosystem research by Fe van den Broek from Inveniam Group.
Good morning, everyone. Picture a world where children's health flourishes through innovation. In our presentation today, we delve into unlocking the potential of pediatric progress. Beyond all the advancements, there are still many barriers to be overcome. We aim to unravel this intricate web of challenges that stifle progress in pediatric innovation, hoping to create a new network and a new spark that can propel us beyond these barriers for a healthier and brighter future for our youngest generation. There are 2.4 billion children worldwide, comprising 27% of the global population. This uniform population conceals diversity, stemming from age differences and the presence of over 7,000 rare pediatric diseases. In the face of such diversity, there's a crucial demand for pediatric-specific innovations capable of meeting the needs of each child. However, pediatric healthcare grapples with slow progress and limited innovation, attributed to several critical factors. Merely 9.4% of total funding supports pediatric research, and a mere 1.6% of overall venture capital in healthcare is focused on pediatric initiatives. Challenges further persist further down the line, with limited access to cutting-edge pediatric innovations affecting 22% of healthcare professionals, who say that they have access to the latest medical advancements. Further complexity arises from developmental challenges and the scarcity of a unified network amongst specialized children's hospitals. Compounding these issues is the fragmented pediatric landscape, which hampers collaboration amongst key stakeholders. This hinders the identification and leveraging of key opportunities. Such a disconnect obstructs the formation of effective initiatives, frameworks, and policies, leaving a large untapped reservoir of innovation, and especially in emerging and moderate innovation groups. So as we've already heard a little bit today, the i4Kids Europe initiative, funded by the European Commission, aims to foster synergies and bridge gaps between diverse pediatric stakeholders and territories. A pivotal initial phase of this was to understand deeply the different barriers and needs that all stakeholders face, both from the different types of innovation actors and also the types of innovation regions. And this is what our first action focused on. So our methodology was twofold. So we had spread a questionnaire we had it open for several months. We collected semi-quantitative data and draw insights from 148 responses, and we similarly conducted 25 stakeholder interviews. Using both Likert scale assessments and ranking questions, we systematically evaluated the importance of 8 distinct barriers. Following the European Innovation Scoreboard ranking, which is not pediatric specific but focused on innovation, we classified respondents into 4 innovation levels. Concurrently, respondents were classified into 7 diverse stakeholder groups, and this established a dual layer analysis. Our exploration then took us into the intricacies of 8 barriers, such as shown on the screen. So we have commercial and adoption, financial, regulatory reimbursement, cultural and incentive, human capital, and let's name them. So what were the results? So after we cleaned all the data, we were left with 148 good responses that paint a broad picture of the pediatric European innovation ecosystem. So as we see, we have quite a diverse mix amongst the innovation groups, which was quite essential for us to identify what barriers differed between these groups. Moreover, we were able to get responses from all important innovation actors, but with a primary focus on research institutions, healthcare institutions, and SMEs and startups. So what were the key findings? So zooming out onto the broader ecosystem view, a broad consensus emerged on the key barriers impeding pediatric innovation across various innovation levels. So the key barriers that came to light include financial barriers, regulatory and reimbursement barriers, commercial and adoption barriers, and human capital barriers. These common challenges stood out as main obstacles amongst all respondents, consistently identified as primary constraints to pediatric innovation across the entire European landscape. However, examining different innovation groups revealed distinct challenges, reflecting the different needs of local pediatric innovation landscapes. For instance, emerging innovators prioritize regulatory and reimbursement barriers, while higher innovation groups focus more on financial hurdles. Notably, lower-level innovators consider human capital barriers as a far more significant challenge compared to higher-level innovators. And at the same time, cultural and incentive barriers matter less to these emerging innovation groups in contrast to their higher innovator counterparts who rank them more highly. So let's try to understand a little bit where these differences come from. The number one constraint to pediatric innovation is the financial barrier. This is quite unsurprising, I think, for most people. So it was listed as the most important barrier for SMEs and startups, research institutions, and healthcare providers alike. Notably, its prominence varies, being more important for stronger innovators and becoming less important for weaker counterparts. In our interviews, 89% of respondents emphasized the difficulty in securing financing for early-stage pediatric projects, encompassing both public and private funding sources. Looking at the different levels of innovation, only emerging innovators did not list financial barriers as the most important barrier. We can also see a difference between the importance of the financial barrier and the type of stakeholder. So what we see is that commercially minded stakeholders from lower innovation countries place less importance on the financial barriers than those with higher innovation areas. And this is almost like a counterintuitive finding. The reverse was seen for research institutions. So this led us to hypothesize that perhaps it's the research institutions that are driving innovation still in these emerging and moderate ecosystems rather than, let's say, more the private side. During the interviews, it became clear that the challenge in accessing pediatric innovation funding is dual: a lack of awareness about available grants, and insufficient knowledge, experience, and support for successful applications. This is evidenced in quotes from emerging innovators stating that pediatric innovation is simply not recognized as a great need within our country. And this is showing an issue from the top down. However, there is also an issue on the skill set and capabilities, saying that they know that these grants exist, but we have trouble obtaining access to them and securing this funding. So to overcome the financial barriers, we propose 3 key recommendations. The first is the introduction of training modules and workshops that can address knowledge gaps and enhance grant application skills. Second, we can advocate for pediatric-specific research and innovation calls, which can create dedicated funding channels. And obviously, we should organize networking events and establish successful case databases that can foster collaboration and validate the use of both public and private funding for pediatric innovations. These strategies aim to empower innovators, bridging gaps and fostering targeted support for pediatric initiatives. Regulatory and reimbursement challenges emerge as the primary barrier for large companies. The hurdle ranks second for SMEs and startups and research institutions, and third for healthcare providers and patient organizations. This suggests that commercial-oriented institutions value regulatory and reimbursement barriers more highly than the research-focused counterparts. This challenge is universally echoed across all innovation groups. Regionally, SMEs and research institutions in leading countries place higher importance on regulatory barriers than their counterparts in moderate and emerging regions. The opposite is true for investors who perceive regulatory and reimbursement barriers as less critical in leading innovation areas and more important in lower innovation regions. A potential reason is that lower innovation region investors are less exposed to the mature companies that are facing regulatory and reimbursement barriers. Insights from interviews further underscore these challenges. They note that there's challenges with the new MDR and adapting it for pediatrics and different age categories, because as we know, the pediatric population is very diverse. Moreover, and what has also arisen from our discussions, is that there are limited centers in Europe, and these are not dedicated to children. So finding the right sites and the right patient groups, especially for rare diseases, is extremely difficult. And moreover, as we know, it's very hard to obtain good cost-effectiveness data, and this is further challenge for pediatric care. And there is an under-evaluation of pediatric data by the health technology assessment authorities. So what can we try to do? We propose several ideas. So that we can try to develop micro-sampling and micro-testing concepts to directly address concerns raised in the interviews about adapting to the new MDR and trying to work with different types of data and access to patients. Moreover, we can provide better guidelines for assessing quality and DALI impact, which offers a structured framework to help with the under-evaluation of pediatric data by HTAs. Moreover, proposing a certified startup label aligns better with the need to an easier route to market and helping, let's say, give credibility to startups that have good data and are credible but are hesitant to be adopted by the hospital systems. Additionally, advocating for a more DIGA-like reimbursement scheme provides a systematic approach to alleviate broader reimbursement challenges. So these are several of the actions we believe we can try to do to overcome some of the regulatory and reimbursement challenges. The third critical barrier was commercial and adoption barriers. And this is acknowledged by 67% of respondents. Stakeholders, especially large companies and investors and SMEs and startups, rank this as a crucial challenge. In leading innovation regions, commercial players consider these barriers as crucial, ranking them as second most important, closely trailing the financial barrier. However, areas with emerging and moderate innovation levels do not perceive commercial and adoption barriers as critical, only ranking them 6. So we see a huge difference here. Interviews underscore a notable gap in the frameworks and procedures for effective innovation incorporation by hospitals and other end-user systems. And this has been identified by 80% of SMEs and startups. So in-house capabilities for commercialization pose a shared concern. And this, with often having problems with scaling up their solutions and looking for pediatric-specific partners that are already limited in terms of collaboration. Moreover, there's issues with the procurement processes, and these are not well set up for pediatric innovations, and especially not for digital therapeutics. And this creates a key barrier for, let's say, a pediatric innovation type, which are the digital health therapeutics, which typically tend to be lower cost to develop, easier to try and scale up, but have limited reimbursement opportunities. So overall, there was a consensus that there is a need to standardize and harmonize the purchasing and adoption process across the EU, just so that we can get access to a larger market that is more similar to the US. And this need for being able to scale up solutions in a market that is small was consistently repeated by all respondents. So what can we do? We can establish relationship-building opportunities between stakeholders, aiming to bridge the existing gaps and knowledge on adoption and public procurement understanding. The creation of channels for solution co-design and validation with healthcare professionals can further streamline the incorporation of innovations. Training sessions on building successful business cases furthermore directly responds to de-risking pediatric innovations and stimulating adoption. So the human capital barrier also offered some interesting insights, and this ranked fourth on an ecosystem level. So a substantial difference arises here when comparing commercially oriented groups to research-oriented groups. Commercial stakeholders rank it practically the second least important, while research-oriented institutions rank it the third most important barrier. Moreover, lower innovation groups find human capital a greater burden, while emerging innovation groups rank it with emerging innovation groups ranking it significantly higher than leading innovation groups, as we can see here. There is almost a negative correlation between the level of the innovation group and the importance of human capital barriers. So what are the specific issues here? So there is, on the first hand, a challenge in attracting and retaining the required talent for public organizations and lower innovation regions. So limited positions are dedicated to the innovation activities, and these limited positions are observed both in public institutions and emerging and moderate innovation countries. Moreover, there's a lack of collaboration-ready hospital infrastructure, as we can see here. Moreover, there's a scarcity of pediatricians in general, contributing to this challenge. So 80% of interviewees express a lack of human capital with the required skill sets, whether that be administrative aspects or entrepreneurial skills, primarily in soft skills like idea generation, risk-taking, and networking. So to address these challenges, strategic recommendations arise. So we can create training modules for commercial-oriented and soft skills that can bridge the gap in identified, attracting and retaining top talent. Moreover, including innovation subjects in education courses can contribute to building the necessary skill sets from an early stage. At the same time, dedicated hours for innovation activities within hospital systems and other institutions can let's say, ideate the solutions from the people who see the needs on a day-to-day basis. Challenges for public engagement, creating challenges for public engagement and having European innovation challenges can really raise awareness on the needs and the skill gaps that we need to overcome. So while cultural and incentive barriers, interestingly, were not a huge barrier, it differed per stakeholder group. So what we saw was that these were quite critical for research institutions and healthcare providers, and this links a little bit to the human capital barriers we saw before. So research-oriented stakeholders ranked this barrier as significantly more important than commercial counterparts. And 80% of interviews revealed that priorities within research-oriented institutions differ significantly amongst personnel, with a lack of motivation from management personnel. So interestingly, large companies from emerging innovators emphasize cultural barriers significantly. And this contrasted with large companies and moderate innovation companies, which ranked these barriers as the lowest. However, there was a unanimous concern amongst interviewees on the reliance of government funding for research-oriented institutions on outdated metrics rather than on innovation levels. So typically we see that the budget that gets allocated to hospital systems is not yet dependent on innovation metrics. And therefore there's a misalignment on the incentives from the top down. So this highlights a critical cultural and incentive barrier. So we need to find a way to reward this innovation amongst all stakeholders so that there's motive, and it should go beyond just the financial one. And as I mentioned before, while those directly involved in pediatric research often recognize the need, whether this is in clinicians or research institutions, senior staff or departments are often not motivated in the same manner nor held accountable. So overall, there needs to be a change in the workflows, there needs to be a change in the positions, there needs to be a change in the way that the innovation is measured and valued by the people that are working on it on day-to-day and also from the governmental side. So how can I4Kids Europe help overall? How can we try to make the biggest impact? So we can create widespread awareness about the imperative need for pediatric innovation across all stakeholders and innovation groups. We can organize comprehensive trainings and workshops that can play a pivotal role in bridging skill gaps and fostering collaboration, thereby creating essential alignment within the pediatric innovation landscape, whether it be on accessing calls, making sure that you're developing the right solution for the problem that the hospitals are actually facing, and creating best practices to avoid duplications. And finally, at the end of all of these 2 years, we will be developing a white paper of best practices for sustainable innovation in pediatric healthcare. Together, these initiatives can help overcome the barriers facing stakeholders and innovation groups across the pediatric ecosystem and contribute significantly to catalyzing positive change for younger generations across all innovation groups. Thank you.
Thank you for this amazing speech. Is it available already? The research, is it available in some PDF form maybe? Can you download it, for example, for the viewers, or it will be available?
We have submitted it in the portal of the Commission, and we will make it available in the I4Kids website in a 4-week wait.
So it's going to be available in the following weeks. That's really amazing. And perfect. Thanks a lot. And we have a question. I don't know if you can have Paulina. Can we have questions? Paulina says yes. Okay, so we're going to have a question from Dr. Magda.
My name is Marc. I am a pediatrician from Children's Memorial Health Institute in Warsaw. Congratulations for this fantastic presentation, very with conclusions, very useful for our future, I hope near future. But I get one question on the methodology of this survey, because I was surprised to see in the beginning of your presentation that the showing the results divided into 4 groups: leaders, and Poland is in this emerging group. And I was thinking that we get in our country a lot of problems related to the regulatory barriers. But in fact, in this category, there's no difference between leaders and emerging countries. It's a 0.2 score in this scale. Is it significant or is not? So, because it's 5.8 for the leaders and 6 for emerging countries.
So unfortunately, we didn't have sufficient responses to the questionnaire to properly assess significant differences. So If anyone here hasn't filled it out yet, the questionnaire is still open and you can give your input. But what I think, so in reality, it's true that the 0.2 difference is not per se significant, but what we did understand is that emerging and moderate innovation groups, they have a greater challenge in navigating this landscape. So as we all know, regulatory and reimbursement processes are super complex, very lengthy, and I think that most likely in leading and strong innovation countries, there's better support systems to help researchers or startups navigate these things. I think probably the frameworks are not that different because we operate at quite similarly to some extent in Europe. But yeah, so it would be great if we can get more responses so we can see whether this is indeed a significant difference. Yeah.
Thank you very much. Somewhere at the beginning of your presentation, I realized I was one of the interviewers, you know, so I was looking for myself, like, is there my quote somewhere there? I'm not sure because it was anonymized, but I kind of identified, like, number 3 looked familiar, 25 and 17, which means we all have similar problems, even though if you're in the leaders group or emerging group. So thanks again, that was amazing. And coming next, we have our speaker, Marc Ramis, from Managing Partner of Montana Impact Fund and Venture Partner at Ship2B Ventures, who will discuss the challenges of financing in the pediatrics. So, the floor is yours.
Hi. Well, good morning. Thank you, everyone. Especially the organizers and K.I.D.S Poland for inviting us. It's a pleasure to be here. 2 years ago when we were doing the i4Kids in Barcelona and we were thinking about doing an i4Kids abroad, so here we are, no? So I think we have a recognition for that to be able to you know, start to internationalize i4Kids and this event here, okay? So thank you also, Faye, for your presentation. Because actually you make, maybe I don't need to do the presentation because actually you made my point. So the top one barrier here is financial, okay? And that's basically the challenge that we are trying to achieve through this fund I'm gonna explain to you in a few minutes. But this has been a work that we have been doing together with i4Kids for the last 2 years. On trying to find ways to go through this financial barrier. So these 2 kits basically represent 2 different concepts. One is pediatric innovation. The other one is impact investing, okay? So after this analysis, we kind of realized that one potential solution, and that's what we are testing right now with Montana, is to basically synergize between these 2 kits. The concept of pediatric innovation that you know very much, a lot, and then the concept of impact investing. So if we think about 1 second on pediatric innovation and we focus on the financial barrier, we'll see that basically how projects reach pediatric innovation. So they are basically at many children's hospitals around Europe, around the world, and they are, some of them well-funded by public funding, great scientists, pediatric philanthropy, and then some of them go to become pediatric innovation, generate some intellectual property, some know-how, something that could be interesting to reach the patient. And then there's some institutions that they are pushing that, consortiums trying to push that, but basically there's still a gap between this pediatric innovation and the impact of on children's health, okay? We describe that gap of innovation to patient. So one potential solution that is actually already working is the idea to create startups, okay? Find funders, people who is really excited about doing that particular job, not the previous job, and then give them tools, give them money, basically capital to do it. So I have like a couple of questions for myself and for the audience. How these ventures are currently funded? how these companies, these startups, the ones that they are already trying to bring the innovation to the patient, how they are being funded. They are funded by traditional VC. I don't think so, because much of them, as 1.6, 1.9% of venture capital invest in pediatrics. So basically, they are not well funded by VCs. And the second is venture philanthropy. Normally, they are not feeling well investing in ventures. So they invest more on the public research, they invest more on the hospitals. So it is enough? Clearly not, okay? So basically, the idea here is to how we can increase this patient access to the innovation by building more and more startups in pediatrics. And there are basically two ways to do it. One is increasing the venture building activities. So going through the first step of this venture building and increasing capabilities there by pushing more research, more venture philanthropy, pushing the first steps of a venture building, pulling from institutions, like, for example, there's a very interesting case in the UK where actually a non-profit foundation is funding the venture building process of a new company for a particular need that is being identified by the foundation. And the second one is that how we can increase this 1.6% of VCs that they are investing into pediatrics. Because the more capital they deploy, and that's the professional VCs that we need to deploy funding into the startups, the more that these startups will be able to reach the patient. Where we need professional VCs to become the investors of our startups. And that can bring success cases. So I'm not saying that pediatric ventures are not funded by VCs. We have actually successful cases in Europe. One of them is Minorix. This is a startup from Barcelona. And this company has been massively funded by VCs, well-recognized VCs, and they reach clinical trials. So it's possible that they can do it when they see that there's an interesting project. Another one that I know very well is Thebiotex, and this did not get funding by VCs, but they managed to reach also clinical data together with impact investors and crowdfunding. So you have here two successful cases to reach the patient, okay? Because both of them, they are on clinical trials. So actually kids are they got access to this innovation. So that's what I'm saying, that we need more and more and more Minorix and Thebiotex in therapeutics, same in medical device, digital, all type of technologies. So one thing we can do is scale up more and more and more entrepreneurs and ventures, and the other one to scale up is to bring more venture capital firms to invest in pre-seed and early stage and seed early stage companies. So in order to do that, our approach is this new modality of investment called impact investing. So you will see in the news, in many reports, actually many VCs, that they are saying that they are doing impact. Impact is the, is the new word that is everywhere. But who is really investing in how they are doing? They are really doing impact investment or not, okay? So one way to measure that is by this, and I suggest you to go to this really interesting, the GIN, the Global Impact Investing Network. You will see there many reports and information that actually what means impact investment. But to summarize, for me, it's like 4 different ideas, especially the 3 of them. One, intentionality. What means intentionality? The funders, they are looking to find a solution for a particular problem, and they are not going to change the mission of the company because the investment. They are going. So I give you an example. Let's consider there's a platform technology company who likes to sort a solution for a particular pediatric tumor. The same platform technology can be used for adults, okay? And they maybe have the opportunity to get investment from VCs to develop first an adult solution. But the intentionality of the team is to do it for kids first, pediatric first. So that's very important. And that type of founders are the ones that they are able to get impact investment. The second one is that you have to be able to measure the impact. And by measuring the impact, it doesn't mean, okay, this is going to reach whatever number of kids. No. It's not like that, okay? They are a methodology that has been developed for years, and then you need to be aligned with this measurement. Impact measurement, very important. There has to be financial returns. This is not philanthropy, okay? So you have to provide profit for your investors. And the last one is that you have to work in a range of assets, meaning that you have to focus in a particular technology, in a particular group of assets. So if you want to apply for impact investment, you have to be able to accomplish all these 4 concepts. And this is something very interesting because about 10 years ago, this was not even, I think, in the agenda. So there's something that is emerging. And if you measure, there are also papers from the same, how traditional investment, responsible investment, and impact investment is going to grow in the next 10 years, you will see how this impact investment will grow a lot. So what means impact investment in healthcare, or at least for us at Montana? Means that you have to provide, so here on your left, you have an expected financial return axis, and then on the bottom, approach to impact. So for example, philanthropy is passive on approach to impact. Sometimes they don't look for evidence base, and they are okay with a complete loss of capital. They don't mind if they lose the whole money. Impact investment is in the other side. So we are looking for market rate, return of investment, together with evidence base of the impact. Okay, so startups in pediatrics should be at that part, at that corner of. You can find this information again at the Global Impact Investing Network. So, as I was saying at the beginning, if you put together these 2 concepts, the one from pediatric innovation and impact investment, you will see that makes a lot of sense to build a vehicle, a private vehicle, based on this new modality of investment, called impact investment, to invest only in pediatric innovation. Okay, and that's basically the concept that is emerging globally. There are already, then you will see in a slide, there are already 3 funds in the US that they are a pediatric fund for impact investment. We met them 2 weeks ago in London, and I discovered there was another one in the UK that is emerging. Obviously, the British, they want to do their own. And there's another one in Canada. Okay, so, and we are the one that we are building the same concept in Europe. So basically, there are already 4 or 5 funds, and we think that there are going to be more in the next 5 years. And the reason is because it makes a lot of sense to find a solution to achieve the financial barrier on pediatric innovation by using this new modality of investment. So there's a complete rationale behind this. And that's Montana. I'm going to briefly introduce you the fund. So last year, I think I was saying here in the same Pediatric Innovation Day that we are going to do a fund and we are going to register a fund. So basically what we did the last year is doing that. Okay, so that was possible basically for 3 different parties. The one that brings us experience, the one that brings us knowledge about pediatric innovation, that is the Barcelona Children's Hospital. The one that is giving us knowledge, information, experience on impact investment, and is Ship2B Ventures. Ship2B Ventures is one of the leading VC firms in Europe on impact investment. They already raised 55 million on the first fund, and they have been invested by the European Investment Bank. So these guys, they know about impact investment. Actually, I know them very well because they invested in Thebiotex, in one of the companies I was co-founder. And basically, together, we went to them and said, we have this crazy idea to have a pediatric innovation impact. And they say, no, this is not crazy. It makes sense to us. So let's do it together. And the third party is our motivation. So K.I.D.S Barcelona is an organization, Ricard is here, hello, and they are the kids that they are doing things, they are pediatric patients, and we ask them can you help us to brand for this fund? And the name Montana comes from their idea. So basically there's I don't know if there's in the south, there's a type of wind called Tramontana. It's the wind of impact. And basically they like to see that as a wind of change, okay, as a wind to impact. And that's why we call this Montana. Okay, Tramontana was a bit, for English, a bit difficult, no? But so basically, Montana is the second fund of Ship2B Ventures. It's a 30 million fund. We are going to invest in the next 4 years, 16 to 18 companies. Next year at the Pediatric Innovation Day, I hope I can already disclose the first 2 investments that we are planning to do during 2024. It's based around the children's health. We are not going to invest anything outside of the pediatric field, and we are agnostics in terms of technology. The idea is to identify needs, okay? The idea is that our mission is that every child deserves a healthy childhood, and this is not happening. You know that much better than me. So the idea of the fund is to focus in particular situations, and then, work with this synergistic model of impact investing into the life science sector and going to impact investing in children's health. I've been inspired by John Parker from Springhood Ventures, and he always says that the market is not, and this is true, so the market is not small, so it's a growing market. We have the opportunity we have no competitors on that, so we are able to access the best pediatric innovation in Europe. And we have a lot of support from public institutional investors. They are very interested into this fund. So we are going to take advantage, and our investment thesis, and we are very proud about that, is an investment thesis around the kid. So we have 3 different pillars. The first one is prevention, everything that we can do to prevent disease. The second one is cure, treatment, developing drugs for kids first. And the third one is about life, quality of life of the kids after being a patient. So this is our investment thesis, and around our investment thesis, we identify challenges. So for example, one particular challenge would be, so for example, 70–80% of the drugs that they are being administered to kids, they are being developed for adults. So our idea is to develop drugs for kids first, and then repurpose the drugs for adults. So basically the other way around, the other way business model, and prove that this is actually a profitable business, and it is. So the idea is to do that. As I was saying, we are not the only ones. So if you have a startup and you want to contact investors, I extremely suggest you to contact them as well as us, sorry. And they are, and actually we are talking to do co-investments together. And this is Springhood, Health Innovation Capital, Next Step Venture, and Cross Border in Canada. Most of them, they are investing also in pre-seed and seed stages. Our experience, it's basically the combination of our experience in biotech. So I have been an entrepreneur before being an investor, and we have been able to raise seed and Series A rounds around both in Europe and in the US. And as I was saying, Ship2B has an amazing impact investment experience with already this small fund and the second fund, the big one with the European Investment Bank. And together we have been working in many pediatric projects, as you can see here, therapeutics, digital, medical devices, but we have a quite strong track record in Europe on that. And we have the collaboration with all the, with many hospitals. I don't know why this is not working, but basically our network, this is where we are going to scout, actually we are already scouting projects. The idea is to analyze between 100 and 200 cases per year, okay? During our first year, we already have 80 projects identified. We have received more than that, but 80 is the ones that we already identify, with the idea to invest in the next 4 or 5 years into 16 companies. So we are going to be very, very, and that's a normal rate from what you receive as a project and what do you invest. And the type of investments, we are going to do between 2 and 3 Series A, where we are going to be the anchor investor, and we are going to co-invest with other investors, the ones that you see before, or maybe traditional VCs that we are able to convince them to invest into a startup pediatric. The main focus of the fund is seed, so we are going to do between 8 to 10 seed investments that will qualify a funding team with intentionality, proof of concept, strong IP. And then we will be also able to do some venture building ourselves. So around 10% of the fund, we are going to allocate that to create the companies together with the entrepreneurs. And that's, I think, a very, very interesting modality for you to apply. So because we are going to actually, we have the experience to, also the lessons learned to do the venture building and to convince other investors. And we are welcome, and that's basically what we are very hands-on on that. We love to do that with founders. And that's pretty much my presentation, and thank you very much.
Thank you for this presentation. That was actually amazing. That means there is hope, right? There is hope in pediatrics funding, you know, which was the main goal or the main problem that the ecosystems were having. So it really is something to look for. And right now we're going to talk about the second biggest problem that we heard of. So commercialization, reimbursement, and the barriers on adoption of innovation. And to have this discussion, I'm going to welcome on the stage our esteemed speakers, Bettina Nygaard-Nielsen, PhD pharmacist at the Department of Anesthesia and Surgery in the Pediatric section of Rikshospitalitet. We're going to have Eva Lejnice, Coordinator of International Projects of the Development of the Telemedical Strategy Sharing Children Hospital University Hospital Experience Riga, and Dr. Marek Migdał, Director of Children's Memorial Health Institute. And guiding the discussion, we're going to have Charlotte Berto from EIT Health Spain.
So thank you. So good morning, everyone. I'm really glad that we are here all on the stage today to moderate this exciting panel where we will talk about commercialization, reimbursement, and adoption in pediatric healthcare. So my name is Charlotte Berto. I'm project officer at K.I.D.S Spain and part of the consortium of i4Kids Europe. So first of all, many thanks to Marc Ramis that I think give us a really great opportunity to step in after this introduction to the financial challenges, which are highly related to the topic that we will discuss right now. So based on the analysis that have been presented just before by Faye, we see that the regulatory and reimbursement as well as the commercial and adoption barriers are the second and third most important barriers for pediatrics innovator in Europe. So these results are highlighting the importance of supporting these regulations and commercialization strategy for pediatric innovation to facilitate the adoption by external parties. And I feel that's what we will particularly focus in our panel right now, the adoption barriers. So with the amazing set of experts that we have here. So Bettina Nygaard-Nielsen, PhD pharmacist at the Department of Anesthesia and Surgery in the Pediatric section from Rikshospitalet in Denmark with experience on clinical trials. Eva Lejnice, Coordinator of International Project with experience developing the telemedicine strategy in the Children's Hospital University in Riga, Latvia. And finally, we have Marek Migdał, which is the director of the Children's Memorial Health Institute with more than 35 years of experience in pediatrics intensive care, and as a local from Warsaw, Poland here. So to start the discussion, I would like to ask you, what do you think are the primary obstacles that healthcare providers face when adopting new pediatric healthcare technology? I don't know who wants to start. Bettina?
Yeah, I can start. Thank you for some very nice presentations. And what we have experienced, what I have experienced during my work with innovation is that definitely the financial barriers will be there, getting funding for your projects, for startups, for just doing clinical studies. That is a challenge. But also when you have, like if you have medical devices you want to implement, often they are tested in adults and they don't come with data for children. So you have to sort of generate the data yourself in order to have evidence for the treatment and can do evidence-based treatment for the children.
Yes, from our experience, we faced that readiness of clinicians to do something to change approach, to make innovations. For example, when we developed a telemedicine strategy, we start from doing one mistake. We start to build it with a group of experts in digitalization. So we make the plans and strategy based on their opinion, what is the best experience abroad, and etc. And when we actually start to ask clinicians, we saw a completely different picture, because if they are not ready to change anything, to implement something new, to change approach, then we will always fail. That is our one of experience. The second is that we are a public university hospital, and even if something good is getting into the market, we can't use it next day. It takes years to implement that. For example, when they came out with insulin pumps for diabetes patients, we had the opportunity, because we have Children's Charity Foundation who pay for that before NHS start to do that after 2 years or something. And the third thing is a certification of innovation if we are speaking about medical technologies.
Okay, thank you. And I don't want to defeat the position of the clinicians. I am still clinician, a pediatrician. But the problem is that I agree completely that we get a lot of the regulatory barriers, financial, but there is also a problem currently in majority of the countries, including States and Canada, the problem with the shortage of the medical staff. I'm talking not only about the problem with nurses, but also technicians and medical doctors. So sometimes it's a problem that the medical staff, if he is overloaded with the regular clinical activities, they are not really able to get additional activities related to the, for example, to the testing or to some research dedicated to innovations. But I think that as usually, if we get some, also not only senior physicians, but also the junior staff who are really interested in innovations, who get a chance to introduce such innovations in our medical institutions. So I think, just to sum up this point, that what is important is to look for the real workforces to be adapted for the new duties and the new challenges. Let's talk about challenges. And I think that we can do it. And of course, there is still a lot to do to improve the situation, but especially after such discussion and presentations as this morning, we get much more motivations to improve situation. So not only financial issues, regulatory, but also we should look how to improve our workforce's availability.
Yes, I agree. The local infrastructure for innovation at your hospital is also important to prioritize.
And do you feel like in these challenges, mainly for the adoption, do you feel also that the workforce can have an impact to facilitate the commercialization and the adoption, or do you think it could be tackled in another way?
Yes, and I think that during this panel discussion, the first word in the title is commercialization, which is quite still rare in the our regular duties of the public hospitals, at least in this part of the world. But important is also reimbursement. A lot of innovations which are doing in our hospitals, we are doing as a kind of the pilot studies using some charity foundations, for example, to introduce the new medical technologies, and later having the very good results, medical results, economic results, we are starting to discuss with our health technology assessment agency in Poland, and later with the financing body, which is National Health Fund. There's a chance, and later, from the perspective of the public hospital, it's a kind of the commercialization, because we test it, we get a good results, and later we get a chance to increase our income from the National Health Fund to reimburse this medical procedure. So I think that's, yes, we are able, it's much less or much less frequently to get a commercialization of the, for example, new medicinal products or medical devices in terms of the, what is to get the approved indication or to get the approved certification for the medical devices. But this is the future. We get I don't want to prolong my talk, but having the Medical Research Agency in Poland established 3 years ago, we get the funds, and we are running in our hospital, for example, non-industry sponsored clinical trials, having the, I hope in 5 years' time, results which will be able to change, for example, to add the new indications for the old products.
And so also something important in pediatrics that we still didn't mention is pediatric healthcare is really patient-centered. And maybe can you tell me how to ensure that this commercialization efforts align with the specific needs and preference that can have the patient, the children, and their family?
I will maybe start. Firstly, about commercialization. We are a public hospital, and as a colleague in Poland told, we can't do commercialization, but we are working with national systems so we can do it one day in the future to improve this development of innovation. Second thing about patient in the center, we as a hospital are working as a filter with our experts, including patient parents supervisory board, to filter those innovations what are getting in the market, if they are actually, if patients will get benefit, like real benefit, not just in innovators' mind, but in real life. So we are working, we have team, we are like evaluating this, if patient will be in the center, if not. Otherwise, that is our aim, not aim, but our role as a hospital, what we can do.
Yes, I think if development is going on in the hospital, it could be development of new pharmacological interventions or medical devices. It will be patient-centered, and it will go from a point from the patient's needs, because that's what you see as the medical staff in the hospitals, that you have these challenges and you have a desire how to solve them and improve patient care and essentially make it more child-friendly.
Sure, thank you. And related to that, do you have any experience or lessons that you have learned from the past where you could share with us? Or?
Yes, we have been doing in the Department of Anesthesia, where I'm working, an innovation project where we developed a nasal spray, an analgesic nasal spray for children. And so we have been struggling with both the clinical trials, the regulatory authorities, the funding, and also taking it from the point of just being a clinical trial with a potential new product to actually doing the regulatory path as a hospital, doing a pediatric investigation plan. And then from the pediatric investigation plan, which is a development plan for it to become an approved product, and into a spin-out company, and further funding for that. So that's sort of all the way. And what I can say is that it's, to my point, it's very important to early in this process to dedicate a commercial project leader to this project, to these kind of innovation projects, because as a healthcare person, you think about all the scientific purposes and challenges here, but you sort of don't know that much about the financial and the commercial part of it. So I think it's very important that you have a person very early in the process that sort of adds these inputs to the project.
Thank you for sharing this insight. Yes?
If I may add another example from the past, the example of the innovation which was not related to the economic effect. It was related to the innovation which we performed 3 years ago in our hospital, together also with the K.I.D.S Foundation and other sponsors. We were informed, just for knowledge of those people who are not able to attend yesterday's visit in our hospital. This is one of the biggest European pediatric tertiary hospital at the moment. We get 1/4 of the million of children passing through our hospital every year, and this is a big complex, 31 buildings in the complex, and one of the partner from the K.I.D.S Foundation, they performed this study, the questionnaire or survey among our parents of our patients. What are the real barriers which they see in our hospital? And more than 50% of our patients are coming outside of not only Warsaw, outside of this region, Mazovia region. And for people coming from, 300 kilometers, 400 kilometers, it was a real the biggest stress was not related to the medical procedures. The biggest stress was related to how to find the proper place in our complex. So that's why we decided to make in our hospital a kind of the food metro. We get 8 lines of the metro. We get more than 30 stations, And later, thanks to K.I.D.S, we also introduced this kind of the navigation system among all of the parts of our hospital, just to support the families. So this is a type of the innovation in pediatric hospital, which is not related to the improvement of the direct improvement of the medical care or economic effect, but is supporting the families. And as you know, with the decreased stress, we get much better, much easier later to perform our medical procedures. So please remember also about this type of the innovations, which are very important for the families of our patients.
Yeah, I can also add shortly that we also did the same, because we are facing now a lot of reconstruction work. All over hospital territory is under reconstruction, and it's very stressful for kids, like for parents and families to navigate. And we also have the lines, colored lines, where they can find something. And it's, I will also agree that we don't need to forget about small innovations, what doesn't cost like almost nothing, just idea how to improve.
Thank you. I wanted also to ask you, so with this innovation, I wanted to know if you have sometimes some, like on the regulatory landscapes that we didn't touch so much for the moment. I wanted to know how, as a healthcare provider, this regulatory environment impacts you in your innovation. How do you deal with it, and which strategy do you employ to navigate these challenges while ensuring the patient safety?
Yeah, he was looking for me, so I start very shortly. Yeah, that's as we discussed previously. Of course, the regulatory barriers can be very important, regardless of the part of the world or Europe. And in Europe, we get talking about the innovations related to the medicinal products or medical devices. Since 2007, we get a pediatric regulation, which changed completely the landscape in the development of the drugs for children. There's the obligation at the moment for the pharma industry to perform the clinical trials, different type of the clinical trials in all age subset of the pediatric population. But we get also the regulation on medical devices, which changed previous directive. This regulation was went into the force in 2017, and the transit period will be ending in 2024. And there is a real problem for pediatric society, because they need to certify all of the medical devices or medical materials in all age subgroup of the pediatric population. There is a real challenge. During the previous talk, where it was said that there is for the investors, there is the pediatric market can be profitable, which is there are a lot of the opinions that no, to certificate, for example, the endotracheal tubes for neonates, the same with catheters for neonates, the gastric tubes. It's a real financial challenge for the manufacturers, and we get a lot of the worries how we perform. And of course, we are open for this also to support the industry or innovators, but I see a lot of the problems in the near future.
And for the pharmacological part, or for the clinical trials with pharmacological interventions, you can say that also the requirements is increasing all the time. So I would say that from the point where you have the idea for the clinical trial and going through all the approval, it will take you half a year to 1 year before you're ready to start, actually. So that's quite a long time.
And later, additional couple years to collect the results of the...
That's another thing, yeah. Data collection, right? So, and also you have to consider for that. Normally, if you're doing large trials, one side will not be enough, and you have to collaborate, and that's a good thing, I think, with other countries and other children's hospitals to get the data collected in due time. But also you have to go through regulatory procedures in these countries. Normally it's easier when you got the first one, but still it's a lot of administration here.
Yes, and we also need to speak with like those policy makers about the role of innovation and how to make those processes easier, not to take like 2 years or 3, but how to change in general those processes. So it make it a little bit easier to change something, so it doesn't take such a long time.
Yeah, and I think actually also that's important, go back to the infrastructure at your own hospital, and you have the support you need to do this while you're also doing clinical work and other assignments here to get the work done in due time.
Except I think it's a really good point to contact the policymaker, but in the clinical trials, do you think there is another way or another strategy that you can use to go faster or to improve it in the following years?
Well, I think, you know, doing it the first time is almost the most difficult, and then the third and so on is much easier. So I think if you have some support in your hospital for doing this, where you can go and get advice, if you cannot do that in your own apartment, I guess levels of experience with doing clinical trials, pediatric clinical trials, will be different from different departments.
Yeah, but it's also our role as a pediatric society to support innovation. And of course, we have no enough money to invest for the development of the new drugs. But we can also cooperate with the with innovators in terms of the, for example, validation of the new biomarkers. It's extremely important to assess properly the efficacy and safety of the new products. I'm talking about the medicinal products, but we have to use the validated biomarkers to see if the drug is working or not. So that's the role, and that's also a chance for us, for the research pediatric institutions, to find the, for example, talking about the new treatment options for the oncologic patients or rare diseases is important, especially with the very limited number of the patients, to know how to really verify if the drug is effective. So that's, I think there are still a lot of the space for the, first of all, for the exchange of the ideas, and later to cooperate in this field for such innovations. Not really very big, serious investments in terms of the budgets are needed.
So you pointed out so the need of innovation for the pediatric society. And to give a bit of future outlook, what do you think could do like maybe the industry collectively with healthcare provider and so on to remove this barrier and really promote this innovation?
I think that is a common goal to cooperate. Yesterday, during the afternoon session, one of the speakers said collaboration equals innovation. So we should to talk together, different stakeholders, and to look for the solutions. If you are, of course, we can get a different backgrounds and different aims to achieve. For us, the main goal is to improve the healthcare provided for the children. But if it is in the same direction for the industries, it's fantastic.
And Eva or Bettina, maybe same question, or do you think there is any tool, strategy, or maybe programs that can be implemented to help to work with industry or to help startups, for example, to...
I think we are already doing this in this network by establishing that. So we just need to know to learn how to work together in most effective way.
Yeah, I agree. But I can see the potential for further collaboration during children's hospitals or hospitals that treat children in Europe, especially if you want to do these larger clinical trials and you want to do them within a specific time period. Because, as you say, if you go into rare diseases, there's not many patients in each country each year. Or then you have the other scenario where I work within anesthesia and pain, and then you have actually a lot of patients. But still, you also need to do large clinical trials to establish evidence, and that would still require more than one site usually, and more than one country.
And finally, I wanted to ask you, like, which differences you think exist between your own healthcare system and maybe other EU country? Which differences existing in the reimbursement and adoption strategy that you can mention and maybe could be improved?
Yeah. Once again, I would like to return back to this morning presentation of the survey among these, you know, the different providers, leaders, and emerging countries. I think that it's important to recognize what are the real barriers are existing, and not only existing in theory, but also what these barriers are. Look for us on our daily practice, but I think that there were fantastic comments using as examples, and I think that still we must improve the knowledge, we must to talk, we must to avoid the wasting effort and money for the innovations which are not really innovated, because we discussed yesterday that for us working in the pediatric intensive care, there were during the last several years a lot of the proposals to use the new IT tools, for example, to collect data from our patients, or to introduce the new mode of the monitoring of our patients. But in fact, in theory, they were working. In practice, they were so, for example, time-consuming that we decided not to use this in practice. So that's, I think, but conference like today is a perfect way to discuss and to improve our, you know, the activities in near future. So I am optimistic. I believe that in near future it will be a real progress.
Well, I must say, considering all the challenges we have experienced with innovation and doing innovation projects, I was a bit surprised to learn that my country was in the innovation leaders group. But yeah, I'm optimistic too for the future, and I think like initiatives like this, where you support collaboration, and that will do something good in the future.
And so maybe to wrap up, so if you had to propose today's headline for this topic, which headline will you say?
Let's work together.
Maybe very short. There is a need for improvement, but there is also a hope that this improvement will be achieved.
Yeah, that's definitely a challenge, but we have to stand up for the kids.
Great, thank you for this message. So we are coming to an end, but I would like to truly thank you for all these really interesting insights on this topic, which is really challenging, but as you say, it's optimistic, and I'm sure that we can continue in pushing the innovation forward. So I really like this optimistic message. And also a big thank you to the audience and the attendee online for their participation.
We have one question from the audience, actually. So maybe before we congratulate you on this really nice panel discussion, we could, share this information or this question. The question was about the open data sets. What about open data sets in your country? Do you share, for example, data with the innovators, pediatric innovators, to help them to do the innovation? Is it possible even?
Depending on the type of the data, as usually. Yeah, but of course, as I presented during this panel, my position, we are open for dialogue, for the questions. Of course, if there are the data which are, protected by the data protection, the GDPR, it's difficult. But yes, quite often we are in daily practice, we are asking for the so-called feasibility data, and we are responding for this. Yeah.
It's the same also in Latvia. We are always restricted with GDPR, and we can't even, sometimes we are facing issues even sharing data with students who are working. And but if we can hide that according to GDPR and other restrictions, then we are open to share, of course, to help.
Yeah, I think we all have the same GDPR challenges, but normally there's or often there's a way around here, depending on the kind of data, of course.
Thank you to all the panelists, and I think it's the best time for coffee. I see my Italian friend there. Maybe we can have an espresso together. So let's get back to the discussion in 20 minutes and come back to us at 11. Thank you. Welcome back, everybody. I hope you had a nice coffee break. Right now, we're going to build the biggest bridge in the world, the bridge that will take us to the Stanford. We're going to have the possibility to hear that what Stanford biodesign process for effective pediatric innovation implementation looks like. So please join me in welcoming our next speaker, Dr. Janine Furch, Associate Professor of Neonatal Perinatal Medicine at Stanford Children's Hospital.
Thanks, everyone. It is truly a pleasure to be here and join you all from California. I have never been to Poland before, so this is an amazing place, and just want to thank everyone who's put together this wonderful event. There's never a day that I love more than I get to talk about pediatric innovation, because first and foremost, I'm a practicing neonatologist, and so innovation for my patients is truly important. And secondly, I'm also an innovator, entrepreneur, teacher, researcher, and on and on. So they wanted me to talk today a little bit about the Stanford biodesign process. So just a hand raised, who has ever heard of Stanford biodesign or biodesign? Lots of you, great, awesome. I love those hands raising over there too. I see all of you. And I know that some of you use it in teaching your own courses or fellowships as well. So we're going to take it back to basics. And I am here today to not necessarily talk about the barriers, which I can talk about all day, because I have done pediatric innovation myself. I have had companies acquired in the pediatric space, and it is hard, but it is also possible. So we're going to talk about how to actually do it and how we've been helping companies all around the world do it over and over and over again. So of course I have disclosures because I'm part of companies or consult for companies. And if you don't know what Stanford Biodesign was, which I know many of you do, we are a group that advances health outcomes and equity through innovation education, translation, and also changing policy, which I know we talked about a little bit about before, is a really important thing to make sure that the entire ecosystem is truly there. Now, in our fellowships, in our classes, we're not necessarily trying to make people produce companies, which is a little bit strange, right? But we are trying to produce the next generation of health tech leaders who then go on to make companies. But of course, a byproduct of that are companies. So there's been over 52 companies that have come out of the Stanford Biodesign program in the last 20 years that was initially started by Drs. Paul Yock and Josh Mackauer, a serial entrepreneur, if you've heard of those names before. So over the last 20 years, this number's probably gone up since this slide was last updated, but helped over 9.4 million patients, which is probably the most important impact metric that we can actually think of. But guess how many of these patients are pediatric patients? Up until 2 years ago, there were 14,000 of these patients, which is really atrocious, right? The process selected out pediatric companies. Anytime any VC hears the word pediatrics, they smile, turn around, and walk away. We know how that goes. But we've really changed this process, and we've really changed this by introducing a different program and a mechanism that we call Impact One, which you'll hear about today. And I don't think I have to convince any of you of this because all the wonderful presentations before today already have. But just something to think about and put in your head, that industry truly spends more money to develop health technologies that address the last month of life than on technologies that can transform a lifetime. And that's really sad. And it's really sad when you're a neonatologist who cares deeply about your patients. But if you don't believe that, I know that you've seen some of this data before, you can believe what the FDA puts out. So guess which line is pediatric approvals? The blue one or the green one? We all know it's the green one. And the secret about this data is that these companies that have gotten pediatric approval from 2008 to 2016 are flat, they're not accelerating, and they mostly address patients 18 to 21 years of age, which are considered pediatric by the FDA. Now, a 21-year-old is not the same as my 450-gram, 23-week preemie, and they have very different needs, both that day and as they grow over time. So, coming back to the whole idea, how does this process actually happen? And I know that we've assumed that most people know how innovation happens, but I'm just going to take a step back and realize all of this has a US bend to it. So if it's different in your own entities, don't take that differently. But how do you really move? And physicians often wonder this all the time and ask me all the time, how do you move from an idea to a product used in patient care? Because having ideas are really easy, but actually executing that is very challenging, and that's where it comes in. So we use medical devices every day if you're in healthcare, but we never think about how they get there. We don't think about the fact that every single device, whether it is small, simple, or very complex, requires a market analysis, a business plan, a sustainable business that can continue to produce devices, as well as a regulatory pathway, reimbursement. They have to get paid for it. You have to have an engineering team. you have to have a quality system, and the list goes on. And this takes time, and it has to be really thoughtful. And it has to be really thoughtful when you're innovating for adults, but it has to be even more thoughtful and precise when you're innovating for pediatric patients, because the cliffs that you can fall off in pediatrics and maternal health are, there's a multitude of them. It can happen all the time. So most technologies, especially coming out of an academic environment, come from a technology push. So a brilliant scientist comes up with a technology, and then they go looking around, where can we apply this in as many places as possible? And that works a lot for academia, but it doesn't necessarily work for innovation in healthcare. So the way that we approach this at Stanford Biodesign is truly needs-based innovation. So we take a need, really understand that need. And if you've ever done the process, you think you understand the need, and then you think you understand the need, and then you think you understand it, and I'll still tell you you don't understand it, which can be really frustrating. But we truly understand those needs. And then the technology actually is much easier to develop because you already understand the parameters around that. And there are 3 stages to the Stanford Biodesign process. This looks very linear and nice and fluid, but really it's very iterative and messy in practice. So identify is identifying the clinical need, doing needs finding and needs screening. Inventing, which everybody loves, is inventing the disruptive technology and screening those concepts against all of the filters that we have, including intellectual property, regulatory, reimbursement, business model, et cetera. And then the process that goes on for quite a long time is the implementation, creating a viable business. So we're talking a lot about medical technology here, but this applies to engineerable biotech and other things as well. But we do believe in creating a sustainable business so that you can actually get those returns back to your investor, and that you can stay alive and not just based on philanthropy. So now into some examples. So here we have, this is a company that eventually ended up being Novonate, which I'll tell you about, but adult central line management, right? You guys have seen this before. It's protective, it's standardized, it's simple. There's a company that develops this. We want to make sure that lines that go centrally into the bodies of our patients are protected because they're at very high risk for infection. And that is the standard of care in neonatology. This is non-standardized tape that a nurse puts together in an art project to hold the most important lifelines into my 23-week preemies and sometimes 22-week preemies that is exposed, and right there's the diaper. So you can imagine that these lines have the highest rate of infection in the hospital anywhere. And this should be appalling to us, that we allow this to happen to our patients. But we don't anymore, so. Just a little bit about umbilical lines to give you guys a little bit of background. They're actually pretty easy to put in as far as lines go. They can take a couple of minutes. They go in through the umbilicus, through an artery and a vein, and they can instantly provide life-sustaining therapies for the patients. Most of the time, these babies, they need glucose immediately and other things, and their veins are, as you can imagine, when they're about 400 grams, are quite difficult to access. So this is the place that we're able to access everything, and you can monitor blood pressure and everything. And it's really painless, so we like that in pediatrics as well, and probably in all fields. But umbilical catheters are often removed anywhere between 3 to 14 days because we're worried about infection. Not because they're going to get infected, but because we're worried about them and the way that we currently do our lines. So the company that eventually came up with this, of which, for full disclosure, I was the medical director for and continue to work for, they came up with a need statement. And this is the core of the biodesign process, and it seems really simple, but it's actually pretty challenging for anyone who's done it. And Polyak will tell you that a well-defined need is the DNA of a great invention. So you prototype it. And the way that these need statements go is a way to blank a problem in a population in order to affect a certain outcome. And I want to go through some things so you can think about the problem that you're trying to solve and give you a couple of newer strategies to figure out how to do this. And so what you want to do is you want to figure out what is the most compelling unmet clinical need, and sometimes that's challenging. So it's probably not the first thing you think of, or it's not the first thing that you observed. But you take that observation and you go back and you try to figure out where the sweet spot is. So is the problem protecting, inserting, securing all catheters? Is it securing umbilical venous catheters, inserting pediatric catheters? Where's the problem? And then you can also go upstream and downstream of your initial observation. So that means, are you trying to prevent CLABSIs in umbilical lines? Are you trying to diagnose them? Are you trying to identify or treat them? Or are you going on to do surveillance and management where you're monitoring line position? And you can choose any one of these that you want, but you want to make sure that you're choosing the most compelling unmet clinical need. And I can't say that enough, because you don't want to spend time solving a little problem in a little population, because then you're never going to have a sustainable business, okay? Got to have impact. And then in terms of the, another one for the problem, this is really hard for everyone. We are solution agnostic. You cannot think of a solution. If you think of a solution, I will know that you thought of a solution, and you will create a need statement around it, and it will show up there. So this looks subtle, but it really limits the range of potential opportunities that you have. So a way to prevent CLABSIs, okay, we're not all thinking of the same thing. Versus a way to remove bacteria colonization from umbilical catheters. That's like, okay, so we're thinking about how do we scrub that? How do we do that? That's probably something mechanical. We're not thinking about a digital solution. We're not thinking about a biologic necessarily. And it makes you start to think about a solution. Make sense? Okay. So then we think about the population. And of course, everybody wants to treat the biggest population possible, and your solution can be for everyone. But that's not true, because you can't solve anything that is for everyone. So as you increase your size of your population, you're also increasing the heterogeneity of that population and decreasing your ability to solve it. So you got to figure out where exactly that sweet spot is. And then, of course, outcome. Physicians care about, our satisfaction, but I guarantee that payers do not, especially in the US. And of course, we have a huge payer problem, which we won't get into because that'll take all day, but that's a different story that I'm thankful you guys have much less of an issue with. If you can address mortality, of course, that has higher value in reimbursement, and safety, productivity, and it kind of goes down the list. So think about your outcome, and it really has to relate to the stakeholder that is the decision maker. What do they care about most? And who's really that stakeholder? So this company came up with a way to, this is their first one, before they met me, a way to protect umbilical catheters in neonates in order to decrease CLABSIs, or central line associated bloodstream infections. Sounds good, right? You got a problem, population outcome, they're related, and you're trying to do something that's pretty impactful. There's a problem with it, but we'll get to that. So then what you do, and I'm combining an entire 10-month fellowship into a very small period of time. So forgive the large leaps that I'm making. You look at disease state fundamentals, existing solutions, market analysis, stakeholder analysis, and you don't just come up with one need, you come up with many, many needs, over 100, and then you have them compete with each other. And you come up with need criteria. So need criteria are super important because it tells your engineers how to make your device, but it also needs to be solution agnostic. So must-haves are things that you absolutely have to have to gain entry into the market, and nice-to-haves are things that are really market differentiators that blow things out of the water. And you want to look at things like efficacy, cost, safety, usability, all of those. And so they did all of this, and then they came up with this device. So this is their solution, and the video on the right is demonstrating how it actually works. This is a very simple solution, and I'm not saying that all pediatric device development needs to be simple. I also work for a company, Vitera, that's doing the artificial womb, and they just raised $135 million to help do that, so that is not simple at all. But this is fairly simple. So it secures the catheter, it protects the catheters, it keeps them from moving, it decreases migration, and it goes right into the standard of care that we're used to. So we've seen no CLABSIs on over 4,000 patients, and the migration rate is decreased at least 7-fold. And so we realized that if you're going to do a clinical study, CLABSIs don't happen very often. They only happen about 1.6% of the time. So a better outcome that was actually measurable and still impactful was to decrease umbilical line migration. And this is taking a very complex problem, this need statement, and distilling it down to the most important aspects, which allowed them to come up with a solution quite easily, working with nurses and physicians and everyone in our hospital as well. So we not only did this once, but we've done this again and again. And the way that we approach this as entrepreneurs and physicians as well is to take really impactful needs, go through that process, which is much longer and extensive than that, and then try to have something where we have low capital, ability to be acquired quickly, and have an exit so that we can have a larger company help accelerate that technology as well. And that tends to be our personal way of looking at it. It does not necessarily mean that that's the only way to do that. So we've done it more times than just Novonate. But Novonate raised a little bit over $1 million. They've treated over 4,000 patients, are in hospitals all around the US and hopefully coming to Europe soon. And they were acquired in 2023 by Labary, which is continuing to expand this NICU portfolio and really allows us to have a better sales force because it's actually really hard to sell one pediatric device to a lot of hospitals. And then a company that I created is called Emmy. It's a hardware software solution to manage life on birth control pills, which is a big problem because about 9% of women become unintentionally pregnant every year while on birth control pills just because they forget to take it. And we were able to solve that problem. We raised $3.5 million. It's commercially available and it was acquired in 2022. And then another doctor at our institution who is a pediatric cardiologist, Brown and Harris, came up with a practical asthma monitoring system that puts a sensor under the bed and is able to identify asthma exacerbations early and decrease hospitalizations. They raised $1 million and were acquired by Apple. And then they're going on to develop that technology as well. So this is really possible. That's mostly what I'm trying to tell you. You can do this, and you can do this over and over again. And so we are doing this over again. So we incubate our own projects, but then we help accelerate projects, which we'll talk about in this next panel, from all around the world, because that is truly our passion. Without, any taking equity, financial commitments, nothing like that. We just really want to help individuals and programs and hospitals be able to advance technology and get them to pediatric patients. So this is one, because apparently in the US, fetal patients are not pediatric patients, so they don't qualify for the same type of funding. So fetal is basically forgotten. And there's a whole lot of political implications there, but we won't go into that. But sometimes when you have patients that actually have a bladder problem where they are not able to have urine pass out, you have to put in a shunt. Right now, you sometimes have to do that 7 to 8 times, and the baby still has issues, including poor lung development and potentially kidney disease after that. So they're developing a vortex shunt that actually stays in place, is kink resistant. They're in animal trials in Belgium right now. And so hopefully they'll be able to decrease this dislodgement and decrease the procedures that a pregnant mother has to have from 7 to 1 and actually be impactful. Another project we're working on is diagnosing early stage necrotizing enterocolitis. Premature patients often have a very high risk of having a gut condition that can kill them in very high rates of mortality and ongoing morbidity. But the issue is we know how to treat it, we just don't know how to detect it. So we found a way to analyze breath in order to be able to detect these cases at least 2 days earlier, which is gonna have a huge impact, which we're really excited about. And so that's almost ready for to spin out of the university. So we keep them in the university for at least 18 months, try to do the clinical trials, use all those resources, and then we're competitive for funding. Some of you may recognize Elizabeth Rosas, who is amazing and another one of my fellows. She has now gone on to, our fellows look in different places in the hospital every year, and this is our second year fellowship. There's lots of details there. They go on to be in the different centers of the hospital and develop innovations through that. So she spent her second year in the heme onc wards, and she found that Now, doctors would never tell you this, so it's really important to have observation, but oral mucositis is a horrible complication that specifically affects pediatric patients even more than adults, where you get horrible ulcers and mouth sores from chemotherapy because that skin is turning over most rapidly, and that's what chemotherapy targets. So she found a way to do a cryotherapy in the mouth while they're actually getting chemotherapy, much like the hats that people do to protect their hair, to then prevent and decrease this side effect. And we found ways to be able to do this where we can raise $50,000, be able to get that while in the university, get all of our IP, get it ready, do clinical studies, engineer basic prototypes to get it ready for venture funding or impact funding. So this is Impact 1. We're going to talk about this a little bit in the panel coming up. But this is my amazing team that I can never say enough about, led by myself and Koen Scheth, who's a pediatric urologist, supported by lots of lovely funding from the US FDA, as well as the Gates Foundation, Kobe Cure, and a bunch of philanthropic supporters. In the last 3 years, and it doesn't even really include this year, we've supported over 122 projects in 17 countries and 6 continents. We haven't gotten Antarctica yet, and Elizabeth really wants to get Antarctica, so if you know of any pediatric projects happening there, we would love to know. They're at any stage, and they're at any FDA classification. We're really proud to say that the founders are very diverse, with 34% being female, and also having persons of color being 28%. But these companies, since receiving our support, have treated over 32,000 patients, a number that I'd love to share with Josh McHour and say, see, we did this in only 2 years. And they've raised over $108 million. We haven't even surveyed them this year. Created over 214 jobs, and 2 companies acquired, but those were ours, so we'll throw those in there. And then we do provide additional funding, KOLs, consultants, connections, and meeting with the FDA too. So we are enthusiastic about creating new partnerships, as we have started to do in Europe, and come ask me if there's any partnerships you want to create, or if you have any questions.
I actually have one question.
Sure.
Because it just a short one. I don't know if you know probably Sheba Medical Center from Israel.
I do. I was just in Israel last year.
So they have the ARC, which is which they do kind of implement in different countries. Do you consider this as a maybe like a product that could be implemented somewhere else with the know-how and the framework that you just developed?
In terms of Stanford Biodesign, or are you talking about Impact 1 in general?
Impact 1, like this looks impressive as well, but Stanford, but let's maybe do Impact 1.
Yeah, so I'll actually start with biodesign. So there's several different biodesign programs around the world, some of which are affiliated, many, many more that people have started and teach courses at, one of them being Israel Biodesign, so that's why I was out there a year ago. I do think that we need to come together as a community to support pediatric development, not just as a European community, but as a world community, because we have less patients who have these conditions. We have to collaborate in order to get enough patients through trials. And I can tell you, as a physician, I am super tired of using everything off-label. Nothing is approved for my patients. Literally no drugs I use are approved. No technologies are necessarily approved, very few of them, I should say. And that would never fly in the adult world. And so we need to come together to be able to change that and give physicians and parents and families information and understanding about, how risky is the technologies that we're providing for their children and the medications we're providing for their children as well. So I do think it's absolutely scalable, and we'd love to continue to partner and do that.
Perfect. I think we will continue this discussion because actually
I
can ask you to stay on stage because we will have a panel discussion together right now with different people. So please stay on stage, and we will ask other colleagues to join us right now. We will talk about the collaboration between actually the startup and the ecosystem of pediatric innovation. So please welcome Sofia Ferreira, Innovation Project Manager, San Juan de Deus, Barcelona's Children's Hospital. We have Janine already on the stage, so please maybe take a seat. We have Tomasz Rudolph, the co-founder and the godfather right now of the K.I.D.S Foundation and the CEO of Dr. One. And we have Pekka Kari from HUS, who will provide and who will lead this panel discussion.
Thank you and good morning also on my behalf. So I'm Pekka, working in Helsinki University Hospital. I work with innovation in healthcare and outside healthcare for quite a while, both in the side of the hospital and also on the side of the innovation funding agency. So knowing a little bit the both sides. But after this wonderful presentation by Janine, so we'll continue the topic of knowledge sharing and innovation together with startups or early stage companies, a bit more also in the general perspective. And with here we have Sophia and Thomas on the panel as well. So maybe first we'll start by short introductions of those who've not been speaking yet. So Sophia, would you like to start? Please introduce yourself.
Thank you very much, Pekka. So hi to everyone, good morning. I'm really excited to be here today. I am Sofia Ferreira, I'm an industrial engineer and I'm part of the i4Kids team and the innovation unit at Hospital Sant Joan. And I started my professional career working in a big engineering company, developing medical devices. And I have to say that was great because it was the start of my passion into healthcare. After that, I moved to Qatar. I work in a children's hospital also, where I realized the powerful of being immersed in a clinical setting where you have the contact with the professionals and with the patients, and you really see all the things that need to be improved and all the potential of having creative minds working together and moving projects forward. When I came back to Barcelona, I decided to do the D-Health program from BioCAD, which is based on the biodesign program. And I think that it changed your mindset because you start thinking about needs innovation, needs statement, and how everything needs to be based on a real need. And the D-Health program, I also founded my own startup with my partner, which we are currently moving forward. And I also had the great opportunity to join the innovation unit at Sant Joan de Déu and really understand the challenges in pediatric innovation and moving forward and pushing, to improve things in our hospital. Thank you.
Great to have you on the panel, Sophia.
Thank you.
And then we have Tomasz. Please, would you introduce yourself?
It's a great pleasure to be here today. I've been in the innovation space for 25 years now, started more on the corporate side, meeting the startups, working for 15 years on facilitating the innovation processes in big corporates, which led to setting up of the K.I.D.S Foundation, being the hospital side. We were trying to facilitate hospital as innovation agents in this ecosystem. And I've moved to the other side of the table with Dr. Joan, actually having met my co-founder in the K.I.D.S Foundation. So it's a very special place for me. And yeah, excited to be here today.
Excellent to have you here. Janine opened her presentation with an excellent type of an attitude speech. It's like a can-do. There are things that we can do here, which is like the spirit that is really needed in innovation. Another like a bit of a myth busting I would like to put here is that the question of collaboration between big and small is not something that is uniquely for healthcare. That's a question everywhere. So, and it is also mastered everywhere. So we can also do difference there. But let's start talking about first the main topic of Janine's presentation about the needs and the needs of that early stage companies are trying to solve. How do we make sure, unless the need is really under companies spinning off from within the clinic, how do we make sure that startups are working with real and important needs? Who would you like to start? What are the ways to start with that? Janine, would you like to elaborate a bit?
I love needs, so I'll talk about that. But, I think okay, so if you ask a physician, I'll pick on physicians since I'm one, what they need, they will tell you. It's just never the right one. So never take what they say at first thought, because they need a new NG tube. They need something small and incremental. They're not usually thinking in these paradigm shifting ways, which is what we need to be able to build a business and and actually impact pediatric healthcare. So I would go in that with a grain of salt and continue to dive down deeper. Hospitals, unfortunately, my hospital doesn't tell you what they need, or it's what they need and it's small, but it's not necessarily scalable. So my recommendation would be not to just talk to one physician or one hospital, which I know none of you do, but to really increase the breadth and depth of the places that you're looking at. And you can do things like consortiums and have, you know, hospitals come together and talk about their needs. And it would be wonderful if hospitals did that, because I think then there would be a lot more targeted influence. But also building teams like we do at Stanford Biodesign, where it's not just physicians or not just engineers or not just business people, but being able to combine all of those, I think, is critically important.
Great. Sophia, what do you think?
Yeah, I think just building on what Janine said, so those programs are based on needs identification. I think that they're a very important source. But then I think that we also, and I'm thinking about innovation units in our hospital, we need to support the relation between entrepreneurs and clinicians, no? And probably try to try to change the way we receive startups in the hospital and the way clinicians receive startups. I mean, sometimes when we arrange a meeting with a clinician and with our entrepreneur, they're just thinking, oh, what is this going to sell me, no? Instead of thinking, wow, they are the people with the muscle to solve some of the problems that I'm having, and we have to change the mindset. And in the opposite way, the same thing, some of the startups, they just come to validate that what they are developing, has a lot of potential, instead of being open to be challenged and maybe to change a little bit the way that they are developing the solution. So I think that is something that it's in our responsibility, and that's probably an important thing to understand, that we really need each other. We have our different roles, and we have to understand that we need to collaborate in order to make sure that we are targeting real needs.
I couldn't agree more, because in academia, I've always been trained, industry's bad, don't talk to them. You know, we've really gone the opposite extreme, right? And I'm sure it's hard for you to get into different clinics and hospitals too. So training as a physician, industry's bad, they only want to sell you things. Selling things is bad, but as I was trying to display, that's the only way you actually get things to patients, and we've missed that disconnect. So I think in academia and in hospitals, we really need to divorce the idea that you can do one without the other. They actually really need to be together.
Another important source of important needs could be the patient experience. And Thomas, when we had the briefing before, so you said that your sort of one of the kickoff things was an experience. So tell me a little bit about what you feel about that.
Yeah, I mean, I think experience is, especially frustrating experience, is often the source of innovation. And that has been the case in my personal story of helping set up K.I.D.S, because I had my unsatisfactory experience in a children's hospital, and that what led to connecting other parents and say, let's have a voice as K.I.D.S Foundation and bring volunteers and help children's hospitals with the human capital they don't maybe necessarily have on board, but we have the innovators, design thinkers, whatever, so we can volunteer and help the hospitals define the solutions to the problems that we see. So definitely I see that as a great opportunity to embrace the frustrations and understand them and just see if they are shared, because if they are shared, then we can maybe jointly address. I think healthcare in general is a very tricky industry to innovate in, because the payer, the one that buys, is usually a different person from the person that uses it, and there are multiple users often, then, especially in a complex world as a hospital. Maybe in primary care it's simpler with maybe one or two stakeholders. Here there's a lot of them, yeah, which makes it really tricky, because the person buying something might not have a total clue of what they're buying. So I think especially here, it's super important to be clear who you're innovating for mostly, what problem you're trying to solve, because there are just so many problems to choose to solve. And that has always been the struggle within the K.I.D.S Foundation team. If we are there to to help solve problems in pediatrics and in the experience of parents and kids in the hospitals. Which problems should we solve? And obviously you'll hear today a voice of the kids themselves from the research. We've asked employees, we've asked doctors and nurses, we've asked parents, obviously, and then you need to just decide what is really the problem to solve. I think that's the hardest part.
How about then when the source of innovative power often from early stage companies is some specific technological knowledge, which they are sort of trying to adopt to different types of industries, and that can be a source of like dramatic or radical innovation. But how would you recommend that these types of companies would approach healthcare to making sure that there is a need or they can find a need that their technology could help in?
So this is antithetical to the way I think, of course, as I told you, because I'm really needs-based innovation. And I actually think that if they have a technology, and I work with plenty of companies that do this, they need to go back and validate the true need and really go back to the point of which they're saying, okay, is this the right solution? And it's really hard to forget a solution that you're in love with or tied to. So that becomes very, very difficult. But I think it's critically important in pediatrics because we need solutions that are tailored to our patients. I am so tired of miniaturizing things because I can tell you a 70-kilo man is not the same as a 400-gram neonate. I know I've said that enough times, but like they're completely different and they have completely different needs. So why do we use the same ET tubes, the same blood pressure cuffs, the same everything when they don't have the same needs? So if the technology truly fits the need, great, but it's rare that that actually happens.
Others, do you have thoughts on that? I suppose you've all faced that situation.
Oh,
There's
I'm sure
excellent
we all have
technology.
thoughts.
Yeah.
I think in general, I run a corporate startup collaboration hub called The Heart for a few years, where we were trying to be the table where those meet and facilitating those discussions. And in order for those two parties to actually agree on something which leads to implementations, not just pilots, but long-term sustainable solutions, I think you need to have maturity on both sides. Just like with dating, if one of the parties is not mature enough, it will not lead to a healthy relationship. So I think on the startup side, you need to have that maturity in terms of, stepping aside, not falling in love with your ideas, ability to listen, and so on, like in the relationships. And on the other side as well, if a hospital or a clinician is on the other side, they need to also be open enough to listen, to understand, look beyond the solution itself, and trying to embrace the collaboration. And then magic happens from connecting those two parties. So I think in general, in terms of hospital or clinician side maturity, being open to the methods like your teaching, I think, is important. On the startup side, also improving your ability, partner ability, by learning to listen, learning to understand how to prioritize those needs. Those are not necessarily skills that all innovators have.
Thanks. So you're referring to dating, so meaning that the too big an age difference might also be a problem, like in dating, or would it? It
is often the case that there might be, I mean, here humans, it's a human-to-human process, and obviously age might not be relevant here, but in general, young organizations are not smaller versions of big organizations. They are totally different. So a hospital is a very different creature than a startup. So they have different, even, mortality risk, because startups die like at 70% rate. So it's a very thing. While in a corporate, maybe, I mean, you will lose your job or whatever, but the corporate will continue at least for decades to come, oftentimes, not always. Yeah.
Sophia, would you have any thoughts on this?
Yeah, I just would like to add that I think that nowadays we are understanding how important it is to understand the market from the very beginning. And in most of the startups, there are engineers and techie people who love to create and to design and to build and to test. But really, it's important to understand that we have to understand the market. Is there somebody's going to pay for this? How many people? No, to understand everything beyond technology. And I think things are moving in a good way, because I can see that now some of the grants are providing some financing resources to understand the market, to validate this, to do some assessments, no? And I think it's a good way to understand that if you're developing something, you're developing something that really has a place, you know, to be.
That's an excellent bridge, in fact, to our next topic, which is about implementation. So as we all know, that the journey then to idea into first prototypes, then there's still the implementation part. So how to make sure that things move beyond the first pilot. So what do you think, what would be the ways that hospitals that are very complex organizations and early stage companies could work together to improve the chances of going beyond POCs? Who wants to start?
Well, I can start. I think it's important to understand how the procurement process works in a hospital, and not just by talking to a hospital, because, for example, in Barcelona, it's completely different if you talk to Valls, or you talk to Sant Joan, or you talk to other hospitals, no? So processes are different, and I think it's important to talk to them, but again, not with the vision of selling something, but with the vision to understand a process inside, no? And I think that this also has to be done in the very early stages of the development of the solutions, because it might have an impact on if you're designing a single-use solution, or if you are designing something that needs to be reusable. So sometimes we don't understand the impact of having those conversations from the very beginning, but we should do that.
Janine?
Yeah, I think going back to the Stanford biodesign process, the reason that we map all that out in the beginning is that so that you spend your time on the most compelling unmet clinical need that has the best chance of actually getting to patients. So I'd much rather spend 6 months trying to figure it all out and think about, can this overcome regulatory hurdles? Can this overcome reimbursement hurdles? And your best guess with the best, you know, advice that you can get, then 8 years and find that out in 8 years from now. I think we'd all rather that. So I would suggest you figure that out as much as you can before you've even built a product, which is hard to do.
How do you motivate early stage companies and innovators to do that? Because that's sometimes considered the boring part of it.
Well, if they want to make money, then they need to think about that. And if they want to be successful and get investors, I mean, our investors are very savvy. They need to see a business plan. They need to see a pathway to sustainable business. They need to know that your IP is locked in, that you can potentially get reimbursement, and that it's reasonable. So they just won't get funding if they don't do that. If they want to engage with us, I mean, we would encourage them to, you know, we provide biodesign coaching and other things. And if they eventually don't want to listen, well, then I think that's on their own, but I think they'll be a lot less successful that way.
Tomasz, what are your thoughts?
I mean, there's probably different advice for the startup side and the different advice for the hospital side to get ready and more partnerable. I think on the hospital side in general, having someone that actually has looked and mapped that process and has defined the path and maybe eliminated some of the obvious obstacles, like not even any idea of how to get it refunded or financed or get even the pilot financed. If the startup has to figure out it all themselves and nobody on the corporate side has any clue how to do it, then I mean a corporation is a powerful source of different forces, and those forces are there to kill all the external disruptions of the system, meaning the startup. So anything that disrupts the status quo will be killed in an organization unless it's designed to have an incubation space for those collaborations that help with all those questions, which many startups don't have. So I think on the hospital side, and in all the corporates we've seen setting up dedicated funds, dedicated acceleration teams or innovation teams that are the opening door and help you prepare for those conversations, find the right partner, because obviously you don't even know who to talk to about different things, and then have also international networks or inter-organizational networks to help you connect with the missing pieces challenges that you might have. I think that's a strong ecosystem has that, yeah, and great big organizations which are great innovators are like Silicon Valley or are like Israel. They are very strong ecosystems, not just one-person decision makers. And the last point is, I think no innovation will be done without leaders on both sides that just see the future and can imagine it. And I think from the projects we've seen with hospitals and with innovators, they were all successful because there were great teams built of those two sides.
Picking up on the point of the role of like funding to build it up, I don't know, is this a big difference between the US and Europe, but I have a gut feeling that in Europe there is much more soft funding available, where those questions that are from investors, they are not posed early on. Do you think that this is a topic? Should the funding be like more directed towards really making these early stage implementation and scaling questions a bit more hard, or am I mistaken? Anyone want to comment?
I mean, there are two options. One is to develop the private ecosystem better, to the VC ecosystem, which countries like Israel and Poland recently has done amazingly well, with tens of VC funds being created here and developing beautifully the ecosystem. Or what you're saying is like make the public funding less easy to get, because then they will be forced to think more.
Or link with private.
Or to connect both, yeah. And I mean, we are a venture-funded startup with 2.5 million so far raised in Poland and Germany for our solution. And obviously, the questions we get asked when you have like fundraising round, you have 50 interviews with investors. They keep challenging you, and we as a startup that started with pediatric cohort as our beachhead market, obviously we have been asked, okay, will you stay in this pediatric cohort because it's so small and whatever? It might be a good starting point. So we get questions about scalability all the time. I think the big challenge is to connect those skills in fundraising and in product development and clinical work in the startup team. Because if you have business savvy people and you have great clinicians and great product people building the venture, then you will have what it takes to build not just a prototype or a product, but to build a company out of that.
Can't agree more, but I just want to focus on this idea that this is a small market, because I think we just have to dispel this right now. I mean, 25% of the population is not a small market. They truly are 100% of the future, as James Wall likes to say, so I'll throw that one out there. It's just not small, and the idea is you can capture a much larger market share because there's not a lot of competition. If you're looking at a very niche area of cardiovascular medicine, you might get 5% of the market, something like that, but you can reasonably get a majority of a market in a pediatric space around the world. So we have to change the mindset of people like that. I know that's a diversion, but I think
that asks you to think global, which not all innovators have the guts to initially. You know?
Yeah, or think about it as Europe, or think about it as, you know, different areas, which is why we need to collaborate.
Of course.
Sophia, did you have a...
Yeah, I just want to add that my thinking is that the public funding goes for the initial phases of the development, right? But the VCs enters in a stage where the company is a company, and the process from going to a research project into a company is quite complex. There are legal agreements, and you have to talk about complicated things. You have to create a company, and that's an important step, and it's a difficult one. And sometimes we find ourselves as innovators that we don't know how to do this. And if you have done this before, you know, that's the experience you have, but most of the times we haven't done it before. And then also we have the challenge that some of the research projects are born in a hospital, and then you have to create a private company from that. So that's a challenge, and I think it's just in the gap of going from public to private funding.
Thanks. Let's switch to a bit another subject, the benefit and quantifying and communicating the benefit of a solution. So the startups need to communicate several types of stakeholders. You already mentioned payers or professionals or families. So how do you advise early stage companies when navigating this landscape of stakeholders and, you know, communicating what is the benefit of the solution? Where to focus, what to do? Who wants to start? Thomas?
We all have something to say about this. Well, there's decision makers and there's influencers, and sometimes the decision maker is the 30-year-plus veteran nurse that is at the bedside, and you have to figure out who that is and who's your champion and who's potentially going to knock your technology out before it even gets a start, and it is hard. So first you start with the big. You know, you've got to start with the people who you really think are moving it, but I can tell you that how things are purchased within hospitals, that is a barrier that probably needs to change, because nobody in the hospital has any idea how things get purchased, which is crazy because they get purchased somehow, but we don't necessarily know how. So that just adds a whole nother complexity to stakeholders that I'll let somebody else tackle.
Yeah, I mean, just giving you an example of Dr. One, we built Dr. One to humanize healthcare by connecting the pediatrician or the physician with the patient beyond the visit. So just like a person, like an uncle or whatever, that you can always write to and ask your questions. And because we believe healthcare is a relationship, and it's impossible to have a relationship without connection. And a visit is an invention to organize healthcare, but it doesn't solve all the problems. So when we started to build that, we had to choose whose needs are we optimizing this business for, and as we build the DNA of the solution, we had to prioritize. And obviously everybody speaks of patient centricity, but we saw that in order to improve or make it possible for patients to connect with the doctors, we had to design for the doctor because it's their private time mostly that this was interfering with. If they gave their private phone to a patient just to help them as a person because they felt the system wasn't necessarily solving that need. So we decided we are doctor first, which is actually even reflected in our name. And obviously, we see the clinics, the payers, or the insurance companies, everyone around that problem statement. But we just had to prioritize for a stakeholder. That is our number one focus initially. And then obviously everybody else is supportive in this. But we decided to solve our problem, we had to pick a priority because it's often hard and you can get lost if you try to listen to everyone and optimize for everyone. And I think part of why healthcare is so sick in many countries is that it's optimized for the payer and not for the physician and the patient. So we said, yeah, we'll optimize it for the relationship between the two and we'll make those two happy, and then we'll try to design an ecosystem around them that makes it possible, but yeah, not optimize a system for the payer themselves.
How about then about communicating the value, not maybe optimizing and listening to everybody, but isn't it still important that early stage companies, they think that if when the patients come and or the physicians ask that what is the benefit for my patient, so that they have a response there, or they have been thinking it out, or for the payers. But I understand your point not to like go wherever some professional or stakeholder group says, but shouldn't they, however, think and learn to communicate to different stakeholders? What do you think about that?
Yeah, I mean, I'll just give you the example of Novinate building off of that. So the benefit to nurses is they don't have to make a tape bridge, their patients don't get an infection, and they can remove one catheter at a time. That makes their life better because they're not dealing with tape sticking to lines and then doctors being really upset that they pulled out the wrong line, et cetera, et cetera. So that solves their problem, makes it easier at the bedside. Physicians love the idea that it is sterile, and it decreases infections and decreases migration. But those are two different arguments that you make because nurses aren't necessarily there every single day in our healthcare system, but the physicians are to see that migration over time. So that is a much more impactful meaning to them. But then you have to think about payers. Okay, so, and value committees. We haven't even talked about that a little bit, but we have extensive value committees, as I'm sure you do as well. And what's the value to that? What is the cost to the hospital system of eclampsia? What is the cost to the hospital system of additional line days, of not putting in a PICC line, of all of that? So you have to have all those arguments for all those different groups, if that's what you wanted us to talk about.
Thanks. Sophia.
Yeah, I just wanted to add that we have been talking about impact today, and how the Montana Impact Fund, it's based on the impact. I think it's really important to start working on understanding which is the impact of our solutions, but in ways that we can measure that, no? And for example, this is why we started at the I4Kids. We created a valorization program that there are workshop specifics for startups to work on the impact of their solution. And I think that's very important, and even more important in pediatrics, no? To understand the impact of our solutions. I remember I was in the CRASH program, in the acceleration program with John Collins, and he kept on asking, like, so what? So what? No, you need to be able to answer those so what questions, but with a focus on the impact that you're having on the patient. So I think it's important to try to start working on the impact in a methodologic way, no?
We ask, so what? And then who cares? Because it's really important, but it's also very off-putting to Americans when you say things like that. Yeah. So the students are always very upset when we say that. But it really is, so what and who cares?
Yeah.
Excellent. Then let's talk about the other side of the group, so the hospital capabilities. So what do you think, engaging with early stage companies, it requires specific competencies or specific people from the hospitals. So what should hospitals do in order to better be partners for early stage companies?
I can start.
Go ahead.
I think that the hospitals understanding the need of having an innovation unit, it's an important thing, as we have seen on the report that Faye was sharing. No, in some of the regions, the human capital it's really needed. No, that they need to understand that you need people trained for this. No, so that will be one of the things. And then I know that hospitals, we do have like. We are not moving in the speed of the startups, so we need to find ways to be faster and probably to have some frameworks of collaboration to make those collaborations easier. And I don't know if it's a cultural thing, maybe for people in Spain, but sometimes we bring important discussions at the end of the negotiation. It's difficult to open the discussion on intellectual property, no? But it's a big one. It's an important one, as well as the equity, or how we're going to get the return on investment. So it's important to have clear conversations, transparent conversations, because we are looking for a collaboration, no? And I think that those are some tips, that could help the collaboration of hospitals with the startups.
So dedicated units who know how to take these things forward. Other thoughts?
And just to know how to navigate their own healthcare system. I don't think there's many healthcare systems that have people that can say, this is where you go, this is how you get a clinical trial through, you need to talk to these people, this is how you approach the value committee, this is the form you fill out. I mean, having a startup figure that out at every single hospital, especially in the pediatric space, is impossible. It is truly, it's possible because we've done it. So I would want to stay on the positive side. It's totally possible, but it's totally unnecessary. It's a waste of time and energy and effort, and hospitals need to figure that out, including my own, so.
But these services are there often, but they are reserved for internal researchers.
Internal researchers, or they're so fragmented that they don't talk to each other. So, you have to have a point of contact. You have to be able to do that, which is kind of why we decided to do Impact One very much outside of the hospitals, so that we could move fast like startups and not be slowed down by the hospital system, and insert where we can.
Picking up on a comment, Thomas, you made earlier about that big organizations are excellent in killing anything that is disruptive. So as a logical thinking based on that argument would be that, no, you don't need dedicated innovation units because it makes things visible. Rather, you go under the radar for as long as you like. What do you think?
I think actually,
provoking a bit.
If you look at the most forward-looking hospitals like Sheba probably, or the many of US, but also the Polish pioneers here in Central Europe, I think it all starts with understanding the agenda of the leaders, and if the leaders are visionary, you can find some priorities, like being the top hospital that's visible, that's talked about, that gets more money, that gets new funding for new initiatives, whatever. I think there are needs of the board that you can address with innovation, and if you, as the innovation leader, can address them and can communicate how our unit or activities will help you solve this, then you get top management buy-in to actually do initiatives, great initiatives like we are seeing here. So I think a key thing is to listen to the leader, read between the lines, what are the priorities, and create an agenda for an innovation unit that will be impactful, be it on the bottom line or on the quality metrics of the hospital or on its PR activities or funding or research projects that it's winning, and then just to build projects that address the patient pain points or that help you win. And I think anybody that has ever sold something to a corporate has identified that you need to build coalitions, you need to understand the priorities and package your innovation in branding and wording that actually is appealing to the decision makers.
So top level CEO support or strategic view that this is wanted and possible and beneficial in an organization. How do you do that? In like many hospitals are in at least past few years been from crisis to crisis. It's like COVID, it's like wartime, it's like anything. How do you do this in the times of turbulent things where it seems that organizations tend to focus, on their core thing, and innovation might be something that is in the fringes? What do you think about?
I can share one tip from the practical side, from the startup side. When we were trying to pilot Dr. One, and just to get credibility in the clinical world that our method of working with patients is actually appealing, it was very hard to go through procurement or processes in hospitals. So we actually joined forces with a stronger brother or mother or whatever, or sister, be it pharma, and we said, okay, we'll join forces on a joint project that pharma will push because of their priorities, and we will jointly propose it. And a project that was hard to implement in one hospital, like that, could be implemented in 6 hospitals because it came with an ally, and we came with the credibility and money and of an ally. So I think you need to build coalitions, be it international coalitions, because, okay, this is an international project with other children's hospitals, or this is an EU-funded project, or this is a project with pharma, or this is a project with someone else. If you are a young innovator with little influence, you need to borrow that influence from someone that has it.
Excellent.
I love that.
Excellent. Other comments, Sophia or Janine?
Yeah, I can add something. I think that they need to understand, the C-suite of the hospitals, they need to understand the value of the innovation, and to that, they need to understand the process, and that it's not going to be super quick and super fast, and it's going to be, you need years to do that, but it's going to have an impact. And also, I think that engaging people in the hospital, you break their routine, the clinicians and nurses, they love to be in co-creation sessions and think about what they could improve. So I think it's important to create this culture of innovation in your institution and educate them, because everybody can bring a lot of ideas to what we're doing.
Excellent, thank you. I liked how you genuinely put the question of the market. So it's not a small market; it's a big market. But maybe we are agreed that it's fragmented. So it's like, so how could we reduce the fragmentation? How could we sort of make it more like a unified market? Who wants to? Janine, go ahead.
Well, Sophia and I have been chomping at the bit to talk about our own collaboration and why I'm actually here today, or why I probably was invited by you. So I think that collaboration is really important, and not just looking at it as US, or not just looking at it as one country in Europe, but actually making those cross the pond collaborations as well. And so we have an awesome, very natural collaboration that we've developed where we have innovators forums, and she brings companies to present to my team, and we should bring companies to present to your team.
Yeah, of course.
To get into the European space so that they can understand what's going on in the US and access our patients and our experts, as well as vice versa. And so we meet monthly, and it's absolutely lovely, and we all are learning throughout the process as well. So we really appreciate that. But you can elaborate on it.
Yeah,
It's
I mean,
much more than that.
So yeah, as Janine said, the collaboration started very naturally, and I think it's great because we have the opportunity to connect the startups from the i4Kids to the US ecosystem, to understand their regulatory pathways. The Impact One has an amazing thing, is that they are able to connect their startups with the FDA, but in a private meeting, let's say, or no?
Like a chill private meeting where you can talk about anything you want.
Exactly, they can understand the process, no? And they can also bring projects in the US that are interested in entering the European market, no? So I think it's a great collaboration. Always, as we said before, you need to talk to professionals, not only in your ecosystem, but in other places, and that also gives the opportunity, you know, to connect people from different places, which is normally very difficult. So I think collaboration, it's needed, it's really needed.
And people are nice in pediatrics.
Yeah.
We just want to
Much
help our
nicer.
patients. So it's a pretty great space to be in.
Tomasz, any thoughts?
I mean, I totally agree. And within the K.I.D.S Foundation, when we were building it, as a group of volunteers, none of us is working in the children's hospitals, but most of us being parents and having experienced this and just working in business in different spaces, we thought, I mean, how can we influence and have the hospitals collaborate, because the challenge is shared among the hospitals. Sometimes there is some competition even between hospitals or physicians or whatever, but we are there from outside looking at this as patients and their parents, and we want the system to work. So what we did with K.I.D.S Foundation, besides running projects that are changing one area or the other, we run surveys that are making the need statements clear. That's one. Secondly, we are organizing awards that create a positive competition among hospitals to share their best projects and learn from each other, which is actually happening today for the third time with the K.I.D.S Awards for the best children's hospitals innovations, because we thought if we bring the directors and the innovators together, they'll learn from each other, they'll feel stronger, and we'll start building that ecosystem and that movement. And we're so happy after the first event, first edition of the awards, where we saw that actually, I mean, it's a small world, but we saw that they didn't know about each other's innovations among those hospitals. So making those connections, I guess, on a local level, even in Poland itself, was meaningful, but making those connections internationally among the startups doing this, researchers or physicians innovating, the innovation units themselves, but also the directors and heads of hospitals on the topic of innovation, I think is super important.
So to conclude, so it's all about also building relationships and also building relationships between individuals. So people, you know, people who know each other and see that this is something that you can work together, super important. We had our chairs there waving that I think we should be stopping, but for the final lightning round, so what would be your one takeaway for any startup or hospital for the closing of the session? So Tomasz?
I'm staying here saying no. I gotta be the policeman. And Tomasz almost wrote a book. He can talk for hours. So we really are
Never
out
doubt
of time.
that a group of committed individuals can change the world. In fact, it's the only thing that ever has. So just connect and join forces and just do it.
Team sport.
I don't know what to say.
No pressure, no pressure.
No, I just want to say that there are excellent professionals in this field, and just take advantage of the expertise of each one of them.
Excellent. Thank you very much for the conversation.
Thank you.
That was perfect. Thank you, guys. Sorry for being the policeman here, but we... Exactly. Someone's got to be the bad guy. That's me today. But we have the next keynote waiting already to present. Our next session explores expanding access to pediatric imaging with technical innovation and enhanced patient experience. We have together with us our next speaker, Ariel Stalder from Siemens Healthineers, and he will share his valuable insights.
Hello. All right, thank you. It's fantastic to be here today. I'm one of the few folks dedicated on pediatrics within a larger company like Siemens Healthineers, and I can relate to a lot of the challenges we've been discussing this morning. For example, just like competing with adults' application to get innovation funding, that's very same problem I'm having on a daily basis. So today I want to tell you the story, and this story is how innovation, both from a technical perspective, but actually so important from a patient experience perspective, are currently changing pediatric imaging. And for that, I will take one modality as a leading example, but it applies to more modality. And I will take MRI as an example. So if you're not familiar, this is what an MRI looks like. So you have like a big magnet. This is for magnetic resonance imaging. And you have some antennas in there. They will measure like some signal from the body. And what does it mean for a patient? That means it's non-invasive, it's painless, it's no radiation, no X-rays in there, but it's loud, long, and challenging for some patients, especially for kids. So let's start with some numbers. We were having the first number already a couple of times this morning. A quarter of the world population is below 15. But when you look at the MR examination performed in this population, this only accounts for 3.5% of the MR examinations. So you see there's a great imbalance here. Here this imbalance has two reasons. The first one is a regional imbalance. The poorer countries have more kids, they have a lower MRI density. So that's one of the problems. The other aspect is, even if you look within countries, even if you look within richer countries, the kids simply get much less MR examinations than adults. And if you look at UK, France, and the US, here you can see the number of MRI exams per year for 1,000 inhabitants, in children in orange and for all ages in green. And you can see that children in these rich countries get about 5 to 8 times less MR examinations than adults. And I mean, I think here in this audience, you all know all the problem of the adults and of the kids, and you know the problem of the access to care for them. But in some other rounds, I really need to justify, because some will tell me, oh, the kids are just healthier. They do not need to get these MR examinations. And it's hard to really show with numbers. But if you look at this disability adjusted life years lost estimates, you can see that the kids between 0 and 9 years are actually they have a comparable daily compared to the population between 25 and 49 years. So it's not that the kids are just much healthier, they do not need these examinations. Actually, there's another reasons behind this. And this is what I call the pediatric MRI vicious circle. And it really all started when you look back at the technology a few years ago. The MRI examinations, they were long, they still are long often. That means the kids cannot stay calm for this duration. That means the consequences, you need to perform sedation or anesthesia to scan these kids. You're automatically reducing the benefit of a risk ratio because of this sedation. And eventually that means there's fewer MRI cases that are scanned, and you only do this for the most severe cases that absolutely need these MRI examinations. And these are as well the more challenging scans that take in turn longer to scan. So all this leads to this vicious circle, and it means there's fewer MRI examinations in kids and a worsened access to MRI for kids today. And this was completely true in the past, and this is unfortunately still a reality in many places, in many countries, but this is still valid today. And let's look at two MRI systems, one from 20 years ago and one from today. And if you just look at these pictures, you will say it looks very similar, actually. You still have like one big magnet, you have a patient table, you have some buttons to control this table, you have some screen, smaller or larger, but the design changed, but it really looks very similar. But it's a bit like underestimating what happened in the back in the technology change in these last 20 years. And just taking one example as comparison, look like the first iPhone and iPhone today, it's the same touchscreen, camera, some application, you can surf on internet, but what's happened in the back has really been a game changer. And nowadays, for example, cameras, traditional cameras have almost disappeared because everyone is using their cell phone for that. So if we look at the MRI, it's a bit similar. And here, looking at these two systems back 20 years ago, the Avento system, and it was a revolutionary system for its time. It's been a bestseller for more than 1 decade. And when it was introduced, we were like advertising 12-minute net imaging time. And that was really fantastic for a basic brain examination here. Not something complex, something very basic. But today, with a lot of innovations that happen in between, like a trend toward higher field strength, that means more strength of the system, or using more channel coils, just like in your camera, you have more megapixels. We are using more channels in measuring the signal in the MRI. That means better images, and as well acceleration techniques. And the latest one being AI-based reconstruction techniques are really helping to drive to be much, much faster today. And today, we are doing this advertisement with 2-minute net imaging time. So you really see this factor 6 in the change we roughly had. I mean, this is not one-to-one comparison, but it's really wanting to show you what's the trend. And it's not only with my company, it's like all the companies are trying to follow this trend. We are no more where MRI was 20 years ago. And this is really a game changer for kids. But technology alone is not enough when you're working with kids. And there has been a lot of things happening on the patient experience side, on the innovations. And it's really started around 2016 when the FDA issued a warning against using sedation in younger kids due to some concerns of our brain development issues. And they didn't say you cannot do it, you should not do it, but they said you need to weigh the risk and benefits by doing that. And this triggered a lot of research and activities about what strategy you can take to get an MRI with kids without using sedations. And people have been extremely creative, really developing some best practices of how to perform that. And just to show a few examples, this starts like before the examination, where the kids are still at home with some audio books, videos, to educate the kid, to introduce MRI in a playful way, in a fun way, but to educate the parents as well, because they play a very important role. This continues when the kids arrive at the hospital and before the examination with having, for example, some mock-up system, here a small one, but some are like larger, or even some hospitals are using like full-size replicas of an MRI system so that you can introduce the MRI in a fun way. The kid can play with it, can see what it looks like, and get less scared eventually. Even during the examination, like making this MRI like looks nicer, nice decoration, appealing stuff for the kids. These are all essential stuff. And on one thing, that's this images down there, having an audio-video entertainment system that the kid can watch their cartoon while doing the MRI examination. It's really like fantastic. There are small things, but there's really like a game changer. And after like giving a reward for the kids, that's for example. All this is really like having a patient or like family-centered communication that's really like essential at making this successful. But it's working, and all this publication is showing this working, on more and more hospitals are following this way. That means we have this vicious circle with the long MR scans. The assumption kids cannot stay calm for this duration. So now it's no more really valid anymore. So the MRI scans do not need to be always very long. And with good preparations, the kids can stay quiet for the duration of this MR examination. That's not going to be always true. There are some kids, some age categories between 1 and 3 where it's very difficult. Some kids that have some development challenges, that's going to be very difficult. It's not going to be always true, but this can be broken in for many, many kids. And that's turned this vicious circle into a virtuous circle where these MR examinations are fast. That means the kids can stay calm because we prepare them nicely. They have a nice environment for the scanners. They don't need this anesthesia or sedation anymore, and that leads to a higher benefit over risk ratio. And that means that more kids can benefit from an MRI. So the situations where a kid hurt his knee and the parents start to think with the pediatricians, should I get an MRI system or this, or let's just wait and see, maybe there's no complications. They start to say, oh, let's do it. Now we know that our hospital can reliably perform MRI in 6-year-old kid without sedation. That's really a game changer. And that leads to an easier patient mix for the hospital doing this MRI, and which again establish that this is possible to do a faster MRI exam. So at the end, it's better for kids because they get no sedations. It allows better access to MRI because more kids get a chance to get an MRI, and all this is cheaper actually because the sedation team is really, really expensive. This started already a few years ago, but Boston Children's Hospital is, for example, really one of the pioneers in these directions. And they have been able to reduce their sedation rate from 55% back in 2007. That means most of the kids in the lower age were just getting sedations, to 15% in 2020. And that's really a huge, huge change. And without going so far away, this is like a smaller hospital in Germany. They only have one MRI system. They always had only one MRI system. And you can see when they started to shift toward non-sedated MRI around 2019, they really were able to increase a lot the number of kids they could scan with this one very same MRI system. And all of this is, if you look on the right side, the black, you see that the sedated kids, they remain constant all the time, but all the growth was with having non-sedated kids where you can be more efficient and scan more kids and have more kids that have an indication for MRI. And another great example is Finland, and they have some great statistics, and they could show that between 2008 and 2018, they were able to multiply by 3 the number of MRI examination in kids. And that's a lot of this is related to performing non-sedated examinations too. So with that, I would like to come to conclusion. So I hope I could show you that really innovations, both on the technological side, but equally important on the patient experience side, are really driving this deep change in pediatric imaging, where it's moving toward a sedation-free modality. It's better for kids, allow better access to MRI for kids, and at lower cost. It still brings some challenges. It really needs trained staff. You need staff that get used to do this, to perform this without sedation. That's not easy. It needs sometimes some additional infrastructure, not like an additional MRI system, but just like these audio-video entertainment systems. That really makes wonder. It needs new workflows, and that's really a big challenge. A lot of hospitals still have workflows from 10 or 15 years ago, and it's really hard to change them. It needs educating the referrers. If the referral doctors do not know about this, they don't send kids. And it needs new reimbursement rules as well. And this is very, very hard to change. But unfortunately, in many countries, we still have the situation where an hospital will get some reimbursement to perform a sedation. They will get money for that. But they will get no money to invest in an audio-video TV for the scanner, or to spend more time with the kids to prepare them to be able to run an MRI without sedation. It's cheaper for the healthcare system, but some countries, hospitals are losing money by doing this. This is really a problem. And with that, if some of you are interested, we have some pediatric experience resources, multimodality. You can just Google for this or scan this QR code, and thanks for your attention.
Thank you, that was amazing. While I was actually hearing this, I could imagine this Lego sets, with the MRI scan, like for the children, or a Barbie doll who is a doctor who can do the MRI, or a Spider-Man. How many times this guy needs to have a CT scan, for example, after all the fights he has? So that would be actually also educational part. And now we can see something serious is coming. The first row, everybody has a laptop. Those people look serious, like serious faces. So it's gonna happen right now. The EIT wildcard contest final. And the best one to actually explain what is this and what we're going to have in a minute is Sielska-Bielska from EIT Health. So please join me here.
Thank you, Jakub, for the warm introduction. I appreciate it. And thank you for the panel for being here and the startups and everybody joining us from here and from home, hopefully streaming in. As Jakub was saying, I'm here to explain you a little bit. Maybe you're hearing about the startups, you're interested in the pitches, but you're wondering, what is it that is the wildcard program? And I want to explain it in a way that it says wildcard program is almost 2 words. I would say wildcard is a concept, and then program is the second one. And I would like to start, yes, first with wildcard. So if you think wildcard in different industries, in different areas, it might mean slightly different things, but we all understand what it is. And first, I would like to just focus on where the concept started, poker. So in wildcard, a wildcard in poker is a card that can take any value. So it can be anything, it's unexpected, it's unpredictable. Second thing that I wanted to mention is, like in North America, in baseball, there's something called wildcard series. This is when top teams in the league fight against or compete against maybe lower scaling teams. They give them a chance to sign, and sometimes they are unexpectedly the winners. So that's also a wildcard. And in programming, going technical, a wildcard character means a character that can take any value. So if we look at that in the keywords that I take out of all these concepts, I would say first, wildcard is unpredictable. Second, a wildcard might be an underdog. And third, a wildcard is powerful. And all of the things that had in common, and we've been were many times throughout the presentations and the panel discussions, a wildcard is disruptive. And something that is disruptive is impactful. So when we talk about the wildcard, and then I'll go to the program later on, we're looking for things that are impactful. And in this case, this year, we're looking for things that are impactful in children's health. But what do we do, and what is this about, and what is the program? So what we do is we construct open innovation challenges in which we collaborate either with industry, hospitals, the network to find out unmet needs that we could foster innovators to actually solve these challenges and to help them accelerate the solutions to hopefully get adopted and get into the market. And as I was saying, and why is it a wildcard, is we're looking and putting the scope of an under-innovated or under-invested areas. And as I was saying this year, and why we're here, is we're focusing on children's health, which we've found that the pediatric community has been a very welcoming one for us in this whole journey. And I would like to thank Sant for the collaboration and to let us be here in this stage with such a motivated and people-driven community that wants to make an impact. So, but a little bit of that is how we got here, what is our history, not throughout, but this year's program. So I would just like to start with how did we get to pediatrics, right? Where was the challenge selection? And as my our director of Accelerator, Magda Krakowiak, was talking a little bit, if you were listening at the beginning of the presentation, with Association of Partners. And what we did was ask our partnership, what are your needs? What are you thinking the ecosystem needs right now, and so on. Pediatrics sounded strong. And this is why we started for this one. And we partnered with Sant in the whole landscape. And you can see here a picture of my colleague Maria Sanchez in a not so sunny, much sunnier day than today, a year ago in the Pediatric Innovation Days, announcing this collaboration. So we've gone a long way, we've done a lot of things, and we're very happy to be here. The next step that we did is to do workshops to shape this challenge, to see what are the real unmet needs, because pediatric is a small word in itself, right? It's a small word for the small people, but not so small as we've heard not so long ago in the panels. So that was the first step, and we've consulted and done many interviews and workshops with different stakeholders that are involved, so industry, hospitals, experts, regulatory, and also patients. So we've been collaborating as part of our collaboration with Sant Joan de Déu with the K.I.D.S Foundation, in which we have kids that are training in clinical trials and innovation to be able to put a little bit of their input into what is created. And we wanted to make sure that we had that perspective when we defined the challenge. And yes, here we have a picture of the workshop in which the kids participated, and we are lucky here today to have two of the patients representatives to do the evaluations today as part of the panel. Then what did we do next? So as anything, we selected companies. We selected 16 companies that started in the, or hopefully they wanted to start in the 5-month journey of the wildcard. Very intensive one, very arduous, but hopefully very worth it, and you will see the outcomes very soon. Then that started with a deep dive in which we involved more than 25 clinical and business mentors to support the startups in a very fast-paced, meaningful way, in which we came from the 16 companies that I'm saying right now to the 7 finalists that are today here with us, and that you will get to know very soon. So that was during the business model validation. This was an 8-week thorough program that we do in collaboration with the CRASH program that Sophia just mentioned very few minutes ago, and with John Collins that unfortunately couldn't be here with us today. But that has been instrumental throughout all the years, the 5 years of the program, and in this edition as well. So that will take us here. But I would want to talk a little bit more about what made special Wildcard this year. What is particular that we didn't have before? And I would like to say that it was driven for a single focus and a single challenge. Pediatric is its own universe, and therefore it couldn't be served with anybody else. If you know that from past editions, we used to have 2 challenges every year, and we decided to make it our single focus. It's our first edition collaborating with a healthcare provider, Sant Joan de Déu Barcelona Children's Hospital, and their unique Eye for Kids. And more than 16 clinicians and Sant Joan de Déu Barcelona Children's Hospital personnel were involved. And you can see their faces there. Not all the names are here today, but we would like to express our thank you. And before we move to the next, I would like to invite Arnau to the stage to share a little bit about the experience and how it has been so far. Thank you, Arnau.
Thank you, Celia. And as you've said, that's been an incredible experience. And first of all, thank you very much to EIT Health to allow us also to be partners on this. We've been learning a lot, not only from the huge experience of all the EIT Health and Wildcat program, but also from the mentors and all the people that are involved in this project, and also from all the startups, the 16 participants, and the connections that have been created in between the hospital and those innovators. We've been talking about those challenges, and I think that thanks to programs like that, we can impact and go beyond the frontiers of the hospital, get to new innovations that can tackle really the real unmet needs that we see. So I think it's been an amazing experience.
Thank you so much, Arnau. I wanted to ask you a little bit through the whole experience and what you were thinking before when we started the collaboration until now, what most has surprised you, or what do you think it was the biggest impact that you had when collaborating with us, but also with the companies and the startups participating in the program?
I think one of the main learnings was and impacts was to see the evolution, and that is possible. In that case, I think most of startups were open to get the feedback. Mm-hmm. When you provide the sufficient and the environment to create this conversation in between the ones that are on the first line of the field, that really know the unmet needs and that have to be working on that, and those that have a value proposition to solve those solutions. So this conversation, how it was created and possible thanks to a program and an instructor, I think was one of the main learnings that I've seen.
From our side, we were very happy to see the involvement of the clinicians and everybody in the hospital, very motivated and very driven to help the startups. And I think it has added an extra value that wouldn't have been there otherwise when all the other times that we've done this many times, but it's a different perspective when it comes to the hospital, and I think more collaborations on this sense that bring us closer to the adoption, and the impact is the way to go. I don't know what you think about that.
Absolutely, absolutely. And here we had the chance to bring together all the different stakeholders. So having the mentors, those people with experience that have gone through the process many times and that have seen many experiences, those that are now starting or that are, again, bringing new innovations, but also those that are on the other side and that are working every day with that, and also the patients with the kids also that can provide their perspective. So it creates this great movement of quick validation, this agile way of working that I think should be definitely repeated, and yeah, I hope that more programs like that can be brought and built in the future.
Thank you so much, Arnau. I really appreciate your input. Thank you. So we talked a lot about what we do and the collaboration and what we've done, but the spotlight is on who we have here today, which are the wildcard companies and our panel sitting down. And I would like to introduce you a little bit of this mentioned panel. So first, I would like to say we have 3 investors in the room. We have Marc Ramis, that is been introduced before with Montana Funds. We had Austin Sawyer from Nina Capital, Sergi Serrano from Capital Cell. We have our own representative, Christina Hertel from E.I.T. Health as Head of Asset Management and hopefully investments to come from E.I.T. Health. And then we have Enric Barba from Sant Joan de Déu, and is an i4Kids advisor. Thank you so much for being here with us. And also the kids. So we have here Ricard Casanova and Daniel Marin that are here to provide their perspective also on the projects. So I would like to then thank also the team. So we are with whom this would not have been possible. So we have here Sofia Florida that you've seen very recently, Arnau, myself, Alessio, that has been instrumental as well, and Maria Sanchez that's also been collaborating. So kudos to the team. We made it, we're here, and hopefully there will be a lot of good things coming through later on. And last but not least, and not least important, the teams. So the teams have done an arduous work to come here. We are only enablers and amplifiers of the work that they put in. So this is very important to mention. There's been 25 hours of mentoring, 16 hours of lecture, but the real time has been on the work. And we put 400 hour plus estimated work, but probably it's more. We were not clocking in the hours, but definitely we know this is tough and this is very hard. So kudos to everybody here for all the hard work. And now I have a question for the audience, and I'll pass it on to Jakub to introduce the teams. But are you ready for our innovators? So thank you very much for listening.
Perfect. So as the classics say, let's get ready to rumble. We have 7 startups. I'm going to be pretty strict. Every startup had 7 minutes, but we are in the delay, so you have 4. No, you will have 7, don't worry. You have 7 minutes for the pitch presentation, and I know you're really good at that, so I don't worry about that time. After the pitch presentation, we have 6 more minutes for the questions, but only from the first row. I know that you people in the crowd would like to ask some questions. No, only these guys, these special people right now in the first row, have the ability to ask questions today. But don't worry, we will have a question and session after or during the lunch. So the first startup I would like to introduce is a startup from Belgium, and it's called Innocence. That's a young startup with a solution that uses predictive AI to protect the most vulnerable newborns.
Good morning still, everyone. I'm David van Lara. I'm the CEO and co-founder of Innocence. And this is me in the picture, taking care. I'm a former neonatal intensive care specialist, taking care of preterm infants in the University Hospital of Antwerp up to a year ago still. And these kids are very special kids. They're young, they're vulnerable, and we need to guide them through their first months of life, but they're not sick. They get sick from time to time. There are 400,000 newborn infants in Europe being admitted in the neonatal intensive care unit every year, and 60,000 of them will get a bacterial bloodstream infection called sepsis. And compared to their peers, their mortality risk doubles, and even if they survive it, they have a risk for a lifelong handicap. Their length of stay in the unit will increase significantly by on average 19 days, and costs will rise with every sepsis episode. Yet sepsis is treatable with IV antibiotics, but timely detection is key for a good outcome. And that's where the problem lies, because sepsis presents in a neonatal intensive care unit with very subtle signs that are easily overlooked. The life of your kids depends on human caregivers that are experienced. And I mean these caregivers take care of multiple patients at the same time. At night, staffing changes. There's less nursing and doctors at night. And usually when a nurse picks up this disease, she can't decide to start antibiotics. So there is this hierarchy in decision making. And if you wait too long with this disease, if this disease progresses too far, these kids are going to die. And I've witnessed that on many occasions. And if you look back into the data of these kids, you could often see patterns changing that were clearly there, but way before we even detected that sepsis. But you can't see these patterns looking forward. And so we used the full data potential that we had, more than 30,000 NICU days with minute-per-minute data, and used machine learning techniques to catch these patterns. And we were able, with our machine learning model, to detect 81% of severe sepsis cases, with 2 to 11 hours faster than the golden standard of suspicion, with less than 1 warning per patient per week across all thresholds. But we all know an algorithm doesn't save lives. So we've built IntelliSense. IntelliSense is clinical decision support technology that will warn clinicians as soon as these aberrant data patterns arise, because that's what clinicians need. They now have an overview of all their patients, where they can look when an aberrant pattern is there, when a patient is at risk for sepsis. But moreover, if they click on a patient, they can see the model output and every signal that contributes to that aberrant data pattern. It's explainable AI. And this is how we do that. IntelliSense integrates in your existing infrastructure. No need for new hardware. We use existing data streams, and every half hour we will compare those data streams, process them with the machine learning model within our software, and then provide updated risk predictions for sepsis. 24/7, day and night, never gets tired. So we've implemented this in 2 hospitals now, and we've done an implementation study in the University Hospital of Antwerp. And this is one case, a 27-weeker, presenting with sepsis at day 7. It took us 10 hours before we started antibiotic, after the nurse raised suspicion 10 hours before. That's the hierarchy of decision making. And after implementing IntelliSense, we saw in a similar case of a 26-weeker that care process was way accelerated. It only took us 2 hours. And so this needs to be validated in clinical trials, whether that translates into better clinical outcomes. We are focusing with our solution on highly digitized NICUs with DRG payment systems in the northwest of Europe. And these are 3,100 beds that we will focus on for a market share of 7.7 million euro. Our pricing is based on our competition. We charge 7 euro per bed per day. We have one-off installation fee of 10,000 euros, and our costs are 5,000 euros for installation and about 11,000 euros per NICU per year. And as I mentioned, we focused on hospitals with a DRG payment, because these hospitals are financed with a lump sum for giving treatment to a patient with a certain diagnosis. And so they're upfront paid. And so if the care efficiency increases, they retain money. And because sepsis is so prevalent and it adds to so many additional length of stay, if you could detect it earlier, potentially you could reduce that length of stay. And we calculated on real financial data, the reduction of 1.5 days would make that solution beneficial for hospitals. And we validate this with multiple CEOs and CFOs of different hospitals in Belgium and Holland. We're going to market in 2026, focusing on integration in 16 hospitals. First, sales increment by 20 hospitals in 2027 to up to 32. We need 36 hospitals to become profitable. Our gross margin is about 81%, net margins of 31%. We're currently in a stage of proof of concept. We're running a pre and post implementation study. We are going to a release of a software version 1.0 with all the ISO standards needed. We're doing validation of our model with several hospitals across the EU where we have access to data, and we're going to onboard in different hospitals to really start doing large clinical trials and showing what we need to do. So what we need at present is we've already raised almost 1.1 million euro in 2023. We now need at minimum 500K euro to reach cost until the end of 2024 for the additional regulatory compliance, to do our first pilot trial, and to increase our operational team. So these are our competitors. We have Hero, that is an existing solution with less sensitivity. They use one sensor, higher false alarm rates compared to us. We have IP that is secured, and we have a trade secret.
That's 7 minutes, so thank you very much.
Yeah, okay.
I gotta be strict because the rest will follow. So if we're gonna be, you know.
No worries. Okay.
So yeah, thank you.
Thank you.
Sorry. Now we have a 6 minutes Q&A session.
Sorry.
So don't worry, stay with us for the next 6 minutes. And we're going to be pretty strict about those 6 minutes as well. So please, the judges, start.
Yeah, one question I had was, how early do you have to catch sepsis with antibiotics? How early do you have to treat sepsis to actually have antibiotics be effective? Part one. And then part two is, how long would it take the hospitals to recoup the price of the software? How many hospitalizations would they have to prevent for them to be profitable or actually be saving money with the current pricing?
So we don't have data on how early, there's never been data out there on how early you have to give antibiotics. There's a real clear medical publication showing that every half-hour delay of antibiotics between diagnosis and treatment increases the risk of poor outcome. That medical evidence from a level 4 NICU is out there, but there is no actual data on the care process and the impact of such technology because it just doesn't exist. We haven't measured that. And so DRG payments, that is where we know that if you have a NICU with about 30 sepsis episodes per year, and you could reduce the additional length of stay by 1.5 days, in a 40% DRG payment financing, it would become profitable.
Just a question on the treatment that follows your prediction. Are you incorporating also what kind of treatment, or you always treating in the NICU with broad spectrum antibiotics?
Yes, we do.
Okay, and that normally the standard of care, and
that's the standard of care.
Okay.
You start using broad spectrum antibiotics until your blood culture becomes positive, and then you narrow down your antibiotic treatment.
And do you see the potential of your technologies basically to skip a step, so you would know what kind of bacteria you should target based on the symptoms?
Yes, that would be possible, but then you would have to build a different model. So this is an early warning model. If you want to go into a diagnostic model, you have to use different parameters and different signs, and then
well, maybe a diagnostic support tool.
Exactly.
And then my second question is, can this scale, and probably this is the wrong forum to bring such a political question, but can this scale to an adult population and then?
Yes, absolutely. So not with the same model, but with the same technology. So everything in medicine is about time.
Yes.
So everything is time dependent if you want to improve outcomes. So yes, but
okay,
the answer
but then
is
my
really
second question, sorry for taking too much time, is the data you collect in this model, will that support the development for expansion in another adult?
The know-how does.
Okay.
It's similar data, but the know-how is dependent on the cross-domain, medical domain, into the technical field doing that.
Quick questions. Congratulations. First one, I need to understand the rationale on your fundraise need. So you need 4.3 million, but then you are pitching for 500,000. Why so?
Because we finalized the first seed round in February 2022. We want to increase the value a little bit more of the company. So we want to top up currently what we have to really reach a next point where we want to do a Series A pre-commercialization, get into sales, prepare sales, and then have a higher valuation at this point in time.
Second question, this data is based on the standard of care. Do you think the novel new generation of antibiotics, how sepsis is going to be treated in the next years, and how this is going to impact on the incidence of sepsis as well, how this is going to change on your technology?
I mean, treating sepsis doesn't prevent sepsis. It's always going to be there at this stage in time. So I don't see there anything changing. What you need to know is that a lot of units don't even have access to real-time data in an electronic medical record. Still, nurses write down a number every hour in the electronic medical record. Let alone that they currently can see the insights that we can provide them. So yes, we will still be earlier for a long time to come.
Thank you.
Well, thank you, and congratulations of the project. I think that they made a lot of questions that I want to do. The only thing I want to know is who is the team, and
yeah, unfortunately, I didn't get there.
I think that was the last slide.
Yeah, so we have a team of clinicians, machine learning engineers, front and back end software developer, and a customer developer who's currently operational in the team. We are a spin-off of the University Hospital of Antwerp and University of Antwerp. We use technology of IBM, and we work with quite a lot of hospitals in Belgium, Holland, and then also in the NHS. But we have a 4-man team currently working full-time in the venture, but also focusing on our sales trajectory already.
And another question, the sensitivity that you have here. How many patients you test to take the sensitivity?
So this is trained on 30,000 NICUs of almost 900 patients. But it's 30,000 days with minute-per-minute data that we carefully enriched. And so we're doing almost the double amount of data that we add from other centers to validate the model on. So it's not only the patients, because patients stay for a very long time in the unit, but you need to have access to 50 days worth of data from every patient with minute-per-minute data in there. And that's not easy to find, let alone that data set is really well cured and that you get the value out of that.
Thank you very much. So we made it just in time, so perfect. Now we have a second startup. That's a startup called Joan team from, First of all, I wanted to say, of course, best of luck to our guest here who just presented, and then I wanted to introduce another team, Joan Life Science from Ireland, who will present their project, also focused on neonatal care, right? But just this one in biotech, I think.
Good afternoon, everyone. We are here on Life Sciences. We will be presenting on an intranasal cell therapy. So welcoming a new baby is a wonderful time for families and for parents, but unfortunately, it doesn't always go smoothly. Some babies suffer complications from lack of oxygen to the brain due to the birth itself or due to the pregnancy. This type of newborn brain injury is called HIE, or hypoxic ischemic encephalopathy. It is one of the leading causes of infant mortality and lifelong disability globally. including high rates of cerebral palsy. HIE is considered an orphan rare disease, and unfortunately, despite many advances in neonatal care over the last number of years, no approved drug therapies have been developed. The current available therapy is therapeutic hypothermia or cooling, where a baby's body temperature is lowered to limit the damage done. But unfortunately, while this works for some, it doesn't work for many. We are developing a treatment to give these babies a fighting chance. K.I.D.S, our solution, is an intranasal cell therapy that is easy to use, developed and optimized specifically for these vulnerable babies. It is based on a stem cell platform technology where we isolate and identify the cells with the highest therapeutic potential and allowing early treatment when it is needed most. So from a single placenta, we can generate more than 1,000 doses, allowing early intervention. So after birth, when HIE is suspected, there is a narrow treatment window where every hour counts. Our intranasal cell therapy will allow early intervention with an easy-to-use therapy that can fit in seamlessly to the current care pathway. So how does it work? Our treatment targets the key mechanisms of brain injury in HIE, decreasing inflammation, as well as decreasing cell death of neurons, the important signaling cells in the brain. This is as well as protecting white matter, blood vessels, and the blood-brain barrier. And we have the data to support this. So our data is in large animal models under clinically relevant conditions, including as add-on to the standard of care. First, we see improved survival, but we also see, importantly, neuroprotection, thinking about the long-term impacts on those survivors. The graphics, what you see in green is healthy, mature neurons, where there is an abundant supply in a normal brain, decrease in brain injury, but after 4 days of treatment, a substantial improvement in the stem cell treated groups. So what are others doing? Our main competitors are MSCs, a type of cell therapy, and small molecules. We have key advantages over this limited and early stage pipeline. Firstly, large animal data. Secondly, improved efficacy over MSCs, which is one type of cell. And thirdly, scalability.
So how are we going to protect it? We've got multiple layers of barriers to entry. We've got regulatory, we've got patents till 2043 at the earliest. We own the supply exclusively, and we have the technical know-how. We've retained the original inventors in the company. Moyed's talked about the impressive outcomes that we believe we can achieve with K.I.D.S, but does anyone care? The patient advocacy groups do. They're crying out for new treatment. We've talked to neonatologists, and they're very excited by what regenerative medicine can do in this space. So who's going to pay for it? We've done our research, and based off QALYs, a quality adjusted life year, we believe at a modest 20% improvement on standard of care, we'd achieve a price listing in the US for $200,000 per treatment, about half that in Europe at a low level. We're being conservative. So what does that look like from a market position? The 30,000 patients, 12,000 of them are moderate to severe, so they require direct intervention. They're our initial target. If we can get half that market, because there is no competition at the moment, we believe the market could be very attractive. So what do you want to do first? Straight to the US, focus on selling directly to hospitals using outsourced sales models, which we've used before, and get this market and get it out here before we go out to Europe. So here's our roadmap with multiple exit opportunities along the way. The technology is up for 10 years, being initially researched in Australia. We've bought it, taken it in ourselves, funded it directly ourselves, and now we're looking to raise 2 or 3 million to optimize the product for a preclinical before we do a Series A to get it into clinic. Exit then, at that point, go to IPO, which we're more than open to, or trade sale, or go again on a Series B to get it to clinic for the phase 3. So I talked about pharma partners, so who are they? Great news today. There's a lot of big pharma who are involved in this space in neonatal brain injury. If you look at the International Neonatal Consortium at the bottom, there's a lot of pharma parties there that we're familiar with, and I'm sure you guys are as well. The good news is also that Moy and myself have experience with these discovery teams and licensing teams, so we have some relationships there already. Why us? Why not? We've done it before. Moy and myself have 20 years biotech experiences, taking concepts all the way from the bench to phase 3. We've done pediatric rare disease before, getting multiple orphan designations in Europe and the FDA, raised money in this space, and we're supported by leading stem cell scientists. Dr. Jayden Patel on the right there is the original inventor and part of the team. To conclude, cooling is the present, canvas, we believe, is the future, and we can have a dramatic impact in this space. Thank you for listening.
Perfect. You guys even saved 20 minutes, so that's perfect. Let's have a round of Q&A then. 6 minutes.
No?
Yeah.
Okay, thank you. A very interesting presentation, but nevertheless, for me it's not clear how you are jumping from the pigs to the children. That means that the most of cases, the tests done with animals are not working with persons. So how you're so sure that you can go from the animal to the person? Because I think the key is the issue in that case.
Yeah, I think so.
Maybe you explain, but you are so fast that I again don't get the point, because for me it's the key issue on this project.
Yeah, so clinical translation is very important, and actually within the experience for HIE, there are a lot of lessons to be learned. So the only therapy that works for some currently is hypothermia or cooling. So this was tested in these animal models. What's observed clinically is consistent with what's observed in the animals. So it's really important to make sure that the conditions are as close as possible. The reason pigs are selected is because they are much more predictive because of their biology on what may happen compared to rodent models, which others are using. But also taking other learnings is, more recently, some trials have looked at other types of EPO, but the early preclinical work in the animal models didn't include these clinically relevant conditions, so the standard of care, and factors like that. So the key is to reduce the risk that there may be a lack of clinical translation by making sure that the animal data addresses as much as you can. It's not going to be exactly what you will see clinically, but it should give you a high degree of confidence that what you are observing in your studies can be carried forward from there.
How many tests are you planning to do to jump into children?
Yeah, so from one of the challenges of going straight into children is that you have to front load your safety testing and your toxicology. So that's from the safety side. From the efficacy side, we have already 2 pig models in HIE and another in neonatal brain injury. We also have data in a wide range of conditions where these cell types in our therapy are tested against either cell alone or against other therapies. So we have 2 large animal brain injury models, a number of supportive rodent models, and ultimately, once we optimize our product, we want to run 1 large piglet model supported with safety work.
But to your question, and to give some confidence on safety, there are other companies who have put MSC cells into phase 1, into babies already. So we have confidence on the safety, but we're adding an additional placental cell to that. We need to do the work.
Okay.
Thanks, guys. Because timing is so sensitive of the intervention, what is the mechanism that leads up or flags the patient to make you believe that there's high risk? And do you have concern about being able to flag a patient fast enough in the first place to make sure that you're intervening at the right time or the optimal time?
Yeah, I think that's really the key here, is that we are not trying to change the current care pathway. So those patients are already identified. What we want to do is within that narrow therapeutic window, so within 6 hours of birth, that we begin treatment. So by being an intranasal, easy-to-use product, that means that staff can be trained easily. This can be given quickly. It's coming off the shelf. This is not like a cell therapy that needs a lot of preparation work. It's when it's needed, it should be immediately available.
So you're saying that 100% of the time, this is caught early enough that you could intervene and it would be successful? I'm asking about whether the flagging is sufficient to actually intervene at the correct time.
Yeah, so HIE is typically suspected very early. It's confirmed later on, but in terms of identifying those who need treatment, it's essentially the patients who currently receive cooling as our first target patient population.
Maybe a little bit related. Can you elaborate a little bit on how you're going to determine dosing?
Yeah, absolutely. So one thing to say is that we can draw from a lot of experience with use of MSC cell therapies in terms of dosing, where we know what the dosing ranges. We also know that one interesting aspect of these cells for other indications is that they seem to work better in children, and that higher doses are more effective. So in terms of selecting doses, we will use our preclinical studies. So we have an idea of a dosing range currently, but then we narrow that down before we get to our first clinical study.
So the dose response study, that is going to take place in the preclinical model, the pig model?
So that will be in the pig model, but then when we go clinically, we'll start with a phase 1. So that will be a dose escalation where we will start with a lower dose and then work up to higher doses.
Well, you want to go first? Oh, quick question on the competitor landscape, please. So I've seen that there are 3 other projects, especially the Japan one and the Duke. They are already in phase 1.
Yeah.
So probably you have to prove superiority about these projects, and then your differentiation approach is based on the improved efficacy versus. So can you elaborate a bit more to be sure about what this is clearly better than the other ones? Because these ones are going to be on phase 1, phase 2, so you will have to prove that you are. So how you?
Just a short answer, please, because we run out of time already.
Yeah, absolutely. So one thing to say is that from the preclinical data, both in the brain injury context and then in others, we have direct comparisons with MSCs. So our therapy is based on 2 cell type ECFCs and MSCs, so there's direct comparison there. And what that highlights is when we showed that mechanism slide, there are multiple mechanisms that feed into brain injury. And for several of those, we have head-to-head data showing improvement. So that is where we see the advantage. Yes, these MSCs are a little ahead, but when you look overall, this is still a very early stage pipeline. So we believe that by moving quickly and by focusing on the advantages, we can compete very strongly.
So thank you, guys. Sorry.
Thanks.
Thank you. I gotta be the policeman again, so sorry for that. Sorry for maybe during a break, but we have the last startup. Of course, best of the luck, Joan. And before the break, we have a team from sunny Italy, Rehabilitalia Technologies, and please, guys, tell us a little bit more about your project.
Thank you. That's that. This one for moving forward. Mm-hmm. Yeah. Well, Rehabilitalia Technologies, kids neuromotor rehabilitation designed for anyone, anywhere, and anytime. That's our vision. Here's Mario. He's a very funny boy with a fantastic family. I met him some years ago because they came in our lab to try and play with some of our devices because they were looking for something useful and suitable for him, because unfortunately Mario is affected by cerebral palsy, and at that time I decided that I wanted to do something for him. And not only for him. There are about 18 million people worldwide affected by CP, which is the most common motor and cognitive disability and in childhood. And from an economic perspective, lifetime additional cost is around $1.6 million per patient in addition. And there are some important guidelines. Rehabilitation has to be personalized. It means that it has to face specific needs for specific impairments of each specific patient. it must be intense in order to promote as much as possible neuromotor plasticity. And especially for kids, it must be playful in order to provide a context for learning and to promote the engagement of the kids to reach a rehabilitation treatment and aims. With this in mind, we started developing a portable robotic device for kids, especially designed for kids. FICube, or the new PlayStation for rehabilitation. 3 highlights. It has more than 30 configurations. It means that it allows to promote many monolateral and bilateral rehabilitation training tasks in a very flexible way. In order to promote an intense use also at home, it embeds our telerehabilitation suite, which is being developing by taking into account families, doctors, and bioengineers' needs in order of data accessibility, which will be usable on PC, tablet, and mobile. And in order to promote the compliance of the kids to the therapy, it will not be interfaced only with commercial games, but also with a suite of games specifically designed with doctors in order to target specific kids' needs. There are competitors, but if we take into account the specific features in order to promote a versatile use in home settings, FICube is outstanding. We have in mind some important KPIs for many different stakeholders. We want to reduce number of in-clinic visits. We want to increase the training time for better rehabilitation outcomes, and also to increment the number of patients for improving the efficiency of the healthcare system. As a pricing strategy, we have in mind a very simple one: 15 euros per rehabilitation session, software and hardware, everything included. In order to start to analyze the sustainability for the healthcare system, we started considering the Italian one, which foresee an additional reimbursement for using robotic equipment over standard therapy of 22 euros, which means, at least in Italy, possible hospital margin of about 7 euros per session. Potentially, all the market is made up of all the 18 million people worldwide affected by CP. We will concentrate on European and American market in the first years, surely, because there are well-established healthcare systems and good relationship and networks between hospital, rehabilitation clinics, and families. And in between these, what we aim is to reach 10% of this market by considering competitors and production and distribution capabilities. In order to estimate the value, we consider an average intense treatment of 2 months per year per patient, which lead to a possible value of the target market about 60 million euros. We will initially target the Italian one because the clinics are well funded. They are used to use MVPs and prototype, and we have a good network of relationship with some of them, and they can help to build the reputation of our product. In our timeline, there are 2.5 years of clinical validation, industrialization, and certification of the product, with the aim of reaching the break-even point in 2029, after starting introduction in the market on 2026, with some well-established and well-defined milestone for fundings. For the product development, we will have to industrialize the mechanics, the software. We will integrate additional artificial intelligence module, and we will also develop a lower limb version. Not only for kids, but we will there move also to adult diseases, geriatric needs, and up to the sport market in order to increase as much as possible the number of beneficiaries. We are a team of 3 people, very passionate of technologies for service of people and expert in robotics, and supported by representatives of associations, kids treatment, and business. Here's Mario, some years later, playing with the cube. And what we propose you is to join us in this venture with 500K, which will help also us for financing a 1.5 million euro EAC accelerator project. Thank you. Here's Giovanni and Matteo, the other co-founders.
Perfect, guys. You made it just in time.
Thank you.
Thank you. So now we will have 6 minutes of Q&A, and after the Q&A, we will have a lunch. So let's keep it time track.
Congratulations. I have a quick question. How do you adapt your technology to each patient? As you say that each patient is different from the others.
Yeah. The idea is to, what we wanted to do during the development is to provide something which was flexible. And the diseases and impairments of kids can affect different parts of the upper limb mobility. So what I show in one of the previous slides is to integrate in this flexibility, in some of the movements that you did, that you saw, together with a specific software application. So it's somehow a combination of the hardware and the software solution.
Thank you.
Sorry, it was too big at the beginning.
Yeah, first of all, congratulations. Second of all, you said you will get games into the machine or the product. Have you already developed these games? With which team did you develop these games? And do these games result in engagement of the kids wanting to go to rehab? Or which is the difference that your rehab does to other rehabs?
Yeah, thank you for the questions. As you saw from the project, games will be the central part will be because we'll engage the kids while they will play. And what I raised from also speaking with clinics is say that if it's not engaging, they will not play. After 10, 15 minutes, they will stop, they will get bored, and they will stop playing. So it will be, we started collecting some suggestions from the kids, directly from the kids, and we already implemented some suggestions that they directly told us. We started, recently we had some usability tests with almost 50 patients, all affected by CP. And so we are starting this journey, and we will, of course, do the best to push on the visual part, which is very, very important for us.
Two quick questions on financing. You mentioned that you apply for the accelerator, or you actually got the accelerator?
No, we will apply. We will apply next week for the first stage.
Okay, next week.
Yeah, we have the
easy. Second one.
Sorry. Yeah.
What are the inflection points with your $500,000? So what you are gonna do with the $500,000? And
the idea I wanted to. Here we are, and what we want to reach with the $500,000 is to improve the prototype that we have now, because it's not so much reliable for clinical tests, some mechanical and software issues. We are already working on that, but we need financing. And our aim is to reach to clinical validation. We are in contact with 5 Italian clinics for a multicentric study, but they are done. It will be done in the research center, but surely we want to move it directly to the company.
Okay, one technical software question. Is your sensors, are they in the software, depending on how the kids can play the game and what they achieve and what they don't, or is it in the mechanics?
I would say it's both. So it's a robotic device, so we have sensors inside to measure position, speed, and force that is exerted on the device, and on the basis of this and what is expected, we can tune the level of assistance, the level of resistance, whatever it's needed for the kid. And on the other hand, we have games, and the games we develop ourselves have the ability to collect performance in the way we need it. And so also from a software level and from a game proposal, we can tune the level of difficulty of the game that is proposed to the kid to make it challenging enough, but still doable for each specific kid. Yeah.
Thanks, guys. Can you describe how this interfaces with the care team? So who's looking at the data? How do they measure progress? And how do they actually encourage the kids to use this in the first place?
I can start from the telerehabilitation platform that we are developing to answer your question. The data is collected continuously, whether the device is used in clinic or at home. And we are in contact with therapists who are actively using similar devices enabled by telerehabilitation, and they directly look at the data, usually. So they are one of the stakeholders looking at the data, but as Matteo said, another stakeholder is the research group inside the clinics. They also want to look at the data that is collected from the device, not from only a clinical point of view, but just even to research, to do their internal research of the use of the device. And third point is that the data is useful for the administrative department to monitor, for instance, if a pay-per-use strategy is economically feasible for them, because they will give the device to the families and monitor if the compliance is enough to justify the cost.
Yeah, just one note. We will make available both raw data for bioengineers and synthesized data for doctors and for monitoring the therapy during the time.
Perfect. Thank you, guys. So it's time for lunch right now. We're gonna pass it through this door. It's gonna be easier for you guys. And for our Italian friends, we made sure there is no pineapple in the pizza. Actually, there is no pizza. So don't worry, guys. You can follow and continue to this side. Thank you. With our wildcard program, final selection. Right now, we're gonna have a possibility to have a pitch presentation from Ira Health from España, who is going to talk about the digital solutions in pediatric pulmonary rehabilitation. Ira Health.
Hello, everyone. I'm Pilar, and for the next minutes, I would like you to talk about who, how, and why we want to transform respiratory care. So, sorry. First of all, Ira MedTech is a spin-off of Barcelona Children's Hospital. They have over 400 clinical trials at their back. Together, we have a combined experience of over 50 years in respiratory rehabilitation and over 35 years in entrepreneurship and innovation. Now, I want you to focus on a problem that affects millions of children in the respiratory care. 60% of respiratory patients don't adhere to the treatment plan. They don't do the respiratory physiotherapy, and we understand why. They have to spend every single day of their lives on respiratory exercises with a device like this, which is a piece of plastic, which is zero engaging, it's boring, and it's repetitive. But they have to do the physio to avoid infections, respiratory decline, and hospitalization. But the problem is bigger. There is an important problem in the care model for this type of patients. At hospital discharge, the patient goes home, and then there is a big disconnection between the patient and the healthcare system until the next exacerbation occurs. And during this gap, the physio cannot know if the patient is doing or not the physiotherapy. They cannot know if they perform it correctly or if it's effective. And of course, they cannot adjust it to the current situation of the patient. So our physio and co-founder, Enrique, he thought of a solution that is a patented respiratory device that uses acoustics to connect with the software, which contains two parts. On one side, a set of respiratory exercises disguised as video games, and a clinical monitoring platform for the physio to use to follow the progress of the patient and adjust the treatment. I.D.A. is already CE marked and certified as a Class 1 medical device. We have conducted a feasibility study, and we have seen that there is an 80% improvement in the adherence of the treatment in children compared to the standard of care. Now, we believe that this increase in the adherence plus the telemonitoring will help reduce the number of visits and hospitalizations, reducing costs by 20%. In our next clinical trial, we want to prove this assumption, and we want to assess the impact in the lung function, the number of exacerbations, of book appointments, and hospital admissions. So we want to start targeting the children market, but then we will expand to the adult market. And it makes a lot of sense, because these respiratory conditions, such as cystic fibrosis, asthma, recurrent bronchitis, or COPD, they affect both children and adults. And the same solution, our same solution, works well for all of them. And respiratory conditions are the third leading cause of death, and it's growing. So the market is big and growing. We are not the only ones that have identified this need, but our main difference lies on the technology that we use. We use acoustics. Our competitors are using batteries and sensors, which increase the production cost and also have a higher negative environmental impact. Just last July, one of our competitors launched their product in the French market. But they are not tackling one of the big problems, which is this disconnection with the patient and the physiotherapist. And we solve it with our solution. Oops, sorry. During the feasibility study, we asked physios what they thought about our solution, and they were very blunt. They want I.D.A. to get objective data regarding the lung function of the patients and be able to adjust the treatment, and also families. I would say, like most of them, and I'm not exaggerating, they were telling us that they would pay anything for their kids to have a better time doing the rehabilitation. There was a mom who said, okay, if I'm buying, check the reasoning, if I'm buying a PlayStation for my older kid, how am I not gonna buy this solution for the other one that has cystic fibrosis? Of course. So, given this, we thought that we need to start with a B2C business model. We will provide the solution for an upfront payment, and then there will be two models. A freemium model that will include a limited number of predefined exercises. There will be also objective data in the lung function of the patients, and patients will get a progress report to show it to their physio. And with the subscription model, we'll have all these, plus personalized respiratory exercises, a direct channel for communication between the physio and the patient, and a broader library of exercises and video games. Since we are already certified as Class 1, we want to enter the market in Q3 2024. And we want to start generating revenue as soon as possible and start collecting real-world data. And in parallel, we will run a clinical trial and transition from Class 1 to Class 2A and enter the market. No.
Sorry for that.
At hospitals.
Yeah, don't worry. Maybe you can. Maybe there will be a question about the team, so you can, present the team. But because right now we will go into the 6 minutes of Q&A. Yeah, you can leave it here. Okay. Exactly. So yeah, please, we'll start 6 minutes of Q&A.
So, what are your financial needs?
Okay, so we. Thank you for the question. So we are seeking 1 million euros to enter the market in a year to start acquiring the Spanish cystic fibrosis and asthma market in children and to complete a clinical trial.
Yeah, you said that you're using sound sensors to.
That we are not. Sorry?
So that you're using microphones to test to check the sound. What's the difference on reliability and precision of measurements in comparison to the other platforms that are using sensors and so on? Like, do you need a controlled environment for the test to be precise?
For the test that we've been doing, since our solution is attached to a microphone, this is more than enough to capture the sound that we need to transform it into parameters that relate to the lung function. So it's if we were not using a microphone, then yes, we would worry about the environment, the noise, let's say. But because of this, it's under control.
You just said that you would like to use this device also in adults. I wonder how would you adapt this device for adults? I mean, you would use games or?
Yeah, so for the hardware part, it's the same. The clinical monitoring platform, it's the same as in children, but the games need to be adapted. In fact, now the first games that we have developed are for kids between 3 to 10 years old. And we will be increasing the number of games and the ranges of ages. And of course, adults need a different type of video games. But adults play also.
How many time takes for a family or patient going for 2 different visits to the hospital, to the physio?
Sorry,
how many time takes between one visit and another?
Okay. So depending on the type of indication and patient. So for chronic patients, maybe it can be 6 months. And during this time, things occur to the patient. But because of the disconnection, the physio doesn't know this and cannot adapt the treatment to the patient.
Very nice presentation. I have a question regarding the adherence, and because you started saying that they basically lead lifelong continuous treatment, how are you going to maintain the interest in playing a computer game with this thing? And then going back to the COPD, which is, have you considered that this is like an inherently difficult patient population to treat? I mean, they have a reduced lung function, but most of them, they smoke and are not doing exercise already. So getting them to blow into this half an hour a day is probably going to be very challenging.
Well, I'm going to start with the end. They already have to do it. They have to do the respiratory physiotherapy, and they have to use this.
But they probably don't, right?
No, exactly. No, but you know, there is less adherence in adults than in children to do so. So we want to adapt these games, and we want to use AI-driven environment to build these games so that the background of the game changes continuously, so that it gives like an idea of a new game or new challenge among these. And with the games for the adults, we plan to co-create them together. And we, like in the future, when we focus in the adults or elderly, we would like to include other features, like using sensors like that have additional biological information, and integrate all these, and to help motivate or increase the use of our solution. But it's a challenge, I completely agree.
And with the patient in terms of making them understand the actual use of the device. So one of the things is just gamifying adherence. And then I think one of the other things that these respiratory technologies have struggled with is allowing the patient to understand whether they're doing the exercises correctly from a form perspective, especially in spirometry, for example.
Yeah.
So can you talk a little bit more about how do you actually correctly instruct them that they're doing these properly? And does that actually matter? Like, how sensitive is the results or efficacy of the exercises to that?
So nowadays, with the standard of care, maybe patients leave the hospital with this, and they didn't really understand how to do the exercises. And they have to come back to the hospital so that the physio explains again how to do it, okay? With our solution, the same game teaches you how to do it. So it's like there is no way you cannot do it well, because there is like graphics that tell you how to do it. So this will help us reduce these extra visits that happen just because they didn't understand how to use it.
Thank you, guys. Thanks again.
Thank you.
Thank you very much and good luck. So let's continue now with another Spanish team. This time we have here Gate to Brain. The Gate to Brain is a biotech company with pediatric solution to deliver drugs to the brain, as their name says. Let's give it up for them.
Hello? Yeah. Thank you so much. I can shout, but it will not be fine. So children which represent 25% of our population, but 100% of our future if we don't decide to live 200 years, really never stop dreaming. Reaching the moon on a space shuttle is probably one of their beloved dreams. At Gate to Brain, we had a dream that it's to create a brain shuttle that will cross barriers and bring medicines beyond them. Going beyond the biological barriers, such as the blood-brain barrier, but also beyond the barriers of the lack of investment and development in pediatric. And why not? Beyond the barriers to achieve one day that health could be for everyone, everywhere. But why the brain? Because the brain is the more precious organ in the human body, but also the more difficult to reach when we need to treat it. And this is due to the existence of the blood-brain barrier that protects it. The reality is that 1 every 4 of us suffer from a brain disease during our life. The good news that there are drug candidates being developed at universities, research centers, big and small companies worldwide for almost all of these diseases. But 98% of these drug candidates will fail crossing the barrier, and this will stop their development and the opportunity for patients. So Gate to Brain is a peptide-based patented technology that helps drugs from different modalities to be able to reach the brain. I'm Meritxell Teixidó. I'm CEO and co-founder of Gate to Brain. Let me present you G2B002, our first mission to the brain. In fact, it's a proof of concept that our brain shuttles are able to deliver a chemotherapeutic agent to the brain to fight pediatric brain tumors with intact blood-brain barriers, such as IPG and pediatric glioblastoma, that are incurable nowadays. But why focusing as a first mission, pediatric brain tumors? It's a clear unmet need that will lead to the orphan designation for our compound G2B002. We have access to the pediatric patient-derived animal models for the fact of having Sant Joan de Déu as co-founder of the company. In fact, it's known that the BBB in kids is more tight than in adults. And we are aligned with the World Health Organization initiative by 2030 in childhood cancer. G2B002 has a clear regulatory roadmap ahead. And in fact, we are starting conversations with the EMA and applying for the orphan designation. We have recently achieved very promising results in terms of efficacy, both in reduction of tumors and increase of survival. We have a package of results of G2B002, and in fact, we are just starting the preclinical regulatory studies with the idea to reach the submission of the IMPD by the end of 2025, by mid-2025. So this is a clear opportunity to invest in a company that has been able to traction more than 4 million euros since the creation in July 2020, both from private and public funding. These 2 million euros that we are looking now will sum up to the 2.5 of the AC accelerator that we were granted last year to do and finish the preclinical regulatory studies and reach this IMPD by mid-2025, and then a clinical trial in 2026. Which are the potential licenses of G2B002? Are companies such as Alexion, Sanofi, companies that are really moving to this pediatric oncology and rare diseases. But the potential of G2B002 goes beyond the IPG and pediatric glioblastoma. In fact, one day can benefit all those brain tumors or tumors that are sensitive to the same drug that we are transporting. But even the technology has further scalability. In fact, it can help to all those diseases where there's a drug candidate that needs a better transport to the brain. That's why we are in conversations to establish a couple of strategic co-developments with Big Pharma to use our technology with their drug candidates. The aim, a clear aim, to create further trust on the technology, and that this can trigger the potential acquisition of gate-to-brain technology, as it happens with F-star gamma until Denali Therapeutics acquired in 2016. But why Big Pharma can be interested in such a technology? It's clear the technology has some hallmarks that make us stand in front of other solutions. Protease resistance of our peptides, more than 12 hours in the bloodstream when a normal peptide is between 15 to 20 minutes. Low antigenicity, and the fact that they can carry a wide variety of drug candidates. In fact, we have recently demonstrated the transport of a small molecule in the case of G2B002, but we have published the transport of nanoparticles, and we have a recent patent on the transport of monoclonal antibodies, therapeutic monoclonal antibodies, using our technology. In fact, these two hallmarks are the ones that really position gate-to-brain as one of the most promising technologies based in peptides to cross the blood-brain barrier. This is the clear business model of gate-to-brain, that will have the asset of G2B002 to be licensed after the phase 1/2 clinical trial, and then these strategic co-developments that will give upfronts and milestone payments to the company through these years. Everything covered with a strong IP portfolio. 3 patents on the 3 peptide families of brain shuttles, and 3 novel patents on peptide drug conjugates, because each peptide drug conjugate is an opportunity to create novel IP and increase the value of the company. Also, we have freedom to operate on the drug that we are transporting in the case of G2B002. And to be aligned with our mission, G2B002 will be protected in all those countries that there's a pediatric cancer hub where kids can benefit from it, having in this way a global impact. This is the team behind the mission, a team that ranges from peptides to oncology, from business to drug delivery and operations, a team that working together with our external advisors dream to cross barriers and bring medicines beyond them, dreaming that one day health could be for everyone, everywhere, and remembering that everything started in pediatrics. Thanks.
Thank you. Now we will have 6 minutes of Q&A, so please stay with us, and thank you for making it in time, actually.
First, I want to applaud you for engaging in this very challenging route to success. I think GBM is a really challenging space, but very, very highly needed. So there's obviously a strong medical need, both in the pediatric and in the childhood space. I'm wondering, and this is maybe again, why have you? I'm not sure I got really understood the why you chose pediatric, because I'm challenging here whether this is the correct strategy for the regulatory hurdles that you have to go up against, and maybe reaching the market and reaching the patient would be better to go with the adult population first, and then expand into a pediatric space.
This was not planned, but I love your question, okay? So let's go from the more biological or scientific driven. So I have been 20 years in this field, okay? So from this part to the more strategic one. Biologically, it's known that in IPG and pediatric glioblastoma, the barrier is intact. When you go to adult glioblastoma, sometimes there's certain concern if the barrier is not intact or not. Not for the cure, but for the validation of the platform, it's stronger to validate it in the IPG, correct? Because you validate it in a more tough scenario. If we move a bit further, it seems very cold, but it's not like this. Because in the IPG, these kids are diagnosed, and then they gone through radiotherapy, and they will reach our clinical trial. Somehow they are a bit homogeneous. If we try to go for an adult population, this adult population, in our case, probably will come from relapse of different potential treatments. So in terms of, in this initial clinical trial, having outcomes or endpoints really giving value to the product and the company, it was very strategic, okay? Next stage, regulatory. I cannot imagine that there's any drug that is approved for pediatrics that cannot jump to an adult population in a faster manner, okay? On the opposite, I think that we'll all agree that a kid is not a half of a pill of an adult. So, but in this sense, probably this path, it doesn't mean that it's easy, but it has certain concerns. About investment, okay, I think that we all know that what you need to do is to go for certain type of investors, no? That's why we applied for this accelerator last year. That's why at the first initial investors were Fundación Botín in a program that is called Mind the Gap. So you need to work in another manner, no? But, and more or less that's it.
Thank you. Maybe just one quick biological question. So if I understand the mechanism correct, you have a peptide that binds to a receptor on the blood-brain barrier. Have you, that causes the influx into the brain. Have you looked at the reflux?
Yeah, because so we have three families. It's true that in G2B002 we use one of a specific peptide, and it uses a receptor that is overexpressed in the brain capillaries, correct? We are not using the native ligand of that receptor, so we are not competing for the same binding site. And the way we discover, and to be fair, it's not during these 3 years, it's during the 20 years and 10 PhD students before, okay? How we discover, we know that we do it in the human BBB model that was developed in Paris. So in these models, you can study the influx and the efflux. Okay, so somehow you only discover the ones that have more influx than efflux. That's.
Sure, I'll do one. Thanks for the presentation. Can you just explain in a little bit more detail your clinical trial strategy? So, you know, how many patients and how much money it's going to take?
Okay. Clinical trial. So let's make a jump on this dream, and then we are starting to have the clinical trial first draft. Let's put it like this, okay? It will be unicentric, okay? It will be 10 kids. This is based on the previous experiment, previous cases or similar cases. Our dream or idea is to center it in Sant Joan de Déu in Barcelona, because probably the hospital is ready to receive families internationally that travel there. In this case, the idea is to make like an add-on, so all of them will have the radiotherapy as a palliative care, and then you make a second arm that is with the G2B002 and compare it to the years and years of data of only giving radiotherapy, okay? This is the idea. Then the jump, the natural jump, is to make it in the next phase, if we do it by ourselves or who will license, is to do it multicentric, obviously. So this is more or less the first draft of that.
How much money do you need for the first step?
For the first step, it's value, when you consider the CMC, okay? And peptides are much cheaper than antibodies, but are not free, okay? So for the peptides and everything, we need 5 million euros. So now we are looking for to sum up to the 2.5 of the AC for the preclinical in this stage, and then we will look for 5 million euros for the clinical phase.
And that will take you to the 3 patient or the 10 patients?
The 10 patients.
And this is the phase 2A?
Phase 1 to A, yeah.
Okay.
And just one last question. So maybe in comparison to other cases that you've seen successfully license out their technologies, what is some of the strategy that you're doing from a business perspective beyond the clinical testing to attract the interest of these potential licensees? Have you started those conversations already, et cetera?
Yeah. So normally there's one sweet spot, okay? In general, in clinical trials, okay? I don't mean that in this case will happen the same. That is, they prefer to do the phase 2B another. The phase 2B, they do it because with this information to do the phase 3, for them it's better to transfer it before than not between the 2 and 3, okay? This is one thing. To make that happens, the ones that been involved in the co-developments that could be for completely different indications, in fact, they will know a lot about the technology. So maybe they can be potential licensees of G2B002 also. This is one thing. But maybe this doesn't happen. In the case this doesn't happen, what I can imagine is that they ask us that they license not only for the IPG in pediatric glioblastoma, but they license the opportunity for all the brain tumors, even if we have not demonstrated. So I cannot imagine splitting in 3 licenses for adult glioblastoma and the IPG separately.
Yeah. Okay. Thank you, guys. Thanks. Now we have another startup. Thank you, of course, and good luck. The next startup, I think, flew here from furthest country. I don't know if you guys live in Kazakhstan on a daily basis, or right now we're in Europe. Maybe you'll, or Uzbekistan. All right, so this is, sorry for that. And I had a mistake here, but nevertheless, it's still far away. So please welcome Mila for AI team, from what I remember, a speech therapy startup that will talk about their digital solution.
And just a remark, I didn't fly from Uzbekistan, I flight from Singapore. I spent two weeks in Singapore on 2 technological forums there, because we are global finalists there as well. Let me just figure out how it works. Do I just... Oh, the big one. All right, okay. Speech is one of the most important and fundamental skills for both individuals and society at large. I'm sorry, just a second. Oh my God, this is. How do I? Come back with the smaller one. With a small one. Okay. Do I press this one again? Yeah. Okay. Okay. Speech is one of the most important and fundamental skills for both individual and society at large. We express our feelings using words. We defend our position using verbal communication. It's not moving though. We express our... It's not moving though. No, it's not moving. Okay, I'm going to just say what's most important. Okay. We express our feelings using words. We defend our position using verbal communication. We connect with people by speaking to them. We remember the first day when our kids said their first words. I waited for over 2 years to hear my son saying, "Mommy," and the picture is not showing. He spent another 4 years attending regular speech therapy sessions. There are over 100 million people worldwide with various speech disorders, including kids with cerebral palsy, Down syndrome, and autism. And there is a lack of speech therapy everywhere in the world. Waiting list in the US is 3 months, Germany 6 months. In the UK, it's up to 2 years. And fees for services are not affordable for people from low-income community. Insurance, if any, covers only a limited number of sessions. Plan of care are often not personalized. Both therapists and the parents lack objective information about the performance. And exercise, kids are not practicing enough to achieve a better result because exercises are boring. That is why we created Easy Speech, AI speech application, which basically address all those needs. It's demonstrate the performance, provides real-time, and there is no voice, provides real-time tailored feedback. Unfortunately, the voice is not, you don't hear it. Provides real-time tailored feedback tailored to specific error made by the user. Masks help the kid to use the correct position and to understand intuitively what needs to be done. The whole concept is based on the so-called video self-monitoring intervention, which works best for kids. The app generates 7 reports to monitor the progress. Those are overall performance over the period of time, performance by exercises, by modules, and the register of error. Those reports will save up to 25% of time therapists spend on paperwork. So how do we ensure that we motivate kids to exercise on a regular basis? Well, let's face it, they hate doing exercises in front of a mirror. Gamification. We introduced a number of gamification features to keep the user engaged. Those features are not only entertaining, but they also help the user to understand the process and to achieve the results. We trained, we built and trained our neural network based on kids and adults of various ethnicity, age, and gender to minimize bias assessment. And calibration makes it even more adaptive to specific face parameters of the specific users. Our algorithm can assess the performance even if the kid cannot keep his head straight. And there are a lot of those kids, especially kids with cerebral palsy. And furthermore, there are personification parameters which adapt to disabilities and preferences of specific users. For example, a hold time for static exercises of level of difficulties. Some call it control AI. We call it humanization of AI. There are a lot of apps, speech apps on the market, including medical devices, but none of them nearly can offer what we do. So we do not benchmark ourselves to other apps. We compare ourselves to human. Compare, but not compete. We are a tool to help the therapists and their patients. That is why we're going B2B2C. Our application will help clinic and rehabilitation centers increase number of patients served and increase the revenue by 10 to 20%, and at the same time decrease the cost of the payer by 40% because of implementation of hybrid methods of treatment. We have implemented 19 mimic exercises covering tongue, lips, jaws, and brows, and sound model with over 200 sound practices assessing accuracy of a sound at the beginning, middle, and end of the word. We have achieved accuracy, precision, and recall rate in the range 70 to 90 in the lab, and in the pilots we have been conducted for a year and a half. We filed patent application in US and been accelerated by a number of innovation centers. We plan to launch by the year end once we are fully compliant with GDPR compliance. And in 2024, we plan to get CE mark as Class 1 medical device to be able to sell the product through the rehabilitation centers. And by 2025, we upgrade to Class 2A device and get FDA approval and become a matching platform for speech therapists and patients, and the knowledge sharing platform for best practice worldwide. We have our target markets are USA, Germany, UK, and Spain. We have expression of interest from China, India, and Indonesia. But we can achieve break-even within 7 months after launch when we hit 400 active users. Given the fact that there are millions on the waiting list, we do not anticipate any problems to achieve that number. Our funding needs is $2 million primarily for certification of formal clinical trials in EU, in US and EU, small portion for our sales team in EU. Our team comprises of 7 engineers and practicing part-time speech therapists. We have 12 months advisory support from Medical Innovation Incubator in Germany. We are the global team with global ambitions. And we will set a new standard in speech therapy, enhancing experience for both therapists and their patients.
Thank you very much.
Sorry about the video. For some reason...
Technology. Now we will have 6 minutes for Q&A.
Okay.
Can you go back and describe the business model in more detail? Because I think that the first statement that you said about how very few insurers currently cover this and the other competitors are mainly going direct to consumer. I'm just trying to get a better sense of how you're actually going to launch this and the exact business model that you're employing.
Right, we're gonna launch as a wellness and fitness application, and we're gonna launch through a therapist referral program because we're already piloting for a year and a half, and they can launch it through a subscription model. Once we get a class 1 medical device, we're gonna go through business license, so that is gonna be included in the bill because rehabilitation centers can use it as in-house simulator or remote patient monitoring. That's basically what we have been discussing. So it's going to be B2B when they will sell a license. They're going to pay fixed fee depending on the number of licenses, and they're going to include it in their own bill.
And when you sell it B2B, what is the return on investment pitch that you're giving them? Are they seeing more patients? Like, talk a little bit more about that.
Yeah.
I know there's some stuff about decreasing time for paperwork.
There is a combination of two things. First one is increase of throughput, because on top of number of patients served, because what's going to happen, the number of speech therapists won't change, right? Because whatever they have, they will still have, but they will have. They will charge the patient for monitoring, because remember we have that monitoring dashboards, like 7. So they're gonna go home after 3 months rehabilitation, and the monitoring based on the review of those reports, or using our platform for that purposes. This is number one. This is benefit for their rehab simulator, and again. When we piloted, one speech therapist can serve one person. If it's a simulator, they can put like 5, 10, 15 kids in front of a computer, right? And one therapist can oversee it. So it's obviously much more throughput through one speech therapist. I don't think I have that picture here, but anyway, you can picture it, I guess. But B2C still, the market is very fragmental. So there are a lot of practitioners working in a small centers. So that is kind of given as well.
Hello, congratulations. Can you repeat, please, the funding needs and how do you will use this?
Right. Okay. We've been conducting trials, but those are not like formal trials which you need for getting the certification. So basically, we've been through the regulatory pass incubation, and we conducted the what is needed, like a regulatory pass to certification. And there is a lot of work to be done, including safety performance in EU, clinical trials to see the outcome, whether we achieve that outcome. So that sort of thing. And this is like in compliance with the MDR in EU. On top of it, FDA have a different requirements like in US, which you also need to do. And there is some overlap between regulation, but US have a slightly different. So I have like several price lists from several providers. So we basically, it's come roughly to 1.8, 1.9 altogether.
Hi, I'd like to know a bit more on your differentiation against competitors. That I didn't.
Oh, shoot. Okay, while I'm looking for it, basically there are 2 medical devices on the market. One is in US, constant therapy, and one is DIGA-listed Neolixon in Germany. And all of them basically provide demonstration of exercises. So in other words, you won't know whether you're doing right or wrong. It's like a video saying, okay, this is how you need to perform exercise. And that's basically it. You can basically get it from YouTube for free, but they're selling it as a medical device. Our technology assesses accuracy of performance. And it's not just assessing it's right or wrong. It's saying exactly what is right or wrong. So every exercise has 4 to 9 various feedbacks depending on the error made. So it's not just, it's not correct. And on top of it, none of them produce, well, first of all, non-assessment, now real-time feedback. And we have 2 types of real-time feedback. I just didn't want to bother you. And none of them basically does dashboard reporting, which is save up to 25% of time. And again, when we show this to clinicians, they said, this is really something which makes their life easier because they hate doing reports.
Thank you.
I think that was the last question, actually. So thank you guys again for the presentation.
Okay. And this is CTO. If you have any questions, you can basically come up and ask him, Alexander.
Perfect. Thank you, guys. Now we're going to have the final startup of the day. It's going to be another Irish startup called Myndgard, and they're going to talk about their health solutions for management of kids' patients. So please, Myndgard, we're glad to have you on the stage. Thank you.
Hello, everybody, and we're nearly there, so don't panic. Just want to say congratulations to all the fantastic companies that we're on today. So the best of luck to everybody, and thanks to EIT. So where's my go? Okay, so we're Myndgard, and what we do is we quantify mental health specifically with adolescents and young people, and that accelerates their healing. So how big is the problem? We all know how big this problem is. There's approximately 1 in 7 of adolescents has had experienced mental disorder worldwide. Suicide is the 4th leading cause of death in this age group. And there's about 4 million adolescents in the US who have a serious depressive episode. So how does it work? What we do is we focus on the sweet spot in the clinical journey. If you think about it, there's pre-therapy, therapy, and post-therapy. So we focus on the pre and post-therapy. And that means that we don't actually interfere in the actual therapy. So immediately everybody's assigned to a wait list. They download the app and they start using it. So what do? So we collect behavioral data, important behavioral data such as sleep, location, social interaction, and we also use clinically validated questionnaires to enhance the data. And we build a personalized clinical depression behavioral model. Now, there are a lot of different types of models, much more than you think. Like, depression can manifest itself as passivity, it can manifest itself as aggression, and there's a whole range of different behaviors. We provide this model to the psychotherapist pre-treatment. We also, importantly, monitor post-treatment for relapses. Now, my colleagues here we'll introduce them officially in a minute, but they're experts in this space. There's a lot more to this than just a couple of graphs. But the graphs that we present to the therapists are quite interesting, quite intricate. For example, this one here is the different types of emotion and thoughts and how strongly they're connected to each other. It's really a system, it's not just an app. Well, what are the benefits? Well, clearly the main benefit is faster, better outcomes for the client and the therapist. It also structures and makes the whole therapeutic approach compliant. There's 11% cost saving in triage management and time saved, and 40% increase in revenues because you can charge for the post-relapse as a service. And we cost about 1.5% of revenue, so it's a slam dunk on the business model. There's about 700 mental health apps, but there's only about 20 of them are what you might call clinically grounded. And this is the space we're in. And we want to be the leader in clinically based real-time therapeutics. The beachhead market is university psychological services. And clearly these are identifiable customers. They're relatively easy to contact. They all are stressed. They have too many clients and they've not enough resources. And there's a lot of word-of-mouth communications between them. And we're based in Ireland, so we can get to all 22 in Ireland. There's about 45 that we can get to in the UK and 500 in the US. So it's about 600 institutions in the beachhead market. Transaction model is very simple. Well, we just need about $10 per engagement. Bear in mind that therapy costs between $700 and $1,200, so we're quite low cost. It's a very simple model to bill. If you do a top-down market analysis, 8% of, this is very conservative numbers, 8% of the active market, we've got about 25 million in ARR. And if you build I'm a lot of experience in B2B selling. If you do a classic sales team build up, you get to 4 million with about 6 salespeople. Oh, so here's the A team. Personally identify as Mr. T. Don't know about the other lads, but we'll see. But anyway, so I'm the entrepreneurial lead. I've had a number of successful spin-outs. Dr. Idel Crean is a leading clinician in Ireland, a lot of clinical experience. Dr. Sean Kelly is a world leader in quantitative psychology. I forgot that right, Sean. And he's published in a number of major journals. So we've done a lot so far. We're quite there's always more. Now, the things I want to concentrate on is MVP developed. We did the clinic, we talked to 30 plus therapists and engaged with 3 clinics. We ran a clinical trial last year with 80 students. It was very successful. They got really into it. And we started a triage trial with the University in Galway just this month. We also have the most listened to podcast in therapy in Ireland. Here's part of our ecosystem. Trinity College Dublin. Enterprise Ireland is a government funding agency, and these are some of the clinics we engage with. So our ask is, so where we are is, we've just agreed 100K with EI. Sorry, I'm going to make sure I get these right. We expect another 100 to 150K in further funding. We're getting tax relief for UK Angels, and we're looking for $1 million. Now, we can get that matched 1-for-1 with EI. Okay, so the ask could be 500,000. But we'll take more if you have it. Okay. So really, I started at the beginning. This is a great investment. It's commercializable now. There's a huge market. There's an ideal solution that is focused on where the problem is. We have a great team, amazing team, I have to say. And, you know, bang for the buck, this is a great investment. As I said, though, really the heart of this project is we're bringing young people help and hope when they need it most. As Adele said, it sort of releases them into their second childhood when they think they're losing it. So that's it, and thank you for listening. So.
Thank you. Thank you for your time discipline as well, and now we're going to have 6 minutes of Q&A. $1 million looks like a bargain. It's like cheap, right?
Hey, I'm a sales guy. You know what can I tell you? I have to go for it.
Congratulations. I would like to get more information on your target population, maybe with the doc. Because I've seen many apps, or as you see, this is a great market in terms of population, but also very competitive. So I'd like to understand which type of population are you precisely targeting first. And yeah, thank you.
We're looking to work with kids who are help seeking. So they're already looking for and seeking therapy. They're already on wait lists for therapists, private therapists, and they're already in counselling services in universities.
Okay,
so they would be from maybe the age of 15, 16 upwards.
Okay, and they haven't been screened by other type of, so how these kids are being identified at schools or universities?
Correct, there's always a referral process and a referral system. So a kid is in distress, they're referred by the school, by the GP, by the parent sometimes. And typically the practice manager will automatically do a very brief screening and you're waitlisted. And then depending on which therapist is available, you're then allocated to that therapist.
Okay.
So nothing happens from the time the kid says, I need some help, to the first session right now.
And there's also still a problem on to identify that kids, because as far as I understood, there's also a challenge to screen for these kids, but because they're much more than it looks like.
Yeah, there's two types of kids. There are kids who haven't put themselves forward for help.
Yeah.
We're not targeting them right now. We're targeting the kids who've already looked for help.
Okay.
And waiting.
Okay, thank you.
Yeah.
I'm just curious, can you explain a little bit more about why you chose to target universities in general? Because I see that universities have a vested interest of their students, of course, and they want to provide the best care. but I'm trying to think of the contrast between who's paying for it, and then if potentially these students do not get this care and they relapse into the hospital, that's another person that's actually eating the financial burden of potentially what happens if the students don't get care. So I'm trying to figure out the return on investment for the university from an economics perspective. I think the clinical value is there. It makes complete sense.
So we've talked to a number of US universities. Their issue is they're overburdened. As you probably are aware, the federal government recently has put, I forget what it was, about 5 or 8 billion into mental health for this target market. If you think about the target market, they're most used to sharing their information. They are most used to using devices, and they are the least resistant to using this. So that's sort of the top view. But in effect, as what Adele said, they're help-seeking. They're already in a frame of mind. And what we got out of the UCD study was that they really love getting feedback about their mental health, serious feedback about their mental health. You know, that was encouraging them. So I don't know if that answers your question, but
yeah, it does. And one quick follow-up. So the budget that the university is going to use to purchase this, is there existing examples of budgets for digital health solutions within these universities? Like, are you marketing it to a budget that already exists, or are you allowing the university to quantify the problem so that, you know, government or public agencies can come in and give them the money to then pay for the solution?
Yeah, the model we did is very conservative. So you saw there was a 11% saving in direct costs, and we cost 1.5%. So on that basis, it works. I can talk to this, is there's digital health therapies being brought by universities. You're aware of one of that?
There's a committee, heads of department committee in Ireland that meet, and they're heads of department of all the counselling services for university students. And they have put themselves in quite a powerful position, and they now distribute the funding for mental health from the Higher Education Authority into those services. So they make a lot of decisions, and I have a good relationship with them.
Okay, make it.
And I would say that they have mixed, I would say some of the universities have no digital solutions, no digital approach, and some have now started some early funding. And we mentioned some of them in the slide, Together All and companies like that.
Right, thank you.
We're on the wave, really. That's what it boils down to.
Quick question. How do you adapt this technology to different regions? Meaning that there's difference in the culture in USA, UK, and
I think Sean might be the best. John is actually American, so we were ready to
nice.
Well, a lot of the symptoms of mental health conditions are quite similar between populations, but one of the advantages to our approach is that it's very customizable to what individual therapists see as the primary driver. So these models are fully personalizable, essentially. So therapists can select which individual symptoms they're most keen on looking at, so that can take into account cross-cultural differences, also differences that they see between different subpopulations within their same clinic. So because of that, the solution is essentially able to account for a wide variety of factors that even we can't account for at the current status.
Yeah, and finally, you talk about, first of all, congratulations. You talk about the clinical trial in Dublin. What were the results of this trial? Did you find that you targeted the right parameters, or did you find any major flaws in the process?
We'll let the intelligent people answer that question.
I mean, it was a very successful trial. It was a very intensive version, so it was a shorter version of what we intend to present to the general population. So that was really the only major challenge there, was the intensity of the level of engagement we were asking. But again, that was a learning we took, and we kind of know that we need to make it less intensive for kind of more general populations.
Thank you, guys.
Thank you.
So that was actually the last presentation from this wildcard competitors. Now we're going to ask the jury and judges and the VCs, of course, to continue to the room where you had the lunch, to have one-on-one meetings with the startups and actually to make the final decisions. And we will get back to the EAT finalists 20 to 5. So right now, please continue to the room where we had the lunch for one-on-one to talk with startups, maybe to ask some questions that you couldn't ask right now. And then to finally select the two. Excuse me. Yes, just follow Maria, please. And right now we will have another keynote speaker, Łukasz Ogrodniczak from K.I.D.S Foundation, will talk about the hospital of the future from the perspective of a children. So please welcome Łukasz for the keynote speech.
Okay, guys, thank you. I think you can be quite overwhelmed by all of that information, but I hope you will not be bored by mine, because today I would like to show you some initial insights from the overview. This is actually overview from our latest study, which we conducted with K.I.D.S Foundation, and I have only 20 minutes, and actually I need to be on rush. I was exercise that, and I think I need to be like, you know, very fast to present all of I've prepared for you. So actually today I will present you something about the methodology, about the findings, and about recommendation, just to give you some context about that, just to give you also, just to tell you also about the insights. And what is the most important, I would say, also about to tell you about the recommendations. So I will start with study setup, because I think it's quite very important here, because we knew from the beginning that we would like to achieve here triangulation. So that means we wanted to use very different methodology, very different methods, just to combine that insights and compare between different sources. So we start with IDIs, because we knew that we wanted to create some safe space for kids once asking them questions about the stays on hospitals. And then we also used diary studies, journals, because we wanted also to catch long-term perspective, not only when we are on the same room with kids, but also when they have some kinds of an assignments, and they could answer the questions on their own pace with support of their families. And on the end, we also decided that we would like to have some quantitative method, survey, just to have bigger scale about our insights, just to present more numbers and have like stronger evidence about what we are saying here. These are the numbers. So we've conducted around 42 IDIs, actually we sent much more diaries and journals, but we received only 18 of them back. I hope we will receive them more in the future. And so for now, we have 100 answers on our survey about when we were asking about the experiences of kids. We were conducting that study on 4 major cities in Poland. It is very important for us because we wanted, you know, again, compare the data just to be sure that we are not missing any important insights about what kids experience once being in hospitals. 2, we also decided to divide that group, target audience by 2 factors. First of them was the length of stay, because we know that if the stays are up to 2 weeks, they are completely different if they are longer, more than 1 month, for example. And the last one, of course, age, because we knew that we need to prepare different scenarios for different kids, because they are, you know, on different development phase, etc. And also we have 6 research areas here, and you all find that in the report, final report, because today is only overview. I can only present you some initial insights. We were asking about daily routine, about education, about free time, stress factors, well-being, and strengths and weaknesses of hospitals. So it's quite a lot. We have a lot of these insights, and I think we have a lot to share to you. We can all use that. And also there was a lot of amazing volunteers engaged into that process of collecting that insights, collecting that information and data. It was around 23 people. I was one of them, so I'm today only, you know, presenting that on the stage. But there was like amazing job of that people who are behind that process. So I will jump directly into the daily routine, because if I can ask you, okay, so how that day is going on when you are on stage, when you are on the hospital, of course, the best answer will be it depends, and I will not use that anymore. I would like to show you why, what are the factors it depends. So, first of all, it's characteristic of the department. Then we have personality of the children's, and we have day of the week and duration of stay. So all of that factors combined somehow implicate very different routine for the kids, but we have some factors which are quite the same in Polish hospitals during all of the stays whenever people are. Okay, so here we have some points of the day which are quite constant in every single hospital we were conducting our research. So on the beginning of the day, we have some measurements like temperature, then we have meals, then we have medical staff rounds, then we have tests, we have also treatments, and we have free time. As you can see, for most of that points of the days, there are not very positive emotions, not positive factor for the children. Starting with measurements, because they need to wake up quite early, they cannot sleep as long as they want. Meals, you know, as a fact, it's nothing unpleasant, but it's more about the quality of the foods, and usually kids in Poland are complaining a lot about that. We have a lot to improve here. Medical staff runs, here is more about curiosity, because kids are very interesting about what will happen next, what is the context of their treatments. It somehow also helps them to cope with the situation of being at hospital. So this is very interesting for them. So it's like quite neutral. It depends from the situation, and and then we have tests. Tests maybe are not so bad, but you know, there is like a lot of anxiety, a lot of stress, because you know, then you need to looking for some kind of results, and we have treatments which are the worst, because you know, it's all associated with pain, injections, and all of that unpleasant feelings once being under that treatment. And we have free time, and free time is mostly positive, and it is something very important for that kids just to have better experiences. So daily schedule at the hospitals are quite similar for the children who are on the departments. But if they are for the first time in the hospitals, they have no guidance, they have no knowledge how to, you know, accommodate into that different environment, what to do, what to expect, how to prepare, and actually this is a big problem. And also, free time is limited. It's limited, you know, they cannot go outside, they cannot play as they used to at their home and the school. So we have here some problems, because we have limited individuality. We have less freedom, we have the need for quick adaptation, and we have lack of knowledge. And all of that insights combined are not very pleasant. They build that, I would say, not optimal good experiences, and we need to have that in our minds once building the next space and that experiences. So then I will jump directly into education, because this is very interesting, especially when we ask how they learn, how kids learn once being in hospitals, and most of them saying they don't. But I would like to give you some justification here. Most of them said that because the people who were the part of our study, they've been, you know, up that to 2 weeks in hospitals. So actually it's not such a long time, so they just don't need to learn very much, yeah? Because if they feel very bad and it's only 2 weeks, they can do that later. But then the second factor is I learn with teachers, then we have I learn on my own, I learn from books, so they have like very different strategies, and these scenarios I will let you know about them later. So about that school-age children who are under that 2 weeks period of being in a hospital, we have two major strategies here. So first of all, if they just don't have they do not feel well, they just do not learn, yeah? And the other scenario is that they learn with the help of parents and classmates, so it's like, you know, more individual work if they are conscientious and they are motivated enough to do that. So in case of longer stays, it's completely different, because it needs to be much more organized, structured, and we need to have here also more individual approach, because it's all connected to, you know, stage of education, type of the school, and individual motivation of the children. And here we have three scenarios. The first one, the most probable, is individual work. So they are doing everything by themselves, like, you know, they learn from the books, from the notes, from their classmates, so it's like very much individual work. The second scenario is individual lesson with teachers, so they come to the hospital and they provide them some support, and they just teach them about some chosen subjects. And the third one is remote class, so they are joining via video conferencing tool platform and have that classes online. But what are the biggest obstacle in Polish hospitals? So the biggest problem is with, this is the problem with concentration, because there is no space which is for study, yeah, and they have no, they don't have that, so they do not have their own desk, they don't have any room when they can focus apart from being on their room. So it's also about the change, and it's change about environment, change of teachers, change of the learning methods. So there is like no single model, yeah, that helps them have that education process. And I would say that this is like very big problems, but then we will talk more about the recommendation. And leisure, I mean free time. Free time is very important, and we ask kids what they are doing, and most of the time they are just searching, browsing the internet, using devices, phone, computers, etc., which we say quite normal, and I'm far away from being negative about that. But I've also asked about very different activities, what they do once being in the hospitals. So they spending their time with the family, they spending the time with hospital friends, they painting, drawing, watching movies and series, so we have electronic devices here again. And then the last 5, we have playing games, talking via social media, playing board games, playing alone, attending extra activities. So as you can see, we have a lot about electronic devices, a lot about, in general, internet, browsing the internet. And I would like you focus on that attending extra activities, because it was very rarely mentioned activity, because I will show you some additional data about that. So there is a lot of free time, especially once being on the longer stays. Children want to have that time as much similar as they have at their home or the school, and they would like to have an access to various entertainment, because they would like to choose what they would like to do and when, and they would like to not be bored once being in hospitals. So we've asked them how they want to spend their free time, and as you can see, and this is, I think, something very positive, they thought that they would like to spend more time with the other kids, with other peers on their age, because right now, especially if they are on longer stays, you know, they need to end that new friendships, and this is very important for them. They would like to have more that contact with their with other children. They also would like to attend extra activities, and we do not have that too much in Polish hospitals. If we have, they are very limited, like they are a few times per week, and this is a very good situation, but there is not like we have a lot of types of that extra activities, and this is something very important. I think we need to focus more time about that. There is, of course, spend time with the family, but other members of family, like grandmother, sibling, etc., not the guardian who is during the stays in the hospital. And then we have paint and draw, watch movies and series, play games. Actually, you know, it wasn't mentioned too often because they already do that. So that variety of entertainment is very important because it helps them cope with that very hard situation of being in hospitals, and we know that. And maybe it can be quite obvious for all of us, but I think this is the rule we need to remember, that free time, that leisure actually is very important, because it's something which will help them and support them once coping the situation. But we have also some insights about the hospitals from, you know, advantages and disadvantages. And here you have the whole list about what they said about what we can improve. Like, it's a lot of that. I will not read one by one because we would spend another hour on that. But we can see that we have like few different categories here. And we have what is the bad side of being in a hospital is, of course, that these are bad emotions, yeah? We have difficulty in maintaining relationships with current friends and new friends. We have poorly planned space, so we have no space for study. We do not have space for entertainment, usually. Also, there are some equipment shortages. So, for example, they do not have some kind of wardrobe. They do not have enough space to hide their private things, etc. Also, they have limited or no access to extra class. And food is like the very obvious, quite a big disappointment for most of the kids. So this is like one of the quotes. So small portions, still the same, no proper diet, which I require, no water, I have to buy everything. So actually it's something very bad, and that, you know, is very important once being during the stay in the hospital, but actually this is one of the biggest disadvantage. So what makes it all hard once being in a hospital is everything they lack. So they would like to have that experience as close as they have in their, you know, natural environment, in school and or in a home. And what more, also, it's being in a hospital is somehow connected to all of that bad emotions. I already said that, feeling pain, fear, inconvenience, lack of comfort. There is limited privacy. There is not enough sleep for all of them because, you know, there's like that scheduled routine they need to follow. Also, they have that limited contact with friends and limited activities. So, it's, you know, I would say that pretty all of that is about just emotions, yeah? But what is the very positive side of pediatric hospitals in Poland, and I was impressed by that, most of them said that they have amazing experience with medical staff. So they feel support, they feel empathy. And this is very interesting because I will be honest, I didn't expect that would be such a strong advantage. And what they would like to, what is good when they feel they have free time, they can decide about that free time. When the medical staff is well trained, once in relationship, once building relationship with children patients. And if they have autonomy about deciding what they can do, it also implicates their better experiences. I've also asked them about how they can evaluate different aspects of being in the hospitals. And here you have the answers. I just would like to focus I just would like you to focus on that very good answers, because actually this is something very interesting, because most of them say that everything is good and very good. But I would say that the strongest here, again, is doctor's approach of other staff, hospital equipment is, I would say, on the second place. That comfort, I would say, is, it should be on the last place based on that evidence from the interviews. So actually, it's not so bad, I would say, if we'll compare all of that. But we have some discrepancies here because, you know, they didn't evaluate so low that food, but once talking to them personally, everyone was complaining about that, for example. Yes, so this is quite interesting. So children likes everything what increases their comfort. Yeah, so they would like to maintain valuable relations, autonomy, privacy, and diversifies their stay. This is very important. Okay, ideas for improvements. Actually, I think I've been quite fast here. We have here 5 ideas, I would say. So I would start with something which we heard on the beginning. Before going on the field work and starting to cooperate with children, we have that meeting with psychologists who say there is no way that they will tell you about some positive experiences, about a perfect day in hospitals, because it is something very unpleasant. It's so unnatural being in hospitals. It's connected to feeling pain, stress, and anxiety about the future. So it's not about making the day perfect. It's about, you know, somehow give children that opportunity to better cope with all of that situation. But we have some dimensions which I think we need to focus once creating that better experiences. And we have space, we have free time, we have medical staff, we have accessibility, we have equipment, and we have rules. So I will start with the first one, if that will work. Oh, okay. So the first one is about the comfort and about equipment. Because, as I said, they feel like a lot of lacks. They do not have the same comfort as they have at houses. So sometimes something very, maybe not silly, but quite easy, like more comfortable mattresses. They would like to have more wardrobes, as I said previously, cupboards, space to hide private things, So it's like very basic, yeah? I would say that we're supposed to have that already. They're supposed to have desk for doing homework, etc. Then we have the point about the medical stuff and about how they treat the children. And this is also very interesting because I think we should have some kind of regular training for that, ensuring that employees have very golden standard once providing and talking to that kids and their parents. Because still we have some incidents when it's not perfect, but we know medical staff is overloaded and we need to somehow support them in that. So probably they should have some trainings like on a regular basis. So we would like to have also more about introduction of educational lessons when doctors are explaining what's going on with their treatment, what they can expect, and all of the implication. They just would like to know more, just to better cope with all of that fear and anxiety. And also it's not only about education, it's about informing them about what next. So they would like to know the steps of their treatments. And on the end, but actually last but not least, psychological support for children and parents. Actually, we do not have that very present in Polish hospitals, and I think we should have, of course. And this is very, very important. But, you know, someone today told about that app which can help here. So space should definitely be more functional. So most of them said they would like to have individual rooms and with private bathrooms. They would like to also have that interior design more cozy, not that hospital style. They would like also have that separate areas for study, for rest and relaxation, and would like to also go outside, which is not this is very interesting, but I wouldn't expect that would be such a strong insight, but mostly all of them were telling that they're missing that very much. They also told that they would like to have rooms for friends and for the parents, just for them being more comfortable once visiting them. And on the end, we have also facilities for people with limited mobility. And this is very interesting because I didn't expect that we do not have that, but sometimes it happens. And once creating and designing new space, new hospitals, we should really remember about that accessibility issues because this is something crucial, yeah? Usually most of the people have limited mobility once being in a hospital. It's like normal, I would say. Okay, and free time. So maybe I'll just wrap up that very fast. So they would like, of course, to have TV channels, TV with educational channels and with cartoons. Availability of various extra activities. They would like to have common room, which will be open for long hours. They would like to have the presence of educators who are somehow moderate that free time, moderate that activities, because it's also not about what they will do, because, you know, still these are children. Sometimes they need the support, sometimes they need the guidelines, and during that time, and it could be a good trigger for them to spend that time with better quality, I would say. And good Wi-Fi internet, yeah, of course, it's like normal. And the rules, it's not about, you know, how it is, how they experience this. Sometimes it's only about, you know, what is on the piece of work and what they can do. So they would like to have possibility visits from their friends. They would like to have simultaneous presence of two guardians, because sometimes it can be only the mother, only the father, only the guardian, but they would like to have that bigger support. They would like to also have keep silent before 7, because sometimes that you know, people are doing a lot of noise and they cannot speak, they cannot rest properly, and then they would like to have silence in the halls. So just to wrap up, because I think that I gave you like a lot of very different insights, and I hope you will all read our full report. So what is the perfect hospital of the future? And actually today Sabina had amazing workshop with children when they were kind of, you know, working of that. They were sharing their ideas, what oh, and this is not working. Oh my God, this is very bad, but actually we're supposed to have. So I will tell you that, and then you can see that, because we have, there is a board when it's, where it's all drought. But actually, it was about having that zero-touch treatment. So with no injection, no pain, no fear. It's about having some kind of guidance in the presence of some kind of, you know, for example, pet will tell people what to do, to children what to do next. They would like actually to have onboarding. They would like to know what is the routine in the hospital, what they can expect, what would be their treatment, how they can better cope, etc. So they would like to have that onboarding experience and that support, and also that environment is supposed to be as close as possible to having that good natural environment at home. And guys, thank you very much. On the end, I just wanted to say that this is the research team. So the people mentioned here were conducting that study. Actually, as I said, I'm just only here for the present and just showing that to you. But yeah, big applause for them, if not for me. Thank you very much.
Great, thanks a lot. We are slowly but surely coming to the end of the conference. We still have one more panel after the break. And this will be the last coffee break that we will have. So I don't know if you guys have seen the bunch of the wolves which are waiting for you over there. There is a pack of wolves next to this beautiful young ladies selling them. So if you guys are coming back home, wherever you came from, and you would like to buy something in the airport, don't do that. Bring this wolf instead, you know. This wolf, actually, all the profit from this wolf goes to all the kids projects, to the foundation. So thanks also to that, the Kids Foundation can thrive. So that's a small commercial and advertisement. Let's have a short last coffee break, and we will see each other at 4 p.m. Thank you. Come back after the break. Right now, we have the last panel discussion of this evening, of this day. We will talk about the patient experience and their critical role in the research and innovation. And to delve into this panel, we have Begonia Nafrai, Patient Engagement in Research Area Coordinator, Senior Expert on Patient and Public Involvement from K.I.D.S Barcelona Foundation. Quite a long name. Please welcome Begonia on the stage. We have Dr. Michał Deszczyński, an expert in the coordination of deformities and limb lengthening from the Pali European Institute. Welcome on stage. We have Kasper Reitz Mathiasen, lead play designer at Mary Elizabeth Hospital. Yes. And last but not least, the panel will be hosted by Joanna Sobolewska, a patient, parent, and founder of the Project Dignity Foundation, as our moderator.
Good afternoon to everyone. I have to say that this is my third time in this conference, and today I'm coming as always as a parent. And it's amazing to see that we are starting the discussion between the doctors, the researchers, the designers. And today I would like to start the whole discussion about research and innovation with this thing that have changed completely this what I'm doing today and my way of thinking about the medical field. My younger daughter, who is now trying to sell the wolves, I'm promoting them as well right now. She went through the surgery in United States. The first day that we have entered the hospital, it was the day before the surgery. Someone has been thinking about the way how she will be feeling, and they have invited us to visit the hospital, to talk with her sister, with me and my husband. Someone was looking at the reaction of us, and someone have thought how to convince, at that moment, 3-year-old girl to go through the surgery in a way that 1 year after, she was saying, "Mommy, mommy, mommy, can we go to the hospital? I would like to go there." And it was this thing. What they have did, before the day of the surgery, they asked her, "Jadzia, would you like to have a special mask? You can select your color." Of course, there was this pink and the blue color. She selected that one. the minute after, they gave her the stickers. Of course, she could select the stickers in order to personalize this thing. But then the real magic have started when I was asking how the procedure will be carried. Will you be using the needles? Because she's afraid of the needles. And then they said like, no, no, no. Let us concentrate on her right now. Now I'm trying to find one thing, which is a lipstick. There was a girl who came to us, and she had a box full of lipsticks, different lipsticks with different flavors. And she asked, what kind of smell would you like to have tomorrow that will be coming from this mask, because this mask is magical? The lady, she had, I think, more than 20 already used lipsticks. And the task, Jadzia had only one, to select her favorite taste. At this time, when she was doing, and she was super busy, of course, with her sister, we were given instructions what will be happening the next day. To cut the story short, after that, the lady said, can you open the lipstick? Can you put the lipstick inside? And now you can smell it. The task was to take this at home, to change the environment of this thing, and to normalize something that will be used the day after. I was observing this, working as a customer experience manager in different companies, and I didn't realize how important it was, because 1 year after, when we went to the hospital, when my daughter, she saw the leaflet in the hospital when there was something similar, it was this only one spark that have said to her head, there was a nice thing inside of the hospital. And for me as a parent, it was a great relief that she's not afraid of the hospitals. I have started this panel with this story because this is US experience. When I came back, I thought that it will be never possible to see this kind of things. And today on this stage, I have 3 people who exactly know why this is so important. There is one person who is using this kind of things, you will hear later on. And there's someone who knows how important is the play. So I'm super happy that I'm sitting today with this kind of with this specialist, with this mindset, and that I think they should be now saying who they are, what they are doing before I will ask the first question. Thank you. Kasper.
Yeah, hello. My name is Kasper. I'm a play designer in Mary Elizabeth's Hospital in Copenhagen. And to you that don't know what a play designer is, it's an experienced designer that designs with play in mind. So environments and tools or whatever that is building upon play mechanics. Yeah, not necessarily just for kids, also for anybody, just for humans.
Thank you, thank you. Michał.
Hello everyone, my name is Michał Daszyński. I'm an orthopedic surgeon. I run Pediatric European Institute. It's a center specialized in deformity treatment, and especially for children and young adults. So when I was a resident at one of the public hospitals, it was very difficult to me to accept the realities and the environment that I was working in. So I decided to change something in my life. I went for this quite long fellowship to US when I had the chance to see different setups of hospitals, of working environments. And then after this year, I came back to Warsaw, and due to my experience I've gained abroad, we set up this institute where we treat children and try to help them in very different pathologies regarding musculoskeletal system. Thank you.
Good afternoon to everybody. I'm Begoña Nafri. I'm working at Sant Joan de Déu Children's Hospital. This is the largest pediatric hospital that we have in Spain. And my role in the institution is to coordinate a department that is fully devoted to incorporate the voice of children, young people, and parents, in this case in research and in innovation. And for us, it's a value and a principle of the institution to involve them in any activity. There is more tradition probably from the patient experience side in healthcare, and it's more challenging when we work in clinical trials and in innovation, but never it's late. And for us, it's a must to be sure that in any project our families are involved. And this is basically my area of expertise.
So knowing that, and I just mentioned about the US, I think the first question will be, Begonia, to you. What about the perspective of European Union? How this engagement of patients, kids, and professionals, how important it is, and what you can see right now?
No. In this case, Europe, and talking about research and innovation, it's more advanced than the US. Surprising, but it's more advanced. The context is different. In the US, probably the needs to involve the families and the patients are more in the healthcare, in the advocacy, because you know which system they have. But in Europe, we are lucky because we have public systems. And what we saw is that beyond to involve the patients and the families in the design or in the improvement of these services, the priorities at the European level were to promote more pediatric research. And in this sense, in 2007 was published the pediatric regulation. Nowadays, we have more research, but of course, it's not enough. Still, we have more, a lot of conditions that we don't have any therapeutical solutions. And recently, and I think that at this point also we are so advanced in Europe, last year was fully implemented the European Clinical Trials Regulation that encourage all the research teams to involve patients in the design of the protocols, that this is the right moment to incorporate them, because there are many decisions that it's going to be hard to adjust or modify afterwards. And in this sense, Europe is so advanced, of course, in the adult setting, because always it's first, pediatrics is always the last priority, but in the involvement of children and young people, we are doing a good progress, not only for this regulation, also because in 2017, with other 3 pediatric hospitals, we created a network of young persons advisory groups that we also coordinate from Sant Joan de Déu, and later on you will see a couple of our members that also have been part of the jury. And what we try to do is to coach and to teach and support other colleagues from other hospitals. We are working with the Children's Hospital here in Warsaw. We are working also in Denmark, across Europe, to replicate this model that at the end what it's promoting is to change the method to do research and incorporate the participation of patients and families from the early stages and of course until the end of the process.
But we're saying about the framework, about the process. Michał, talking about the innovation and the research, you as someone who is practicing, what the innovation means for you? I know that you like coding and you're pretty good with these things, but what does it mean for you?
So yes, that's a very good question. So it is very important in nowadays how can we help the professionals to focus more on the patients rather than on the bureaucracy. But still, I find it very important that the human factor and the human resources play a very major role in all of this, because at the end, if there is no empathy in the medical staff, you can have all this innovation and research and still it will not work as it's supposed to. So that's what I'm trying to, every day in my work. Of course, my main place is the operating room, operating theater. And as a physician, it's very difficult to participate in other activities like research and innovation, which I really love. And when I was a resident, I had this big problem because I had to fill out tons of forms working on the floor. So I came out with my own EMR software, which was just coded on a low code platform. And then I just share it with my colleagues that they can use it. But at the end, someone from the CEO of the hospital almost fired me from the hospital because it was the very beginnings of EMR systems in Poland. So I was almost fired because I was trying to have some kind of innovation in our working the daily routine, so we can focus more on the patients and on their needs. So that's a funny story of mine. And I always try to go not with the wave, but against the wave. And innovation is very important, but we must remember that the medical staff and their education needs to acquire some tools. How can they work with patients on daily basis? It's very important. How do we talk? How do we introduce ourselves, how do we explain the processes that our patients will go through. And I think this is very important. And we must not forget about this area of this, which is the part of the whole process.
And Kasper, how, because you with your design thinking and a lot of ideas, how then healthcare professionals, patients, parents, how they can collaborate to make the change?
We are doing what you said you want to have done or be able to do, and most of the new things we create in our hospital, 90% of it comes from the practitioners. It's bad ideas. You guys get lots of bad ideas. You see clear problems and get a bad idea, and then people like me can make that idea better. But I will never get that idea in the first place that would fit. So together we can make this work. What I'm struggling with is how we make research, like scientific research, fit in this equation. It's difficult, but we also need that third party. So to me, like the triangular process of having the practitioners with the bad ideas, sorry, but you probably get good ideas, but some people get bad ideas. And then the design thinking, the methods and ways of understanding needs and wants and all that, and the process forward, and then also then validate and prove that this is valuable to do, prove that this has a certain effect, so we can counter it, because we are all in scarce budgets, so we can't just do anything that looks fun. And then the last part that we also try to bring from the design team is a view on humans, like a perspective that we don't distinguish between children and grown-ups. We don't see play as a thing for children, and we're not trying to make a hospital that is child-friendly. It will also be child-friendly, but it has to be human-friendly, and it has to be treatment-oriented. We need to use play to make better treatment, to make a more humane workplace, and so on, and that needs collaboration between all three parties.
Can you give us some ideas of the things that were coming from the doctors, you have changed it, or maybe they were coming from the parents?
Yeah, one example that I have is, I probably don't have the words in English for these things, but we have some children that are in isolation for a while. They got a bone marrow transplantation, and they get some medicine that tastes really, really bad. And to make that easier, they have to get that every day. We put in a tube into the stomach. What is it called? Like something like that. And that's not nice to have done, like put that in. And so we had this nurse that had tried to create this, like to explain this to an 11-year-old girl, that next day she was going to have this tube. And she explained it to her with a teddy bear, and they used some tape and scissors and stuff, and they built this version of it on the teddy bear. And they, with the syringes, they could put in like red juice or milk and stuff, and in and out of this bag and play with it. And then she was kind of, hey, now I get it. Like, this is a thing in there, I can put it on it. And the next day she was just fine having this done. Then this nurse comes to my team and says, I have this great idea. And we're like, super idea, we can tweak it a bit. Let's do this in a way that we can implement as a mindset everywhere, and that every doctor or nurse has available and so on. And she did a small comic book. We helped her make that like great. And suddenly we have like a dialogue tool that anybody can do and use in many different ways. And then we try it out, and then we probably learned that this is way complicated, more complicated than it has to be, and then we can continue to tweak it, but we do it together with her and together with some families and different departments also.
I remember you was telling me something, because today there was a presentation about MRI scan, that you were also struggling with that part, and I think this is super easy solution that we could be sharing as well here. You don't remember?
Which one was that?
The 95% of the kids, they don't need to go through anesthesia.
Oh yeah, we had this. Yes, we have I think our friend from Siemens almost mentioned it, but we have had this project, scientific project, without designers in it, where they had the children that was going into MRI. They came a few days before and had a practice session. We have a mock-up scanner that could do all the sounds and stuff. No magnetics, but the rest looked the same. And they come in and they can try this out for a while. It takes about 35 minutes. And we have a 95% drop in general anesthetics in this project. So now we're testing some more. Like I think it's around 60 children have been through this. And we're going to do a new round of this and so on. And yeah, so there are easy fix also. Yeah.
And what about now about the challenges and barriers in the research field? And I think I'm looking at Begonia because I think you know quite a lot in this area.
Yeah, we have many challenges. Probably the most tricky one, because it's not easy to adjust or to change, is that in some cases we take for granted that implement a clinical trial protocol with children for a drug that has been studied in adults, it's going to be the same project exactly. And children, I suppose that you have been speaking today about this, are not, small adults. And really, this clinical trial needs to be a different protocol. This is probably one of the challenges, but we have many other ones about formulation. Sometimes we don't think that children, they have some problems with some formulations, pills, the taste, the palatability. There are many elements around formulation, and still we are facing a lot of problems to have the right formulation for each, let's say, age different group. And in terms of the experience, when we design these trials, sometimes we forgot that children are children. They want to go to the school, even sometimes it's surprising. They want to go to the school, they want to go out with friends. And we are designing trials sometimes to be very sure from the research side about collecting many data, to be strong on this and to do a very quality project. But in some cases, all this data it's not used. And what we are adding is a big burden to these kids that, of course, they go to the regular standard of care of visits, and on top of this, many other medical procedures and visits of the clinical trials. There are plenty of things to change, and just when I was listening to my colleagues, I think that there are two important things in this equation to change this paradigm. One is to train also the professionals to make closer to the parents and to the children and to have discussions and involve them in their projects. At the end, it's a change of mindset. But on the other way, it's the methods and the opportunities that we offer to these patients and to these families to work with us. If we don't adjust this, it's going to be so difficult. And for this, what we did a couple of years ago in our institution was to design a patient involvement strategic plan that is working with all the departments, for example, with the human resources, and we do every year training for our researchers to explain what means co-create a clinical trial protocol or an innovation project together. I think that there is something in the roots that we need to change, because if not, still it's very isolated, the experiences that we have that are good, it's common sense that are beneficial, but still it's a very small percentage of projects in which we really involve in the right way the patients and the families.
So, regarding changes, it's also very difficult, because from my experience, like when I became an attending and, finally as a doctor, I could decide, myself how I will treat and where. And, in my institution, in the exam room, what I start doing, I start removing the desk, because the desk is the worst barrier you have in a room. So, in a room, if it's in an adult or a child, there should be no barriers. So I was keep, putting this desk at the wall, but it was keep returning. And every day I started my work from moving the desk. So finally, somebody called me from the CEO, and they told me what I'm doing. It's because the ladies that are at the end of the work when they have to put it back. So, and then I said, no, I will start my own clinic, where I can do things that really I want to do. So it's very difficult even for the young doctors, to start something and start the process. So the same in our clinic, for example, we have these specialties days when we all dress as pirates, superheroes, so the kids don't really feel that they are in a medical institution. So we also have this, and Joan, you know it very well, we have this special bell. So maybe this is that you can talk about this also, but it is so after each therapy and when the treatment is finished, So each child has to announce that, I did the surgery, I had like 30 days of therapy, and my treatment is finished. It's just part of the treatment is finished. So I want to announce to everyone, and we all gather in our lobby in the clinic, and we congratulate the individual that we're happy for him that they did it, and for us they are the most important. So there are many small things you can do in your practice. You don't need this funding, like just really small things you can change in your daily routine to make it better. And that's what I would advocate from my side, is sometimes just zoom out, go above this labyrinth of very complex and difficult processes, but you can see and do some minor changes, and that will make a great and successful impact on your daily work, how you do it.
Kasper, would you like to add something? Because when I'm thinking about you and like this what you're doing, and I saw you somewhere internet, the Lego story. So is it difficult to go and to change the mindset of the professional? Because like the story that Michał said about this bell, guys, I went to 5 different clinics and I said, let's do the bell. I will produce this bell. And the story is super simple, but everyone was saying like, but our kids are having really long life therapies. So they are coming here every month or every quarter, and they cannot finish this treatment so easy. So even, like the mindset that my therapy have finished this month and I have the right to ring the bell. Do you see this kind of obstacles when you are coming and, like designing? Because you are interrupting the daily operations.
We try not to too much. I think that we also have a bell that they ring when they have done like a chemotherapy for one round and so on. And we talk about other ways of making a mark, like celebrating and so on. I think that we are aware that we are changing culture, and we are aware that it takes time. So right now we are super friendly. We meet the practitioners with the ambitions that we not necessarily show that much, and then we try to mirror their own ambitions where it fits our ideas. And I have never met, I have maybe met one, but not that many that are not on the same team when it comes to actually making it a better experience. We have a lot of doctors and nurses that fully believe that they are allowed to do better treatment if they have a better relationship with the family, that the child are better at being examined if they are cool, and the child is cool if the parents are cool, and so on. So like they know that play can help this, and the environment helps, and also I think what is maybe needed is in a very rigid and rational workplace and system of a hospital, the maneuverability is missing maybe. So you have room to do things in a new way and improvise, being creative as a practitioner, because they are already all the time, as I experience it. But I think we should maybe acknowledge that skill. To me, the hospital is one of the most creative places I've worked. They are constantly doing things in a new way, have to react super fast, find new ways to solve a problem or a new situation, and things are happening with very short time limits. So I think there are maybe some power to release in that area also. And that's what we're trying to do slowly over the next, we open in 3 years, so we have some time yet to, yeah.
Amazing to hear that the hospitals are the most creative places.
One of them.
Bueno, okay. What is the second one? Apart from Lego?
I'll be the first.
Oh. Okay. Yeah. Okay, now I would like to ask Begonia how patient engagement can enhance the research and innovation process, because you said that there are some barriers, but how important is this young patient voice?
Yeah, for us it's the only way to really, be in the other side, because professionals, adults, of course, we have a bias, and the teenagers or the young people of the present moment are, so far from our present moment. And the ways to have this different perspective, they have, a unique experience. They live 24 hours, 7 days per week with a disease, and they are facing many other things beyond the disease. And this is the value that they provide for us to the projects. Of course, we never discuss with them, for example, the mechanism of action of a treatment. There is no discussion. It's a scientific, element. But we can agree with them if some components of the design are acceptable, if we can improve this, because at the end, if we don't have this early dialogue, at the end we have problems in recruitment, in adherence. And for us, this is the value that they provide to us. We have different methods and different ways to do it. And also we are trying to innovate as much we can, because many years ago, basically, the involvement of children and young people was with interviews, questionnaires, and they don't like this, and sometimes it's very, narrow the opportunities to get their feedback. And nowadays, what we are doing, it's innovating in methods, and beyond patient journeys, co-creation, and all this stuff, what we are doing is simulation of clinical trials. And this is, the most realistic, and we refer high realistic simulation, the method, the most realistic way to test everything before this will be implemented in the real world. And we are getting very important results. Basically in areas that probably we don't have too much experience, because everybody now is talking about digitalization, decentralization of clinical trials, but in pediatrics, still it's something not really implemented. For example, about the electronic assent process, we have in our hospital more than 350 trials working at that moment, and in none of them we have seen these tools. And with simulation, we can anticipate, we can adjust things in the right moment, and we can really design and execute patient-centric, a very marketing concept, clinical studies or any other project. For us also, patient and public involvement, it's an area to do research.
I like not really like, this what you said, the marketing and patient in the center. I don't agree that this is a marketing thing, and why?
It's used.
Yeah. No, but I would like to now call Michał, because I remember a few years ago, we did an amazing research inside of the institute where we were mapping the patient journey. And to be honest, I thought that, okay, it will be another, like marketing thing, exactly like you said. But then what the institute did with that, they really took it and they were implementing a super easy ideas where you don't need a clinical trial. I will just give my example from 5 months ago. When my daughter was under the surgery, she was in the operating room with Michał, I have received a 3 WhatsApp messages from the lady who was like a patient care coordinator, who was informing me what is the current stage, not to be stressed downstairs. And I knew that, okay, the part of the doctors is finished. Now they're, like putting the stitches. You could be seeing your daughter in 20 minutes. It was amazing. It was super fast to be implemented. That's why I would like to emphasize this patient in the center approach, even small research that is being done. And I don't know, Kasper, Michał, you could be giving more examples, because this is just, like my personal experience with that. But there are tons of the things that we could be calling innovation, and they are really doable.
So, I can say, like, this is very unpopular, but what I think that the doctor, he needs to step down from the spotlight. So we need to introduce other parties, like the parents, design team, the research team, to have a voice in this whole process. It's very important, because honestly, I just want to focus on my patients, and that's the most important thing for me. And we have to finish with, especially in our country, with this patriarchic system, when the doctor is the most important part of this whole riddle. But it's really working when you work in a team and you accept other ideas, and you as in our institution, as you said. So in one day we can change the whole process of how we interact with the patients, and it's amazing. Imagine doing this in a big hospital. It's impossible to make a change. And as you said, instantly we can change all the processes in like 2 days with our patient coordinators. And so I don't know how it's, how can this be implemented in like a bigger, institutions, but it's possible. Maybe smaller teams, and give them more freedom how they want to work and with whom. That's what I think.
Yeah, the freedom part, right? So you have the maneuverability to do what is fitting for the situation. I don't think we can do WhatsApp stuff in Denmark, actually. I don't know if you do all your patients' families, but when it's needed, then you do what you can do that makes it work and be better. I think that making space for all those things is a way forward. Yeah, we have one example of one problem I have with the pace of innovation in hospitals that's coming from the outside world. That is really, really slow. Like a PhD takes 3 years, and I like a bit faster pace. So in terms of getting recruit test persons for a test and so on, when it's not medicine or critical equipment and stuff like that, but just experience stuff like new bed sheets or colors on the walls or whatever. I need someone to have an opinion as a user perspective the next day. And we did this, we call it the Test Bunny panel. We have around 1,000 people now in this Test Bunny panel. It's old employees, it's families, it's everything. And it's a scientifically approved onboarding system, and so, but we can search for certain people. So if I need 2 women that gave birth within the last half year, I can find them and ask them, do you want to come, and I need to show you this thing and get some input. So the pace is up. And then when we got something that makes sense that need to test for real, then we have a research team that takes over. So, but that goes all the way back down the other way also. So when someone gets an idea, but lacks maybe the technology or the graphics or whatever, we talk about having design service available for our practitioners, so someone can help them 3D print a thing or graphics or whatever they need, like fast, to try an idea out in their practice immediately.
Amazing. Just I think to close the discussion, I'm not just the parent of 2 girls. I'm representing here, I think, families who are trying to navigate through this super difficult for us healthcare environment reality. What, from your perspective, from your area, what could be done, changed, how we should be thinking to live in a, I don't want to say better, but easier reality for parents and for kids? I know we haven't agreed with this question, but
no. I was thinking that it's complex. No, it's not agreed, no problem. I like the surprise questions. But I think that it's complex to answer because it's not only internally in the system, sometimes it's in the society. One example, we organized 3 weeks ago a conference in the hospital, and we were looking for parents to explain the experience of being involved in a clinical trial. I had to call many families because not for the interest to participate, because all of them, they were willing to explain their experience. But in this case, they said, I cannot do it because I can lose my job. I'm a lot of days in the hospital for many hours. I need to compensate this time. And in this case, I'm asking for a permission for a couple of hours for a conference, not to go with my child to the hospital. And this is one example about the society. We are not aware about what it means to live with a child with a chronic, complex, and in some cases also a degenerative condition. And in my case, that I'm from the research, field, everything is on top of the standard of care. And I think that we need to change things inside, of course, and outside. And inside, I mentioned training of the professionals. Sometimes the most reluctant people, when they go through projects and they see the benefits, they come back again and say, okay, I want your help. And another thing that we don't have mentioned is that to change everything, of course, you need the right people there. You need, that the CEO or whatever takes decisions will, invest in staff to do all these activities, because at the end it's a matter of time and resources. And surgeons, they need to do their work, but the people working in the patient experience and the patient engagement areas, they can support them. And I think that this is the right model. Work as a team with the experts in this staff, with the patients and the families, but also this requires, an investment and the support from the institution to change, everything around, because it's impacting all the departments of the institution. But it's a complex but a very good question. Thank you.
No, I lost 2 jobs because of the surgeries, yes. Thank you. Thank you for this part. Michał?
So, what I always try to do is to think, if I were the patient, what I would, expect. And that's very important. So the second thing that Begonia said, that, throughout my professional career, it's a big word, I was lacking true mentors that would help me, to guide me on my road to success and to better treatment. So this is still a big problem, that, because of these funding problems and these other, the doctors are so pursued by achieving the results of financial results of the department, which is sometimes a big obstacle to think out of the box, because we are so focused on the financial aspect of our work. So that's the second thing, and and the last thing is because I became a part of my family that is have a big medical problem, and we had many conversations in the corridor and in the places that were not suitable for this. And this is also, again, a medical education is a very important thing, and we need to stress out these points: how to educate young doctors, how can we motivate them, how empathy is something that you're not born with. You can really learn this, and you can really approach differently, to your patients, and to care more about them, and and that's why we became doctors, to help other people. So this is number one of our work. So again, this is not something that we are born with. We need somebody. Some people do it better, somebody worse, but it needs to be the part of our education, I think.
Thank you for this voice, Kasper.
I think that we in our hospital in Denmark, we're trying to create a place that focuses on the family and not the child as such. We want to create a better hospital stay for the whole family, of course for the child and the treatment's case success. But we also want the family to get back to a good life afterwards. We want the family to stay together. Less divorces, less loss of jobs, and so on, and siblings that also thrive and don't get additional problems in the family. So we try to encompass all of the family's needs in pursuit of helping the child. And some of our children, they don't make it. So we still have a family that needs to work afterwards. That's what we're trying to build a hospital for. So a more holistic idea of the family around the child, which also means that we're going to mobilize the parents better in being part of the treatment and the life of having a chronic disease maybe. And we are also trying to push more of the treatment home so they can have a more normal life at home. But that also needs a lot of training of the parents and collaboration and earlier bridging the gap between home and hospital and so on. So I think that is the mindset we're trying to create. And then as a practitioner, being able to be okay with this new broader scope of treatment and not just fixing the body that is sick, that we don't do here, but some places that happens. Yep.
Thank you so much. I don't know, how do you feel, but I feel that this is a great step, and I would like to say a big thank you for the organizers, both from Spain and from Poland, because I have the feeling that with this kind of people and with all of you, we can really build, as Begonia said, a society, and like Michał said, with the great mentors people, organizations who could be caring not only about patients but also for the whole families. And I'm really honored that that I'm sitting here with this mask and that you were listening for 45 minutes. These important people. Thank you so much.
Maybe there is a question from the audience, because we still have 5 minutes, although we were pushing this agenda, to go forward. It happens that we still have 5 minutes. So if any of you would like to ask any questions, or question, maybe not plural, let's make it one. And if not, I might have one, because kind of a big topic right these days is human factor studies, basically, which are involving many times the end user, and the end user in many cases is patient, So I don't know, like, what is your approach? Do you work with human factor studies? Do you even know about? I know that in Poland it's kind of hard, because once I was looking for a company which would do the human factor studies, and I couldn't find one. And I know that the K.I.D.S are trying to do something like this in the experience in the hospitals, like in the memorial hospitals. But is it like a normal practice in your ecosystem, in the world that you live in, that you are super inclusive and engage patients and actually do 10 interviews, at least 10 interviews in theory with those patients to actually get to know what are their needs to project or to design something which is the best for them?
Yes.
Thank you.
I'm a bit baffled about the question, actually, because in my perspective, you can't design stuff without talking to the users. I'm not fully on board on end users. Like, there are many users. Like 50% of my users are personnel. 25% of my users are parents. 5 to 8% of my users are children that are awake. So you need to know your users, and around those users what other stakeholders and so on, but you need to talk to them a lot. And sometimes co-creation is not having like the child and you co-create stuff. It might be together with the parents and so on, but that's a mix you do. But if you design stuff, it's not about how it looks and how it works. And you need to be doing that together with the ones using it in the end. So we do that only.
I'm referring, for example, because many times you have, sometimes the public money is easier to get than the VC from the market. So to get the money from the market, you really need to show that there is a need for this design. But if you're a researcher and you are looking for the public money, it's easier for you actually to focus on your area expertise, or what do you think is the best, not what is actually the best or what is needed, like in the market. This is maybe why you have the more business approach, I would say. But the same with the co-creation of the, of the rooms for the children, for example. I had experience once that there was a hospital which was about to renew the admission ward, the ER, let's say. And I actually started to talk with them because this hospital was close to me, and I asked kids actually to come on board. And I told Sabina, who is the UX lead in the K.I.D.S, let's go to this hospital, let's design a workshop for them and maybe help them to co-create the space, because they're right now in the stage where they need our help. And during this actually workshop, we heard that people were confused. We're like, you ask us to bring on board surgeons and doctors and the management and the nurses? What for? We are talking about the design of the ER. What do you need them for? And we said, like, really, guys, this is important. Let's bring them together. And during this meeting, we told them, you know what? And it would be best as well to bring on patients and ask their opinion. And they were like super confused and freaked out. Like, we're going to ask patients about, how they want to have the route in the hospital, in the ER? Yes, actually, we would love to do that, But it's still not a mindset that we have in many places. Maybe in this perfect world we would have that, and I would love that. But still, I think there is a lot of education needed to be done, and panel discussions like this one that will include all the stakeholders needed to make it happen.
But sometimes you don't need very sophisticated research. I will just give you an example from the clinic. And the lady, she's actually sitting here. She's from the marketing department, and whenever I'm in the clinic, and I'm pretty often over there, she's coming and she's saying, like, is there anything that I can do for you? Or after the treatment, when the doctor is leaving always, Michał is leaving, there is a lady who is a patient coordinator. She's always asking, is there anything else that we can do for you, or anything bothers you here? So this is about this also regular feedback that you are being asked. Me as a parent, this is super important. And then after a few weeks, I see that all of these things are happening. All my voice is being heard. So this is also a great word of mouth that I could be creating as a parent, as an ambassador of the place, and as an, I think, active family member of the child who is being treated. So
a follow-up, what do you think about the NPS score or any kind of a questionnaire after you're in the hospital? Because usually, at least in Poland, when you enter the Google Maps, for example, and you look for hospital, when a hospital has 2.5 stars or 3 stars, it's like, whoa, this is amazing that they had 3 stars. Because usually the people who leave feedback are the people who got annoyed or who were treated badly, not the ones that actually had the good experience. Maybe they used the word of mouth, as you mentioned. So what is your, as well, opinion on the NPS from the patient side? This is not a medical tool. It's more of a marketing tool in the end. But to some extent, it kind of may show some kind of a quality, at least in the service that we have in the hospital, or how you're treated.
I think NPS is a good factor, but it could be used in 2 ways. One, it could be used as a navigation among different hospitals, different clinics, competition-wise. But if you have internally designed the process of data gathering and data analysis in a way that really the stakeholders could be receiving the proper information, and then they have the willingness to do something with that, then it's a great tool. It's a great tool. You could be having a regular CSAT, or the lady who is sitting and is asking, is there anything that I can do for you? Unless you will not do anything with that, it's totally useless. So it's
feedback loop.
Yes, not really feedback loop, but the engagement of people. They need to have the feeling that I can do something with that, and this is really meaningful. In the big organization, you could be paying an extra bonus for that, but in the healthcare, I think you need to have people either with passion or great mentors who could be showing you that it really matters, that this is really changing the lives of people.
Great, thank you. Thank you again for this panel discussion.
Thank you.
Thanks again. So right now we're going to have a moment that we were all waiting for, at least the participants from the EAT wildcard, but I think after all those speeches that you saw, you are still interested and you would love to see and hear who actually won this competition. And to actually say the last words and tell us about who won the competition of EAT wildcard, please welcome again Celia Pita from EAT Health.
Hello, everyone. So I have the rare honor to be second to last, and I'll make sure to not make this longer than it needs to be, but at the same time, we wanted to make sure to finish with a bang our wildcard program and all the work that we've been doing for the past almost a year since we started in the inception to the challenge to the culmination of the pitches that you have seen today. First of all, I would just like to thank our hosts for having us here, and Paulina and the team for all the organizations that have done, and i4Kids for having us here. It has been a rare pleasure. Yes, please. So really, thank you so much. It's been a pleasure. It's been very welcoming to be here in Warsaw. So what we're going to do, and you might be wondering, wildcard award ceremony, what are we doing here? So as I was saying, this is a program. It's not really a competition, but we have something in store to kind of acknowledge all the work and all the amazing innovations that you have seen today. So I would just like to start bringing to stage every single one of the teams to give them the certificate for the completion of the wildcard program. That is no small feat. As you said, as I was saying at the beginning, we started with 16 teams. Now we have only 7, and it was a hard-use competition to get here. So first, I would like to call on Joan Life Science, Marc, Ryan. Let's really thank you for all the work. So I don't know if you want to say something about the journey so far, Marc. What do you think? Put you on the spot.
No, it's no problem. Yeah, what I said to Magda and last night was like, you know, EIT had the nerve to put deadlines on our dreams. I think people here have really good intentions and big plans, and it's all very exciting. But then you're getting pulled back to say, well, have you thought of this and thought of that? And that might sound annoying, but it's really important, and we've got a lot from it. And you know, we've been talking about it. It's a two-man show for the most part, and it's really come on a lot if you look at our deck from the start and where it is now. So we really appreciate what you guys do, genuinely. Thank you.
What he said.
Big round of applause for Joan, please. Thank you. So guys, now you can go ahead. So next on the list, and the furthest one they come on the most international team, we have Mila for AI. Firuza, are you here? Thank you so much for coming and for all the work. Would you like to say some words, Firuza? Yes.
Well, first of all, thank you very much for having us here and admitting us to Wildcard program. I think that was a absolutely amazing experience when people are challenging you, asking you a question which you might be trying to put away. It was absolutely great team of mentors from US, from Europe with different opinions, and very great ET health team. So I hope that we will continue cooperation within one way or another. Same.
Well, she said. Thank you so much. So next, we have Gate to Brain from Spain. Marichel, can you join me?
So it has been really a gift, no? An accelerated gift, and I can thank Elena and Claudia that the three of us were in the middle of August starting this adventure. And for me, the best thing is the family we create with the 7 finalists, because we are doing different solutions, but we all believe in that it's pediatric first, so it was really an amazing. Thanks.
Thank you so much. So from Spain to Spain, Ida Meditech. Pilar. Please, coming to the stage. We'll wait. Don't worry, no need to run. As long as you want.
One extra minute to finish my pitch. Thank you very much. So everything has been said for me that I used to be a I was leading an accelerating program. It was amazing to live it from the inside and experience how it truly accelerates a project. It's like amazing. I love that. And the negative part of this is that it's finished. And I need my mentors. I need the program for like a year maybe. So if you could extend it, please, I would appreciate it a lot. Thank you.
That's great to hear. Thank you, Pilar.
You can advertise mentoring network.
Yes. We'll see. So now we are crossing to Belgium, Innocence. I don't see you. There you are. Sorry, the lights doesn't let me see. Last but not least, you will do the talking. Okay, spokesperson.
Yeah, thanks a lot. So it was an amazing journey for us, and I think as a team we matured a lot thanks to the crash course, and that feels that we got a lot stronger and that we already won in that way. So everything else is a surplus for us. Thanks a lot for everyone.
Thank you so much. Sorry for the drag, but it's a little bit longer. So we have another team, Rehabilia Technologies, coming from Italy. Round of applause, please. Hi, Matteo. There you go. Who wants to say a few words? Sorry.
Yeah, okay. Oh, what to say? Thank you. Thank you. It was, I would say, awesome in the sense that we had, a lot to do. The work was not easy, but surely, and it was intense. But we had the possibility of meet virtually very awesome people, many people. Nothing else to say. Thank you. Thank you.
Thank you so much, Matteo. Thank you. And next we have MindGuard. So, yes, I see you in the room. Hello, Pat. Yes, so, Adele, do you want to say something?
I'd just like to, there's a lot of people who have been involved over the last couple of months. I'd like to really thank everybody. I know a lot of work goes on behind the scenes. I'd like to special mention to EIT Ireland UK and the people involved there, particularly Marc and Elaine and Sneha. There have been a lot of really positive experiences out of this. One is meeting yourselves throughout the last couple of weeks, but especially today. We've also got to know the other teams. We're looking forward to a nice evening meal and forging those bonds, and hopefully they'll continue. And also we might frame this, put it beside a picture of John Collins, one of our mentors and leaders, and a special mention also to the other mentors, Mustafa and Alfonso. So big thank you to everybody.
Thank you so much. It's been a very great experience, and the work hasn't gone unnoticed. So before we go on to the big surprise, I would like to bring to the stage Ricard and Daniel. Would you come? So Ricard and Daniel are part of the i4Kids, the K.I.D.S Barcelona Foundation, in which they work a lot to thrive innovation from a patient perspective. And they were actually part of the evaluation panel today. And I would just like to ask you a few words on how you see this experience from their participation in the workshop and how we frame this challenge to seeing the projects now come to fruition. What is your thoughts?
Well, I think it was a pleasure being part of this team because we could show that all these projects had in common that they want to improve problems that are occurring nowadays. So this is nice, no? Trying to improve things, make the medicine better for children. This is fantastic. And well, it was a pleasure to see all these projects and also choosing which one would be the winner.
Yeah, and I think that our own experience says that this is the right direction to go because we have found ourselves with some of the problems that we're trying to solve here now, and seeing projects that try to solve these problems that we faced come to reality. I think that we're like fulfilled to see things like this go to reality and things like this happen.
Thank you so much, guys. And thank you for all your work to get us here. So to the moment that we've all waiting for. So today there was a panel, there were some questions, there was some scores going on. And even though, as I was saying, this has not been a competition, it has been a lot of piece of work, we wanted to acknowledge a little bit merit and performance tonight. So we have a special surprise prepared for two of the teams that we're gonna call on stage, first place and runner-up. So, Maria, if you can come in and tell us the results.
So, we would like to call Gate to Brain and Innocence to the stage. So we want to invite our jury member panels to explain who is the winner and the runner-up and the reasoning why. So welcome to the stage.
Okay, so in the middle. Okay. Okay. So I think, well, first, all are the winners, and it's been quite difficult, okay, to be honest, and we could be there for maybe a couple of hours more, but at the end we have to decide it, and well, we have some process on scoring, and I have to say a hot debate between us, but we finally choose these two projects, okay? I'm gonna explain about why Innocence, and basically there are three main reasons. The first one is the impact that this technology is gonna be able to do on kids, okay? The second one, it's more based on there's a clear and met clinical need, and this technology will be able to find a solution for this need. And the third one is, I think, the capability of scaling up with this to not only to adults later, but as well to engage with pharmaceutical industry on shows on helping them. So they are the winners, and congratulate them, okay? Yeah. And I think another person have to explain more about Gate to Brain, please.
All right. Thank you, everyone. Yeah, just to reiterate that, we had a lot of fun back there. I'd say there was a heated discussion, but thank you so much to all the startup companies that came. You did a great job pitching. There was no real negative feedback. I think the progress that you guys have made over the entire program has been really impressive. And it was awesome to hear kind of how you've evolved from day one till now. So thank you very much. So Gate to Brain. I think, congratulations to you guys. I think, this is not an easy space to innovate in. You guys have been incredibly bold. Some people would turn away or get scared by these type of bold issues, but you guys haven't. So I think the impact, again, to reiterate that was very interesting. I think how thoughtful you guys have been about your strategy in terms of coming from the clinical evidence of why this is a thing and how you de-risk the strategy. We were really impressed with the fact that, no matter how hard our questions were in terms of how the heck are you ever going to accomplish this, you had fantastic answers in terms of not only the clinical, but the technical and biological justification for why you were doing that. And then also, I think, based on some of the experiences of the team, what we've seen as an appetite from the potential licensees of this type of technology. So, we've reviewed and talked to these experts and these strategics, and so I think this is a very timely innovation that they've been hoping for. So between all of those, we thought you guys did an amazing job. Thank you.
Thank you so much, everyone. And I just want to say a little bit, you see this beautiful text here. So come together. So the teams will have a voucher for 1,500 euros to use in mentoring services that you can get through EIT Health. The idea is to continue on the journey and continue supporting. I think Pilar said it somewhere around the room that she wishes that it didn't end so they could keep getting it. So you're the lucky ones that you can still get a little bit of a piece of the EIT Health pressing arm. Really, congratulations. It's been a pleasure to have you with us. And everyone, please reach out to our companies and everything that you've been seeing if there's anything of your interest. they're here. We will be continuing here later afterwards, and I would just like to thank everyone involved, and a big round of applause again for all the teams. Thank you so much.
All right. Congratulations, guys, again, and hope to see you get all the rounds, all the money that you asked for. So we hope that you really will make it, and in 1 year you will graduate to Gold Track or some other program of EIT that will get you to the market. But right now, this is not the very end. We have one more thing at the end right now to really show you that we care about the patients, we care about asking their opinions, we care about what they think. So we have, again, guys from IFR, K.I.D.S, with a short presentation. Or not? You do, all right. And then we're gonna have as well kids from the K.I.D.S Foundation who are gonna present us what they did today in the workshop. Perfect. Come on.
Hello. Okay. Well, good afternoon. It's a pleasure to be here. And well, we'll go fast, but we want to talk about a really good project that we did in our group, the design of the IQ. And to explain this project, we will first to explain what is K.I.D.S Barcelona. And this is also an important part of this project. K.I.D.S Barcelona, it's a group of young children aged from 11 to 20 years old, more or less, that we have a common interest in different topics, scientific topics, such as development of new medicines or drugs, in clinical trials, and also in innovation. So in this group, we are formed in different fields, such as ethics, biomedicine, and the aim of this group is, as we are patient advocates, so our mission is to try to improve all the projects or try to do better medicine for children, so as to make sure that everything that's going to the pediatric population is adapted or has our point of view, and to make sure this, no, that it's adapted for them.
Yeah. Yeah. So what was the objective of this part of our volunteering? The project in this case, the objective in this case, was to move the experience of patients in the ICU to make it more kids affordable, to make the environment more available for kids, and to make it more, the kids were more comfortable in the environment. So the first proposal was to make a domotics room in a kind of sense that we wanted that the room could be controlled and personalized by the kid. And how would we do that? By a mobile app that we would control the lights, to make, for example, a ceiling projector, to be able to control the sound ICU, to lower the volume of the machines, and, for example, to have a voice recognition so that the kid could interact with the room in a sense.
Also, a part of this, we also decided to make we decided that the light was also an important part of the ambient of the room. So we decided, for instance, that we could choose if the light was warmer or was colder, depending on the day. I mean, if it was in the morning, in the afternoon, if it was in the night. Also, having like a cinema mode, sorry, in which you can choose like a more soft light to see films or wherever you want. Also, in general, the idea was to improve the ambient by choosing the different type of light that the patient wants in the room. Also, we decided we said to have a screen in which you can use for watching films. You can personalize to see movies. Also, the idea was to have a projector in the wall, so you can see things much bigger. And well, also would be free, of course. If you are staying in the UCI, it would be fine to have this type of things free. And you can control this by an app in the mobile phone.
And lastly, music and sound, because music and sound at the end of the day for a kid is a part of their life. So what our goal was to take all the machines out of the ICU, that we know it's not possible, but to reduce the impact of those to the kid. Maybe that those machines that could make sound could be controlled by an assistant, that the sound of, for example, the screen, if you played a movie, could be directed towards the kid, and that the kid could be immersed in its life, not the life of the hospital. And maybe that, for example, that he could control music or just put its own movie night or just immerse in its life so that he could go on living and not focus on the hospital.
Also, the last idea, it's called the K.I.D.S kit, and it's like a kit, as the name says, that has some items as a welcoming for the patient. These items would be like socks, moisturizing cream, lip cocoa. So this would make a more comfortable stay in the intensive care unit. And well, also other relevant items that might the patient need. So this way would, in general, with also domotics and, for example, with this kit, we could improve the patient experience in the intensive care unit, and so as to improve also the outcomes on the treatments, no? And well, this was everything we had to say.
Thank you very much.
Thank you, guys. This actually sounds like fun. I would love to have one set like that, cinema set in my home. But yeah. Now we have kids, the other kids, the kids from Poland. So let's see what Yuchi came up with today.
Good evening, everyone. My name is Helena, and today I'm going to show you our prototypes that we were working on it while the whole event was starting. And everything was based on research that was shown before. And my friends and I, we were working about we're working about two topics. And the first topic was the first moments in hospital. So the first group made special hologram with wolf that will explain you what's gonna happen next, and we'll show you the way where you need to go when you go to the hospital, so you don't feel lost and you will know what to do next. So the next prototype is special tablet that have everything about patient data, and you can play some games on it, or it will show you a notification that your special, I forget the word in English, oh my god, I'm so sorry. So you can even talk with friends in your hospital. So you can socialize with other people, with the kids. Okay, so moving to the kids and socializing, my group made prototype of playground room that have like special TV on it that kids can watch some movies or play there, because we have special bookcase that actually is broke, but okay, never mind. It's only prototype, okay? Yeah, so it can be books there or some games, yeah. And even it's special place for kids that having chemo, so they can't be bored when they having that all this procedure, yeah. And that was all prototypes that I showed you. Thank you everyone for this opportunity to standing in front of you all guys. Sorry for my mistakes in English, because you know, I'm Polish, I'm not perfect in that. And I want to say that it will be very helpful to invest money in all that project, because I know that it's very important in kids' life, because it's a big part of my life, all that hospital things, because my sister had surgery a few times, so I know something about it. And thank you guys all.
Perfect. Thank you, guys. It was really perfect. So you see, we actually are inclusive. We care about the patients, about their families, about their siblings. We really, as a doctors, would like, as a community, we would like to be together with you. So there is no possible innovation that will happen without patients, doctors, the personnel, and the whole ecosystem. So that was amazing time with you here in Warsaw. Thanks again for all the sponsors that was here. And of course, thanks for the organizers who made it happen.
I want to ask my team to come here and show themselves. They were working very hard for very early today. Monika, Ola, Maria, Eliza, Ewelina, Krzysiek. Krzysiek, jesteś tu, czy już przy kąpie? So this is the team that was making it happen today from really 6 o'clock in the morning. We were here. Thank you. It wouldn't be possible without you, so thank you very much. And have a good evening. Bye.
So I think that's it, basically. That was the last people that we thanked today. I don't know what else to say. I'm really amazed and happy that we met all here today. 4 years ago, when we were doing one of the first projects of the foundation, scoping for the best hospitals, best examples, we found I4Kids, we found San Juan de Joux, and now today you are guys here with us, telling us how do you do the ecosystem, how do you organize this, and you're actually not only saying, you're actually helping us to build this strong and resilient ecosystem of innovation, pediatric innovation in Europe. So thanks again to all the sponsors, San Juan, all the people there, EIT. Sorry I didn't mention all of them, but that's maybe the last, at the beginning of the speech there is a stress, and maybe at the end as well. Thanks again, guys, for this event.